You're doing a fracture fixation. You want to temporarily reduce the fracture and hold it with the help of a couple of K wires. Similarly, this is your first suture, which is your reduction suture. And by performing this reduction suture, you will now hold the meniscus in place. You can see and observe in the top left corner of your screen that we have two people. I am holding the arthroscope, I am holding the cannula, and then I have an associate to my right who passes the needles, and another associate to my left who retrieves the needles and then ties them off. So it's important you should make vertical mattress sutures, much like what Dr. Anant Joshi did show in his previous talk, wherein he stressed the importance of making good vertical mattress sutures because the fibers of the meniscus are circumferential. So you start off in the center and then you can proceed both anterior and posterior, and the minimum distance for applying these sutures should be at least about 3 millimeters between both of them. So though we still don't have the correct answer as to what should be the exact distance between these two sutures, but about 3 to 4 millimeters is what we require. I first place all the inside out sutures on the top surface of the meniscus. This will enable the meniscus to flip up, and once it flips up, you have the undersurface of the meniscus which is exposed, and now using the same cannula, you can pass sutures on the undersurface of the meniscus, thereby ensuring that you have a good circumferential repair both on the top side and on the bottom side, which allows you to have a good compression of the repair and thereby prevents any form of allows you to have a good meniscus healing. So biology and mechanics both are extremely important, and at the end of your procedure, when you are satisfied with the number of sutures and the type of the repair, all that you need to do then is to go ahead and tie knots on the external surface of the meniscus. So this is how you would perform an inside-out meniscus repair. How do they compare? I mean, Ashish Bedi published almost about a decade ago looking at inside out and all inside repair. Comparable results between both of them. Less amount of breakage of implants, but definitely a higher incidence of nerve irritation if you're not careful with the knots. Again, the Bernard Bach, his center published updated systematic review, and again no differences between the inside out and the all inside with comparable results between failure rates, Lishom scores, outcomes, and complication rate. The Aaron Grich's group from Mayo, they also looked at the outcomes of all inside versus inside out, especially looking at bucket handle medial meniscus tears, and they were also able to demonstrate no difference in the results between the inside out and the all inside. Another meta-analysis which looked at the inside out versus all inside, they actually favored the inside out repair with respect to failure rates, but with the all inside, you had lesser complication rate because of less amount of nerve irritation. So the inside out suture technique is a safe, effective, and reproducible technique. It is cheaper than the all inside. The results and outcomes are comparable, and with the help of zone specific cannulas, you are able to reach further zones of or further areas of the meniscus than what you could reach previously. As the president of the Indian Arthroscopy Society, I would like to make a plea to all of you in Kanpur to please join our association and please attend in large numbers our marquee event, which is the ISCon 2022. We've been waiting for it for quite a while now. We have a variety of academic treats in line for you, including master classes, a lot of awards, which consist of cadaveric sessions not only in India but overseas as well. A lot of live surgical workshops, and we have excellent national and international subspecialty faculty all for you. So please do register today and help us make this event a big success. And thank you so much one more time.
And thank you, Dr. Sachin Tapsavi ji. And now I will ask if you have any doubts and any question to Dr. Sachin.
Sachin sir, this
Yes,
Vinay here. Dr. Sachin,
yes, sir.
so there's a question. Do you
Yes.
do pie crusting in all the cases of attempting meniscal repair?
Yeah, thank you for that question. I think when we want to make meniscus repair easy and reproducible, Dr. Sundarajan will stress upon that how to have good exposure, but you require very good exposure of the meniscus on the medial and on the lateral side. On the medial side, pie crusting of the MCL is a technique that I will practice almost in all cases of doing a medial meniscus repair. It helps me avoid inadvertent damage to the cartilage and allows me to perform a good repair. So yes, I would perform a medial pie crusting on the medial side whenever we are doing a repair on the medial side, almost in 98% of all patients.
Sachin sir, I have a question.
Yes, sir.
On the posterior medial side, when placing the spoon between the capsule, the medial gastrocnemius and inferiorly the semimembranosus is there. Sometimes when passing the inferior sutures, inferior surface sutures, the needle sometimes misses the spoon and comes below that. So there is a paper recently in, I think, in AJSM, which suggested that the spoon should be placed inferior to the semimembranosus rather than superior. So what is your take on that?
So if you look at the incision, and if you look at the incision where you make this meniscus, where you make this particular injury, sorry, where you make this incision, then the incision essentially is about, if this is the joint line, then one third of the incision is proximal to the joint line, two-thirds of the incision is distal to the joint line, and your spoon essentially is more posterior and inferior or distal rather than at the level of the joint line, because as you are coming in with your needles, these needles are going to, the trajectory is going to be more distally directed than proximally or at the same level of the joint line, since your portal is at a higher level and the meniscus is at a lower level. So your point is absolutely correct that the incision should be extending more distal to the joint line, because the sutures will exit from the proximal to the distal area from depending upon the trajectory that you choose.
Next,
Thank you, sir.
Thank you.
will be from Dr. Thank you, Dr. Sachin, and for your very good illustration of it, the technique of inside out. And next lecture will be from Dr.
Thank you, sir.
Dr.
Sorry for the
S.
glitch before.
R.
I'm
Sundararajan.
waiting for the host to allow
This
me
is
to
also
share the
a
screen.
online presentation.
Hello. Still shows the disabled participant screen. Can you make me? Can you allow me to share the screen?
Yes, you are audible,
It shows
sir.
host disabled participant screen sharing. Can you allow me to? Can you make me a co-host? Thank you, sir. Sorry for the glitch before. I'm waiting for the host to allow me to share the screen. It shows host disabled participant screen sharing. Can you allow me to, can you make me a co-host so that I can share the screen?
May I have some questions from the faculty? Please, sir, the question answer session by the time. So we can have questions for Dr. K.D. Tripathi and Dr. Anant Joshi who are here
By that time, may I have some questions from the faculty?
Questions, we utilize the
Please
time.
start the question answer session by the time.
This is the
So
question answer
we
session
can have
for Dr.
questions for
K.D.
Dr.
Tripathi,
K.D. Tripathi and
Joshi,
Dr. Anant
and
Joshi
Dr.
who are
Amit
here
Joshi.
and Dr. Amit Joshi. So if there are some questions, we'll
Please come
utilize
to
the
the
time.
podium. Mic and
So this is the question answer session
Joshi
for
sir,
Dr. K.D. Tripathi,
as
Dr.
super
Anant
technical
Joshi and Dr. Amit
slides are
Joshi.
inside, outside, and the circumference. What the consensus says.
Please come to the
Exact,
mic and
I think basically the all inside.
My question to Joshi sir, as suture techniques has been described all inside, outside, and the circumference, what the consensus says the exact technique.
I think basically the all inside fixation of the meniscus is something which we need to use, especially when you are dealing with the posterior horn tears. And although they are expensive, one has very little option, especially when dealing with the posterior horn of the lateral meniscus. Whereas when it comes to the anterior and the mid third of the meniscus, I think the options of outside in, like Amit has suggested, or inside out, as Sachin has shown, is much more economical from the point of view of the patient. And it is, I think, much more reliable because if you see the perforation made by a all inside device versus the perforation made by a needle in the meniscus, when you are using either the all inside out or the outside in, is much smaller. So I feel that the damage to the meniscus caused by the needle is much less than a fixator. And cost wise, of course, we know that effectively you can put probably tens inside out or outside in for the cost of one all inside fixator.
Is there any protocol, post-operative protocol of differences in the
I don't think
inside outside?
no, because you cannot circumvent the biological healing process whether you use either of the techniques.
Is a 3 week or it is a 6 week immobilization?
I like to go by the extent of the tear. So if it's a large bucket handle tear of the meniscus which I have repaired, then I like to immobilize the patient a little bit longer than a shorter period of immobilization. Because I think as we all know, the biology of healing of the meniscus is very slow, and therefore, although you have used all
This is
kinds,
the
you have
last
done
question.
abrasion, you have
Our
done
online speaker is there,
all kinds of
and then we
things
might
like a clot.
we'll take
I think you
questions from
still
Dr.
have to
K.D.
give time for
Tripathi
the
later
meniscus
on.
to heal.
When to repair the meniscus, the timing of injury is important, I think so. It is a 6 week, after 6 weeks, it is necessary or it should be, Dr. KD.
this is the last question. Our online speaker is there and then we might miss it. We'll take questions for Dr. K.D. Tripathi later on.
Okay, so how to get a successful repair in meniscus?
I request Dr. Sundarajan to continue.
Thank you, sir. Can you see my screen now?
Yes.
Okay, thank you, sir. Okay, so how to get a successful repair in meniscus? I think there's a very important is choosing the right patient for a meniscus repair is very, very important. So the indications for a meniscus repair are the most, one of the most important criteria to get a. Hello?
You are audible, sir. We can hear you. Please proceed with your talk.
Hello?
Can you hear me? Dr. Sundararajan. Hello,
Can you hear me?
Yeah, we can hear you, but
Yes, we can hear you, sir. Please go
I
ahead.
can hear you. Go ahead, sir.
Hello?
Sir, you are audible, sir. We can hear you. Please proceed with your talk.
Hello?
Can you hear me, Dr.
Hello,
Sundarajan?
can you hear
Sir,
me?
you are very audible and clear.
Yeah, we can hear you, but
Your evidence, you are very audible and clear.
Can you hear me?
yes, sir.
Hello?
Sir, you are very audible and clear. Your picture, your image, you are very audible and clear.
Hello? Okay, okay. Okay, thank you, thank you. So to get a successful outcome is to have a proper indications, and the alternative of implants and the instruments are the key to get successful repair. So you should have all the armamentarium before you take up any ACL cases, because many isolated meniscus repair cases are very rare, always an isolated with the cruciate injuries. So you should be ready with any armamentarium of the meniscus repair system is the key to get a successful outcome. Of course, you have to learn all the technique to do the repair, like inside out or outside in or the all inside repair. And also you should know all the knotting which we do it at the shoulder, because that is also very key in many kind of meniscus repairs. At the same time, we should understand that not all tears are symptomatic and require treatment. So with the advancement of MRI, the meniscus tears are becoming easier to identify, but we have to understand that the patients aged around 18 to 39 years, the prevalence of asymptomatic meniscus tear were around 5.6%. Especially in the elderly population, the age between 50 to 90, the prevalence of meniscal tear is 31%. So the most important aspect is that clinical radiological correlation is is the key to get to do any meniscus repair. In cases of acute ones, I think the most often associated with the ligament tears, which cruciates, which already discussed about it. It is important to assess that young patients and the acuity level of these patients are very important to decide about the meniscus repair. Of course, acute and chronic give you a clue, and also the zone of the tear, whether it's a red zone or red white zone, they are amenable to do a repair, and what type of tear. So not a single factor is an absolute indication for a surgery meniscus repair. So you have to calculate all these four factors before you decide and do the meniscus repair. Especially when it comes to the bucket handle tear, especially in a chronic situation, as already shown that the quality of the meniscus is very important. So even the patient comes after 6 months or sometimes 8 months, sometimes the quality of the meniscus is good. If it is in a repairable zones, then it should be repaired. And also the radial tear, you can have an asymptomatic tear, you can have a symptomatic tear. So you have to decide whether it is a degenerative incomplete tear or it is a complete tear. So incomplete tear doesn't require a surgery, but complete radial tear requires surgery. At the same time, when you come to see the root tear, it's a double-edged sword. So you should not think that all the root tears should be repaired, because you see the root tears in all the osteoarthritic patients. So it doesn't mean that they all need a repair. So you have to see the proper indications, like a grade 2 osteo up to grade 2 or maximum grade 3 with a good cartilage with the root tear. Previously asymptomatic patients are amenable to do a root repair. At the same time, in horizontal tear, there are mostly degenerative horizontal tears we can treat conservatively, but sometimes you can have a horizontal tear along with the cyst in a younger patients, or sometimes even with the older patient with a good cartilage condition. Sometimes you may need to do a meniscectomy or also do a repair. I will come with some series of cases which we can have a good indications and when to do a meniscus repair. The most important is that, as already shown by the question answer, and Sachin answered, that the pie crusting is one of the important technique where you take a 16-gauge needle, you can use in the tibial side or the femoral side. You can see the tight posteromedial compartment, carefully watch it, how does it open, by just inserting a needle and breaking the MCL, superficial MCL, opens up the joint space. See, this is one of the key factors. So previously we were afraid of doing that, but now we know that by doing this, you are not damaging the cartilage, and it allows you to do the meniscus repair with ease. When it come to the cases, this is one of the case where the patient presented with the pain and instability of the knee for 7 years. That means he has got an ACL tear for a 7 years duration, but he had a recent fall 4 months before and presented with again pain. If you see carefully these patients, we should not think that these patients have a meniscus tear, but even though the ACL was 7 years old, they can have a fresh meniscal tear. So anybody presents with you with the younger patients with the meniscal tear, even though there is a old history of ACL injury, they can have a fresh MCL tear, sorry, meniscus tear. So it is important that you should preserve this meniscus, and you should be ready to do the repair. So we should not think that because it's 7 years old, we do a meniscectomies, because this is almost in the red zone. So this needs a repair. The technique wise, as already it is shown by Dr. Sachin with how to do an inside out repair, like you can alternate both vertical and horizontal inside out stitches to make it more robust repair. Once you've done the superior surface medical and mattress and vertical stitches, you make another stitches on the inferior surface. So it is very important that you balance the meniscus on both superior and inferior surface, and finally it is complemented with your all inside stitches for the posterior horn, where you are not able to do that inside out stitch. That is very, very important. So the all inside stitch, how does it work? I think most of you know. So these are all commercially available implants. Even though it is costlier, sometimes we may need to use in the junction, at least in the posterior and posteromedial junction, because we cannot use that inside out or outside in technique. So the inside out works by getting the implant, that is the peak implant, goes to the out of the capsule and clipped over there, and by just pulling the knots, it gets tightened up. So this is a very easy and reproducible technique which is available with all the companies, but it may require in a few situations like this. So to get a successful repair, you may need to all those things. You should add a mattress and vertical stitches. You had to go to the both superior and inferior surface of the meniscus. At the same time, you had to include the all inside to get a comprehensive repair to get the stability. So suspect new meniscal injuries even in the old ACL tears, it's very, very important. There is another patient of 29 years old male patient, pain and giving way sensation for a 3 months duration. This patient presented with a sudden popping sound. That is, the X-ray is normal. You can see the double PCL sign. That is that shows that this patient has got a bucket handle tear. So you can see when you see these patients after 3 months or 6 months, you can see that by the time the displaced meniscus, the locked meniscus already is joined with the remnant fibers of your ACL. So you have to release that remnant fibers. We may think that it's a very chronic because it's a dislocated a long time, but it is locked and fused with the remnant fibers. But by doing a pike crusting, you can reduce the meniscus inside. You may think that it's very tough, but we do a pike crusting, you get an enough space over there, then you reduce the meniscus. Once you've done the meniscus, then reassess it. So you can see, considering the age is only 26 years old, it's not a very chronic, but see the quality of the meniscus is still very good. So in these cases, you should try to preserve the meniscus, even though it is a 3 months or a 6 months old. You have to do the repair. So you can see that as already was shown in the previous talk, that you do the inside out 2 or 3 inside out stitches to stabilize it, and we can do a posteromedial incision or the posterolateral safety incision. And if you are careful enough, sometimes you can come with the small incisions like this and do a repair. Of course, it should be complemented with your outside in technique. So any bucket handle repair, you required to learn the technique of outside in technique, because in the anterior horn it is difficult to achieve by inside out. Even though there are now few companies that have come with the curved cannulas for even for anterior horn of the meniscus. So still to learn that outside in technique is very, very important to learn to do any successful bucket handle repair. And And you can see that is the repair still, but the posterior horn still it's open. Here you cannot do an inside out or outside technique. So here you may need to do a one superior and one inferior all inside suture device. So it's very important to stabilize that posterior horn to get the overall stability. So that once that is the complete repair of the meniscus. You can see that we thought it cannot be repaired, but you see that at the end of the procedure, that is a complete repair. You can add a microfracture, you can add a fibrin glue, PRP, and bone marrow aspiration. That may help add a biology for this meniscus to heal very well, especially when they have an isolated meniscal tear. It is very important to add this biology. That is the final outcome of this meniscus repair. You can see that near normal look of that meniscus repair with all these techniques. This is a 37 years old female patient presented with the instability of the right knee, 3 weeks old twisting injury. And you can see the meniscus, lateral meniscus tear in the sagittal view. So this is the common scenario which you see whenever they have an ACL tear. Lateral meniscus tear is the most commonly associated with an ACL tear. When you see this kind of complex tear, you see that's completely separated from your posterior horn. The body is completely separated. What you are seeing in the behind is the popliteus. You may think that we cannot do anything over there, but there are techniques which we can do now. You can do a side-to-side repair. You can see that here the viewing portal is an anteromedial portal. I'm working on an anterolateral portal, take bites on the posterior at the level of the root to take a bite. Then again you shift your scope to the anterolateral portal and work on the anteromedial portal to take a bites on the body of the meniscus. Then you do the side-to-side stitches. It will approximate. The lateral meniscus has got a very high potential for healing. So it is important that you preserve the meniscus to make 2 or 3 side-to-side stitches. It can be complemented with even with the all inside technique also. So you can see this after 2 or 3 stitches, you can trim that inner edge, which is a white zone. So after making a 2 or 3 side-to-side stitches, you trim that inner edge, then make it that remaining meniscus is stable. So it's important that you should know that side stitches, you should have the armamentarium of this kind of instruments and the knotting technique for this. This is a 38 years old female, pain presented with 6 months duration, right knee, slip and fall 6 months before. That is that X-ray. You can see that MRI shows the complex tear. When you see these kind of patients, even though they're young, the cartilage looks very good. They are not arthritic patients, even though 36 years old. So we know that the complex portion of the flap tear is the symptomatic one. So this patient, again the pike crusting helps you to open the joint bit. They remove that meniscus portion which is flipped and locked in the posteromedial junction. Once you've done that partial meniscectomy, it is not get over along with that. Yes, you see there is a big horizontal tear of the whole body, which is extending almost to the body of the meniscus. Here you may end up in extending the excising the flap in the normal situations, but because they are very unstable. But with the help of the new instruments, you will be able to restore that normal anatomy of the meniscus, making a multiple stitches. You can do in both way. You can take it this kind of knee scorpion instruments, take bites from the superior and the inferior surface and making a knot like this. Or you can use an inside out technique which Sachin showed beautifully. You can take it both superior and inferior surface. You can stitch it outside if you don't want the knot inside. So this is how you make the knotting technique for this kind of horizontal tear with the multiple stitches. You can see that there are 3 or 4 stitches which will help you to help that both superior and inferior flaps to come into the place. This can be added with, because the posterior horn was very unstable, it was stabilized with an all inside device, so that helps to stabilize with the posterior capsule for the meniscus more stable along with your multiple stitches. We can see that at the end of the procedure, you can see that it is completely stable, near normal looking meniscus. So here we are done the meniscectomy, at the same time meniscus repair. So it is not the question that whether do a repair or a meniscus. Sometimes you may need to combine both meniscectomy, partial meniscectomy, and also do the meniscus repair. This is the last case. It's a 44 years old male patient, presented with the pain and following twisting of the right knee. This is just a 1 week duration. The same, you can see that meniscus tear, which already showed one more case before. Just I want to show again the complete radial tear, why it is very important to stitch it back. You can see a gap over there. Normally, when you think that the gap, you cannot do a repair. Just making a simple side-to-side stitches, like which I showed in the previous video, that by knotting technique, this can be nicely approximated, and it can get the anatomy back by adding an inside out or all inside suture devices. So you can see the completely stable meniscus. To conclude, you know that meniscus repair has got a lot of techniques, lot of learning curve, but it is worth. Is it very expensive? It was expensive before, but now with the new instruments, with the new cannulas, your indications to do all inside is very few, because in the posterior horn alone, but the remaining space you can manage with the cheap fiber wires with the cannulas. So, but saving the meniscus and knee is most important than this cost. Thank you very much. With this permission of chair, I also as Sachin showed, that I welcome you all to the Coimbatore, where IASCon 2022 happening in September 15 to 16, 17. We have a 16 international faculty. We have an array of life surgeries of 25 plus life surgeries. And we have a master classes specifically for the beginners, and symposiums and panel discussions. Thank you very much.
Thank you, Dr. Sundarajan.
If any questions, I will take up. Thank you very much.
Any questions from the audience?
My humble request to all the delegates, please.
Sir, the master class is for dancing or for arthroscopic surgery?
There's a lot of nuisance from the
Dr. Anant Joshi is asking something.
Sundar,
My humble request to all the delegates,
can you hear us?
do not visit any farmer stall during the session. And I request to all the farmer stall guys, please make silence.
So my humble request to all the delegates, please be seated. Please do not visit any farmer stall during the
Thank you,
session.
Dr. Sundarajan.
There's a lot of nuisance from the behind. Lot of noise is from the behind. It's my humble request to all the delegates, please be seated. Do not visit any farmer stall during the session. And I request to all the farmer stall guys, please make silence. Please. There's a lot of noise from behind.
He will call you later, he says. Now we move on to the next lecture by Dr. Anant Joshi. It is on evolving concept,
Yes,
why and how not to.
Thank you so very much for a wonderful talk. There is a question Dr. Anant Joshi is wanting.
Yes, sir. Yes, sir.
He will call you later, he says. Now we move on to the next lecture by Dr. Anant Joshi. It is on evolving concepts, why and how not to miss meniscal root tear, which is very important.
And one such procedure which has suddenly caught the fancy
Sachin?
is the meniscus root repair. And I'll quickly go through the logic behind
Okay. I will talk to him later.
Every few years, a procedure catches the fancy of orthopedic surgeons. And one such procedure which has suddenly caught the fancy is meniscus root repair. And I'll quickly go through the logic behind repairing the root. So if you go on ViewMedi or on PubMed, you will find a number of articles saying that if you see a root tear, fix it. It is the new silent epidemic of the knee. Some people feel that the root is the root cause of all osteoarthritis. And some people even go to the extent of believing that if you repair the root, you may not require a TKR. So let me give you my take on this root repairs. So this is the PubMed search, and you will realize that the amount of papers on root have suddenly gone up exponentially from 2010 till 2019. So what is this root we are talking about? We all know that both the menisci are firmly anchored to the tibia by the anterior and posterior roots. The anterior roots are very strong, and even during the normal kinematics of the knee, they are not under too much of stress, and therefore we do not see commonly anterior horn root tears. What we commonly see in practice is lesions of the posterior horn of the root, both on the lateral side as well as the medial side. The definition of a root tear is not just an avulsion of the root of the meniscus, but also extended to a radial tear, which is within a centimeter of the root. The incidence of these root tears are believed to be anywhere between 10 to 21% of all meniscal lesions. Now, why this sudden interest in the root? A biomechanical study done on 9 cadavers, out of which 6 cadavers only were appropriate, 3 were gone. The study showed that if there is a root tear, there is loss of hoop stresses. The meniscus starts extruding out, leading to increased loading on the of the articular cartilage and leading to progression of arthritis. And this is one seminal paper which is quoted in all papers as the reason why every root should be treated. The other paper which basically enforced this impression was this paper, which said that if you repair the root, it restores the joint mechanics, and therefore, in effect, it can restore the knee to its normal function. Now, the etiology of posterior horn root repairs is extremely distinct. There is a traumatic episode which can lead to a root tear, and we know that traumatic lesions of the menisci should be addressed. But a more common and debatable or controversial one is the relatively atraumatic root tear that we commonly deal with. So the traumatic version is seen with an ACL deficient knee. It is commonly seen on the lateral meniscus, but you can also see it on the medial side. The relatively atraumatic, which is seen in the 50 plus age group, is more common on the medial side than the lateral side. And this is the one which is the debatable and the controversial one. So very often we had these 50-year-old females commonly coming to us with a sudden pop in the knee while not doing any really exertion, but just walking on the street. And that causes some kind of a catching or locking of the knee. And in years before we even understood about the root, we used to diagnose these as exacerbation of osteoarthritis, treat them with rest and NSAIDs, and most of them used to be better. But now when people come to us with a pop and a click, we immediately go for an MRI to see that there is a root tear of the meniscus. So the diagnosis of this root tear can be on a high degree of clinical suspicion. So if you have a middle-aged lady coming to you with a pop in the knee and the symptoms are very vague, the pain may not be necessarily on the medial side of the knee. Very often it is posterior and posterolateral. So they are not able to pinpoint the area from where the pain is coming. On the MRI, if you have a trained musculoskeletal radiologist, but unfortunately most of them are not even trained in reading the MRI, you will find that there is a ghost sign, which means you don't see the root on the sagittal section. There is a cleft in the meniscus on the coronal section. So as you can see, the meniscus on the lateral side is coming right up to the center, but on the medial side you see a vertical cleft. You also see the cleft in the axial plane, and this shows you the root tear. And on the coronal side, what is very important when you're dealing with a root tear is the degree of extrusion of the meniscus. So as soon as you get a root tear, the meniscus starts being pushed out of the joint, and if the extrusion is more than 3 millimeters, then it is a significant amount of extrusion. You also see some amount of bone contusion which may be associated with root tear. So this is the amount of extrusion. More than 3 millimeters is something which is needs to be looked at. Lateral meniscus root tears are commonly diagnosed during arthroscopic evaluation of an ACL deficient knee. They are frequently missed on the MRI and go unreported. There are various classifications of these root tears depending on the MRI as well as arthroscopy, but the most common classification is based on tear morphology, which tells you that a type 1 is when there is a partial root tear, when the root is in situ and you may not have to really repair it. The commonest one is the type 2, where there is a complete radial tear in the root. The type 3 is a root tear with a bucket handle tear. The type 4 is an oblique tear into the root attachment, and type 5, which is commonly seen in the adolescent population, is a bony avulsion of the root. So indications for repair are always when you are dealing with a traumatic meniscal root tear, which is commonly seen in the young patient who does not have significant osteoarthritis. In degenerative knees, the indications are still evolving. But the definitive contraindications for a root repair are when there is a complete subchondral collapse, if there is severe joint space narrowing, and if the patient has a significant varus, and when you observe that when they are walking, there is a severe lateral thrust of the tibia on the femur. The dilemma in treating the medial meniscus root tear, posterior horn root tear, is that all these patients will have varying degrees of chondral changes. So if the outer bridge classification has grade 3 or 4, then there is a definitive contraindication. There are also associated problems like bone edema. Many of them have insufficiency fractures. So you see almost like a stress fracture in the tibia, and you can see extensive bone edema like a song. Now, some authors have said that this song and the root are related. But for me, the sonk is a completely different entity than the root. When patients have what is called spontaneous osteonecrosis, these patients come to you not with pain in the knee, but they come to you with restlessness. They cannot sleep at night. There is a throbbing pain in the knee, almost as if it is an abscess. And therefore, this is a completely different entity that you are dealing with. I think it is more vascular in origin and it is unrelated to the root. So various repair techniques have now been described for repair of the root. The commonest one is taking a suture in the root, delivering it through the transtibial tunnel, and then tying these sutures over the tibia. The second is for an in situ tear, where the tear has occurred, but the root has not really got displaced. You can use an all inside fixator, and you can also use a instrument from the posteromedial portal and use it using fix it using an anchor. So we prefer the technique where we take sutures in the root and deliver it through the transtibial tunnel. And these are our steps when we repair the root. One is approaching the repair area. Second is checking the tissue quality and the extent of reduction of the root. Drilling the tunnel at the anatomic location using an appropriate jig, suture passage, and retrieval of the sutures. So let me quickly go through these steps. So we have already seen about medial bicrusting, which has been advocated for easier access to the root. And we take a spinal needle and make multiple perforations in the medial collateral ligament or slightly below it, the joint line, and then the joint opens up so that you can approach the root area better. So these are some of the steps in the repair. You try to mobilize the root, make sure that it is mobile, because any repair that you do under tension, it is not going to function. The next step is to decorticate the area where you are going to repair the root. The third thing is to pass a K wire, and you can pass 1 or 2 K wires depending on whether you are going to use a single or a double tunnel. Then pass the sutures and then tie them on the tibia. So these are the steps that we do in the repair. There are various suture passing devices. One such device is the Scorpion, which allows you to pass the suture in the meniscus and retrieve it at the same time. So this is a medial meniscus root tear. You can see that the patient does not have any extensive degeneration on the medial femoral condyle, and therefore this is an ideal case. I like to pass a needle or a Steinmann pin to make sure that I have easy access to the posteromedial area, and my instrumentation is not going to damage the articular cartilage when the instrument is going in. I next pass my jig, which is this is a industry made jig, through the anteromedial portal. We pass a K wire, and this K wire for me was not appropriately placed. So we kept the same K wire in place. We repositioned the jig, and we drilled again with the K wire, which was now at an acceptable location. So you want this K wire to exit out at the so-called anatomic attachment site of the root. Once that has been done, we pass a suture through the meniscal root, retrieve it, tie a cinch knot. A shuttle relay is then passed through the 4.5 cannulated drill, which is over the K wire.
You can have multiple sutures, and it is then tied on
The shuttle is then, the suture is then relayed with the shuttle relay. One must make sure that you do not have any soft tissue entrapment when you are passing these sutures. And you can have 1, 2, or even 3 sutures depending on the quality of the root. You can have multiple sutures, and it is then tied on the tibia over a endo button. If you are doing a root tear with the ACL, you need to be careful so that the tunnels do not collide, or there is no coalition of tunnels. And fixation is usually done at 30 degrees. Now, like I said, if you have a root which is not displaced, like in this case, you have a medial meniscus root which is almost in situ, you can use a device like a fast fix to repair the root.
And the similar steps are repeated. Now we do not need.
So this is the final picture of a repaired root with an all inside fixator. The lateral meniscus roots, which are commonly seen with the ACL, can similarly be repaired. You can use a suture passing device, and the similar steps are repeated. Now we do not need to really use the ethylon and replace it with suture tape, because now there is what is known as a mini suture tape which can be directly passed, and you can avoid 1 or 2 steps of this procedure. So since we have already seen on the medial side, I won't repeat it, so for paucity of time. On the lateral side, you can also use the all inside fixators, similar to what you saw on the medial side. The thing, whenever you're doing meniscus repairs, is to make sure that you have the right angle of approach. And whenever you are going to pass your instruments, you want to make sure that you do not damage the articular cartilage because of your instrumentation. Because whenever you do meniscus repairs or a root repair, the main idea is chondroprotection. So if you destroy the articular cartilage during your procedure, the entire purpose of the procedure is lost. And therefore, you will see in this case, this is the bucket handle tear of the lateral meniscus type 3, according to Laprade, of a root with a bucket. And here we could not approach this area from the regular anteromedial portal. So I shifted my scope to the anteromedial portal, brought in my instruments from the anterolateral portal, so that there was no damage to the articular cartilage, and I had proper access to the area. And here we have repaired the bucket handle of the lateral meniscus, and we have passed 1 more suture in the root. Here you have to be careful. You must have, you should not keep the length of the needle too long, because of the proximity of the neurovascular structures. And this is the second suture for the root of the posterior horn. So this is how the final appearance of a repair of the root. Now, post-op protocol is almost like any other meniscus repair. You don't want knee flexion at least for 3 to 4 weeks. Now, very often you find that you have promised somebody that I'll repair your root, but when you go inside, you find that the quality of the root is not great. So in this case, you find that as soon as you grab the root and you start pulling it, it just comes out. And therefore, you have to be, I always tell my patients that I will look inside your knee, I will check the quality and the mobility of your root, and only when I am satisfied will I go ahead with the root repair, because an MRI cannot tell you the quality of the tissue that we are going to repair. So it is mechanics versus biology. So if your root is completely extruded and degenerated, and if you are trying to bring it back with single stitch or multiple stitches, it's not going to work in the long run. The meniscus is going to continue to extrude. And various studies have shown that despite doing a root repair, meniscus extrusion and progression of arthritis
ऑप्शन
has
दिखेगा
not really
ट्रांसफॉर्म,
stopped
इस पर
after a
कर्सर
root
गया है। उसके
So
बाद
one
यहाँ
must
पर
be
टेक्स्ट
extremely
क्लिक करने के
selective
बाद नीचे की
in
साइड आप
selecting
देखोगे यहाँ
these
पर बैकग्राउंड
patients
कलर
of
का
root
ऑप्शन
repair. It is
आ रहा
not
है,
something
टेक्स्ट
that
लिख
is
दीजिए, मैं
going
यहाँ
to
लिख ऑप्शन आ रहा है,
definitely
टेक्स्ट
prevent
पर क्लिक कर दीजिए, उसके बाद
osteoarthritis.
ओके पर
This
क्लिक
is
कर
a
दीजिए, ओके
62-year-old
पर क्लिक
female
करने के
who
बाद
went
अब
to a
यहाँ पर
surgeon
जो
who did
टेक्स्ट का
an
ऑप्शन आ रहा है,
excellent
यहाँ
root
पर आप
repair.
कोई भी टेक्स्ट
She
लिख
had
दीजिए, मैं
persistent
यहाँ चेक कर ले
symptoms.
रहा हूँ, तो यहाँ
She
पर लिख
was
दिया
then
सिडी साईं
given an
दर्शन
injection
लाइव, ये
of a
टेक्स्ट मैंने
steroid.
यहाँ पर
And finally,
लिख दिया है। उसके बाद नीचे की साइड आप देखोगे यहाँ पर
then she was told to undergo stem cell therapy because her knee pain was not going away when she came to us. And we asked her for x-rays, and she said my x-rays were never done. And this is what her x-ray showed. So she was a candidate for either a high tibial osteotomy or maybe a uni, but she underwent a root repair because the arthroscopic surgeon has just attended a course on root repairs of the meniscus. So our approach is basically to look at the patient, analyze the symptoms of the patient, find out if the root is severely extruded. So the varus with a thrust is something that we are very careful about. If the patient is walking with a varus, that is not important, but if there is a significant lateral thrust, I think the root cannot really prevent from being extruded when patients have a lateral thrust. So our approach is always to first take x-rays, find out the extent of joint space, and also in all cases of a root repair, do a scanogram to find out the extent of the varus and the alignment issues. Because there are quite a few studies from Korea which show that if you have a significant varus and a root tear, if you do a proper high tibial osteotomy, the root repairs by itself. So you can see in this patient before and after HTO, which has been compared. So are we pushing this repair of the root too far? Some surgeons are saying that we should release the capsule.
बैकग्राउंड कलर का ऑप्शन को हम बढ़ा दे पर आ गया ये, और उसके बाद अब आप बटन आ रहा है, स्क्रॉल पर क्लिक कीजिए, उठे इस पर राइट क्लिक कीजिए, उसके बाद फिल्टर्स पर क्लिक कीजिए, इसके बाद नीचे प्लस का बटन आ रहा है, इस पर क्लिक कीजिए और यहाँ एक स्क्रॉल का बटन.
Then you drill a tunnel in the tibia and anchor the meniscus down to the tibia through a tunnel. Now this also is completely illogical because the meniscus is supposed to be a mobile structure. It is supposed to move during flexion and extension.
बटन आ रहा है, स्क्रॉल पर क्लिक कीजिए, ओके कर दीजिए,
down it's definitely not going to work. And some
और उसके बाद अब आपको जो हॉरिजॉन्टल स्पीड यहाँ पर आ रहा है, इसको थोड़ा सा आपको आगे बढ़ाना है जिससे ये टेक्स्ट हमारी स्क्रॉल से, अब आप देख सकते हो जो हमारी
that here is a surgeon who has drawn this algorithm for a patient. He says that if I don't do any surgery and I give you pain medication and brace and an injection, your TKR will be postponed by 5 to 10 years. But if I repair your root, you will be pain-free and your TKR will be postponed by 20 years. So I don't know whether we are surgeons or astrologers. So in summary, I think root repairs work well in selected patients. However, anatomical repair of degenerated tissue should be taken with a pinch of salt, and alignment, I think, should be given top priority when you're treating the medial meniscus posterior on the roof. Thank you very much.
Thank you, Dr. Anant Joshi. We are running late, so the question answers will be taken later on. Now, the organizers have some announcement to make.
4543 GQ.
Sorry. UP 78 GB 5324 UP 78 GB 5324 गाड़ी सर वो दिक्कत हो रही है उधर एंड DQ 4543 जिनकी भी गाड़ी हो प्लीज सिक्योरिटी के वहां से हटा लीजिए 4543 GQ
because in the complex tears and in failed cases.
So with this, we have come to the end of this session on meniscus. So I would just summarize the session. Dr. K.D. Tripathi sir discussed about the meniscectomy, and he told us that meniscectomy, partial meniscectomy is going to stay. We fully agree with that, because in the complex tears and in failed cases of meniscus repair, we will have to do partial meniscectomy. Then Dr. Sachin Tapsavi illustrated on inside out repair technique, which is considered the gold standard meniscal repair technique. Dr. Sundar Rajan spoke about the combination of techniques, including inside out, all inside techniques, and even outside in technique. And Dr. Anant Joshi spoke about his innovative outside in technique for the bucket handle tear of medial meniscus, and it's really a very cost effective technique, and we thank him for this presentation. So we are coming to the end of this session, so I'll call upon Dr. Vishal Agrawal to proceed further.
Sir, before that, I would like to call Dr. Pankaj Tandon sir to felicitate our chairperson, to felicitate Dr. Sanjay Rastogi sir. Dr. Pankaj Tandon sir. Okay, he is not there. So I'll call Dr. V.S. Sharma sir. V.S. Sharma sir, please come on the dais and felicitate Dr. Sanjay Rastogi sir.
I'll call Dr. Santosh Rajpal sir. So please come on the dais and felicitate Dr. Agrawal sir.
I'll call Dr. Santosh Rajpal sir. So please come on the dais and felicitate Dr. Rajiv Agrawal sir.
Thank you, sir. Thank you so much. Now we will start the second session. I'll call Dr. Vishal Agrawal sir to now to start the proceedings of the second session, I call upon the stage as chairperson Dr. G.K. Singh sir. Sir, please chair the session. Dr. A.K. Agrawal sir.
Thank you, sir. Thank you so much. Now we will start the second session. I'll call Dr. Vishal Agrawal sir to start the proceeding.
Now to start the proceedings of the second session, I call upon the stage as chairperson Dr. G.K. Singh sir. Sir, please chair the session. Dr. A.K. Agrawal sir, please chair the session. Dr. Govind Sethi sir.
Now the stage is all yours, sir, for the second session. Please start the proceedings.
Now the stage is all yours, sir, for the second session. Please start the proceedings.
We are again requesting Dr. Anant Joshi to come onto the dais, deliver his lecture on technical pearls, step by step, of ACL. Thank you very much. We are again requesting Dr. Anant Joshi to come onto the dais, deliver his lecture on technical pearls, step by step, of ACL. Slides.
Thank you very much. At the end of the day, I think you're all going to be fed up of listening to me so many times. Can I have my slides on, please?
Ask my fellow to keep on time lapse and capture the procedure of reconstruction.
Slides.
Make sure that the communication time was only 20 minutes. So that is
I've been asked to speak on the technique of ACL reconstruction and how I switch from 120 minutes to 20 minutes. So I just asked my fellow to keep on time lapse and captured the procedure of ACL reconstruction and made sure that the tourniquet time was only 20 minutes. So that is how we change the timing of ACL reconstruction. So this is trick photography and not really in practice. So ACL reconstruction is a fairly well-established procedure. It is done for patients who have unstable knees following an ACL injury. The aim is to provide a strong graft which is anatomically placed, avoiding impingement of the graft during flexion and extension so patients have full range of motion. You want to preserve biology, and Amit will be speaking on how to preserve biology during ACL, and it should be securely fixed. As things have evolved over the past 20 years in ACL reconstruction, we have shifted from isometric placement to anatomic placement of the ACL, which means that we are trying to recreate the footprint of the native ACL during surgery. To create this anatomic placement, we had to change our technique of ACL reconstruction. So we shifted from drilling the femoral tunnel transtibially, and we shifted drilling to the transportal technique. So that gave us freedom to select the femoral footprint during the surgical procedure. When we started going into the transportal technique, we realized that the femoral tunnel was very short, and therefore to adjust to this, there was a technological change or instrumentation change, and we had to shift from the fixed loop to the adjustable loop. So these were some of the changes that we have seen in the ACL surgery. Besides this, we also found that as surgeons, in order to be accurate during surgery, we were removing a lot of soft tissue from the intercondylar notch because of some of the ridges that were described for anatomic placement of the graft. But we soon realized that we were destroying biology to a great extent by burning out tissues in the intercondylar notch, and therefore today we rely more on soft tissue landmarks during our surgical procedures, both on the tibial side and the femoral side, so that we are biologically on the right side of biology when we are doing an ACL reconstruction. Some surgeons have shifted from the bone patellar tendon bone to the hamstrings for their own reasons, and I was one of them. I started doing bone patellar tendon bone in 1989, and in 1996 I shifted to the hamstrings. And the reason for that was that Juhi Chawla had come to me with an ACL which was done elsewhere, and when I saw the scar on the knee, I said, what would have happened if she would have come to me? I would have given her a big scar in front of the knee and would have destroyed her acting career. So that is the time I decided that I should shift to the hamstrings. So I shifted to the hamstrings in 1996, but the patellar tendon continues to be in my armamentarium. A new graft which we have started using recently is the central quad tendon. So this we are using extensively now, particularly in females who are hyperlax who have absolutely no remnant of the ACL, and we feel that they need a robust graft for stability. So we have shifted that to the central quad tendon in these patients and in all revision cases where you have a failed hamstring or a failed bone, patellar tendon bone. So if you want to keep your surgery very simple, straightforward and reproducible, I think these are the steps that you need to follow. Follow the KISS principle. Start with a diagnostic round of the knee. Go to graft harvesting after your diagnostic round. Graft preparation, femoral tunnel drilling, tibial tunnel drilling, graft passage and fixation. So every surgery that I do seems to be very boring when people come to observe surgery because I am following the same steps each and every time. Now, I've seen surgeons miss this step of diagnostic round because they say clinically I know that the ACL is gone and MRI tells me that the ACL is gone. So what is the need for a diagnostic scopy and why not harvest the graft straight away? So the logic behind doing this diagnostic round is that it tells you whether any additional grafts may be required. For example, if the patient has a posterolateral opening and you need the gracilis for that graft, for doing the Larson's procedure on that side, then you know that you need to have adequate graft for your ACL. The second reason is you also know what is the type of remnant of the ACL. Is the ACL completely shattered, or am I going to preserve a great deal of the native ACL? So that is why this is extremely important. So first the diagnostic round and next probing to find out what all are the additional injuries along with the ACL. So if the ACL, as in this case, is completely shattered and you have to remove the entire ACL, then you know that you need a robust graft like maybe the CQT, or you need a quadruple semity, maybe the gracilis in addition to that, or maybe you need a bone patellar tendon bone. But if you find that the ACL is only avulsed from, say, the femoral side, which we see in a large percentage of patients, where we are able to preserve a majority of the stump, then you know that you just need probably the semitendinosis and you can probably double it, triple it, or maybe quadruple it. So then your approach to the problem becomes simpler. If you find at this stage that the notch is extremely narrowed in patients who have neglected ACL, then you may do a notchplasty, but it is not really required in all patients. Routinely, I harvest only the semitendinosis and quadruple it because I find that I get adequate length and diameter of the semity. Only in about 5% of the patients do I harvest both the semity and the gracilis because we know that the hamstrings are antagonistic to the ACL. So the minimum donor site morbidity that one can cause, the better it is for the patient. So we harvest the semity and then we quadruple it. If we find that the remnant is adequate, then we also do not hesitate to triple the semitendinosis graft. And this is the technique by which you can triple the semitendinosis. So you don't tie knots at either end. And this is the way you can then triple it, pass it over your loop, which you are going to use for fixation, and then securely tie it to the loop, and you can use this as a triple graft. So you can triple, quadruple, double the semity as and when required according to the graft, remnant preservation that you are going to do.
Even I was guilty of this. I used to say that we should augment it with polyester tape. But recently we found that almost 5 patients in our
Now,
large
one
series
thing
of
which has again caught the fancy of surgeons is augmentation of the hamstring graft. So if you find that the graft is not adequate, even I was guilty of this. I used to say that we should augment it with polyester tape. But recently we found that almost 5 patients in our large series of almost maybe 200 where we have used the polyester tape, we found that they had developed extensive reaction to the tape, and this was not immediate after surgery. This sometimes has happened even 2 years following use of this tape. We have found that there is reaction both on the tibial and the femoral sides, and this is one such example which we operated, where you find that the entire button and the tape had to be removed. So one must use this with extreme caution whenever you try, because there are some people who are now saying that if I use the fiber tape, you can jump on the knee on day one, or you can go back to sports within 3 months. But I think there are some side effects of which we should be aware of, and we should be careful whenever we are using any kind of foreign material inside the joint. I think these polyester tapes are excellent for extra articular augmentation procedures, but should be used with great care during intraoperative procedures.
When you use the central cord tendon. Why did we change after so many years?
So the CQT is now our preferred choice, and we tried both the minimally invasive central cord tendon as well as the open central cord tendon, and we find that this is much easier and gives you a more reliable graft when you do use the central cord tendon. Why did we change after so many years, when central cord tendon has been talked about for all these years? It took quite a while for us to change to the central cord, because initially we were hesitant as to the kind of fixation of the quadriceps tendon on the femoral side. But now we have what is known as a fiber tag, which ensures that the fixation on the femoral side is very strong, and the suture material, because we know that the quad tendon is a lamellated tendon. So if you pass regular sutures through this, there is a possibility that it might cut out. And with this fiber tag, it ensures that you have a good grip on the tendon, and that is why we shifted to the quad tendon. Notchplasty should ideally be done after you have harvested the graft, because then you know what is the space that you require in the notch, and it should be done with great care, and you do not want to encroach on the articular cartilage on the lateral side. Now coming to tunneling, maximum number of mistakes are made on the femoral side, as we all know, and you can drill the femoral tunnel either using a rigid transportal jig, which we routinely do when we are doing adolescent knees, because you don't want to go too far laterally and damage the epiphysis. But in our practice now, we use the flexible reamers. So the flexible reamer allows you to go right up to the back of the knee inferiorly without really damaging any native or remnant ACL. We use the fibers of the remnant ACL as soft tissue landmarks for the femoral tunnel, and that is how we use the flexible reamers. So it prevents flexion of the knee, which is often required when you are doing the femoral tunnel drilling. When you hyperflex the knee during femoral tunnel drilling, the fat pad comes in your way and it obstructs your vision. Whereas with the flexible reamers, you don't have to hyperflex the knee. The tibial tunnel has not received due attention, but you can see that you can make mistakes even on the tibial side. Here the tibial tunnel is too far anterior, and you can land up with impingement. The tunnel can be too far posterior, and you may end up with a vertical graft, or it may be too far medial. As you can see here, the femoral tibial tunnel is on the articular cartilage, and so the patient had constant pain during surgery. Amit, I think, will be speaking more on biological augmentation, so I will not touch on this. On the tibial tunnel, I always like to do serial dilatation of the tibial tunnel, because the subchondral bone in this area, especially in athletes, can be very strong or robust. And if you suddenly drill this with a 10 millimeter cannulated drill or a 9 millimeter drill, you may shatter the articular cartilage. So we like to initially start off with a 6 or a 7 millimeter cannulated drill and progressively increase the diameter of the tunnel. If you do not position your K wire correctly in the first time, like here, I felt that the tibial tunnel was too far anterior. I kept the K wire in place. If you remove that K wire, it probably keeps on going in the same track. So keep the K wire in place and then drill your second tunnel and wire with the K wire so that you do not end up doing in the same tunnel. The endo button should be flipped under vision most of the time so that you are sure that it has flipped on the lateral cortex. So this is one of the tips. And when you pass the graft, make sure that it is a smooth passage of the graft. So usually if I have to do an isolated ACL reconstruction because of the team that I have around me and the instrumentation that we have, it is truly a 20-minute procedure. So it is not something which is not practically possible, but you need to have the whole team, the proper equipment around you. After passage of the graft, we have seen that some of the bone debris may be pushed inside the joint during graft passage. And this needs to be looked at, otherwise the patient can land up with a cyclops lesion and block to extension. So this is biological internal bracing. I will not touch on this because Amit's topic is basically this. So basically we take from what ABC of meniscus repair to ABCD of ACL reconstruction. So anatomy, that is footprint reconstruction, stump preservation, robust graft with a secure fixation, and address all the associated deficiencies like a ramp or a posterolateral or a lateral corner injury when you are doing an ACL reconstruction for optimal outcome of a ACL surgery. Thank you very much.
Thank you, Dr. Joshi, for a nice talk. The next, may I call upon Dr. Anant Joshi? Technical pulse, reminiscence of the preservation of ACL.
Thank you very much, sir. So let us talk about something which is upcoming concept on biology of ACL reconstruction. So I have nothing to disclose. If you see that common understanding of an orthopedic surgeon to replace a tissue, same kind of tissue. Thank you very much, sir. So let us talk about something which is upcoming concept on biology of ACL reconstruction. So I have nothing to disclose. If you see that common understanding of an orthopedic surgeon, to replace a tissue, same kind of tissue are the best. So if you are replacing the nerve, probably nerve is the best one. And if you are replacing the bone, you have to have a bone. But when we talk about ACL reconstruction, this is the ligament which has been replaced by tendon. Say it is a BPTB or hamstring or even quadriceps. If you understand why, this is because of the unavailability of the ACL. ACL is not available, ligament is not available. That is why we are replacing the ligament with the tendon. But what we are doing, as sir also said, that from a isometric, we have come to an anatomic ACL reconstruction. So in attempt to recreate the anatomy, we have completely replaced the biological ligament with the tendon. And we all know that all this tendon which has been put inside has to undergo a process of ligamentization, which will take about 12 to 18 months. So the concept is, if we cannot replace, then why not to preserve some of these remnants? And the preservation can be in the form of remnant preservation, or the remaining part of the ligament can be preserved, or the extreme of preservation is the ACL repair, which is coming up very heavily. So there are various advantages of all this remnant. Number one is it is a ligament, it is not a tendon. So it will preserve all the property of the ligament. And as sir showed, the vascularity that comes from the remnant is tremendous. If you see this remnant and some of the picture, these all have vascular channel which will enhance the ligamentization of the process.
The remnant also provides some stability because it has Golgi and the Pacinian's corpuscle in its footprint. So that will provide certain feedback mechanism and will act as a protective mechanism for the reconstructed ACL. The remnant will have preserved its bundle anatomy. Various cellular components are there, various mesenchymal cells are there, remained in the ligament, which will, seed into the ACL graft and it will enhance the healing. In Nepal's perspective, you'll see that in Nepal, we recently published a paper which says that probably most common cause of ACL reconstruction in our country is road traffic accident. And in road traffic accident, the pattern of injury is completely different. Most of the time, these are around 60% road traffic accident will have a proximal avulsion of the ACL. So how to deal with remnants? It's a burning topic recently. There are several classification of the remnant. The Sherman classification is the most commonly talked about classification. But this disadvantage of Sherman classification is this does not give us a guideline how to treat with the or how to deal with the remnant. Gregory Defelis classification, who is a very advocator of ACL repair, this is his detailed classification. Probably this classification is good enough because it provides, it covers the MRI reporting as well as the arthroscopic picture and then gives certain indications for repair. But if you understand our context, that the MRI classification of the level of injury where the ACL has torn, it's in the proximal 1/3, 90%. It's very difficult to use this classification in our practice. So we have come up, we have worked out and submitted this paper for publication. This is our own classification and simple modification of the classification in which we divide them into the proximal, which is type 1, then mid substance, which is type 2, and the distal one is type 3. Both proximal and distal can have a bony avulsion. So if it is a bony avulsion, it is type 1A, and if it is soft tissue avulsion, it is type 1. Bony avulsion is 1B and soft tissue is A. So based upon that classification, we have suggested certain treatment, and then this is about 170 cases prospective study, which is going to be published very soon, hopefully. So based upon this classification, we have given 4 treatment modalities. One is proper ACL reconstruction. If it is a chronic remnant, probably remnant preservation or even a footprint preservation. Some part of the footprint has to be preserved. If there is an acute condition, soft tissue injury, the remnant strengthening and the biological augmentation. And finally, if it is a bony avulsion, either it is from the femoral side or from the tibial side, we have to do repair. So some of these examples, this is example of footprint preservation. This is a chronic empty sign, and you can see the vascularity on the remnants. That is what we are trying to preserve, thinking that it will enhance our ligament. So all the remnant footprint has been preserved and the ACL has been reconstructed. You can see that down the footprint has been preserved. So there is no need of removing all the footprint. As Sir said, we don't need to look at the bony anatomy to place our tunnel. We have to look into the soft tissue anatomy to place our tunnel. This is another case in which we have done a remnant preservation. So if your remnant is attached to some structures, either into the femoral condyle or into the PCL, you can let it attach, let it be attached and put your ACL graft. That becomes your remnant preservation. So here you can see that the remnant has been preserved and new ACL has been reconstructed by the arthroscopic technique. So remnant has been preserved. The third one is the remnant tensioning. So this technique is applied when you have a remnant acute tear and your remnant is not attached to anyone but it is floating. So this was a 24-year-old female presented to us about 2 weeks after injury, and this is in arthroscopy view. You can see that her remnant is not attached to anyone. So what we do is we take bites on the stump of the remnant and shuttle that and put fiber tape. Then we make a proper anatomic femoral tunnel of the ACL, harvest the graft, prepare the graft, make femoral tunnel and the tibial tunnel. So this is the bite taken, and then the suture are shuttled through the same tunnel, same femoral tunnel. Now the graft is passed inside and the suture in the remnant is pulled, and then you can pass your interference screw to fix both the remnant and the graft with the same suture. You can see the vascularity on the remnant which has been preserved and your ACL which has been augmented biologically. This technique has recently been published in 2021 October in Arthroscopy technique. Finally, ACL repair, which I said that this is extreme of remnant preservation. This was a 40-year-old gentleman. 40-year-old gentleman with ACL tear presented to us after 2 weeks of injury. His knee was silent, and if you see this remnant, look at the vascularity of the remnant, and the peculiarity of this one, it had some bone spicule on its edge. So it was a bony avulsion from the femoral attachment. In these cases, we do repair. So you pass few sutures through the remnant, come out from the edge of the remnant, do a biological enhancement by doing a microfracture, crimson duvet into the condyle, and then do a all-inside fixation using various all-inside anchors, which is used in shoulder arthroscopy. So this is what all the sutures has been passed and it has been fixed into the femoral condyle. So if I do a repair, my rehab is little slower compared to the remnant preservation. So this is ACL has been repaired, which is probably, when we talk about the preservation, this is the highest grade of preservation in which all the remnants or all the ACL has been preserved. So to conclude my short presentation, I'd like to say that ACL graft has to undergo a process of ligamentization. So for this ligamentization, we need a good biological support. And nowadays, if you remove the technical issues, the most commonest cause of ACL failure is lack of biology provided to the ACL graft. And the remnant, they put biology to our construct, as I have shown, lots of soft tissue. And then if you go to literature, you will find out that various mesenchymal cells that is present in the remnant, they traverses all the way into the graft and they enhance the biology. There are mixed results coming out of the both repair and preservation. There is no clear-cut winner on the clinical outcome aspect, but there are a lot of research is going on. And the improvement in arthroscopy technique and instrumentation in near future will improve the outcome of remnant preservation and the repair. Thank you very much.
Thank you, Dr. Amit Joshi, for such a wonderful talk. And can I now invite speaker who is online giving the talk, Dr. Sundar Rajan. He will be talking on technical pearls, reinvesting lost art of ACLR using PTB.
Thank you.
Dr. Sundar Rajan, sir, are you there?
Yeah, I'm here, sir. Thank you, sir. I request organizer to make me co-host to share my screen. Yeah, I could see that. Thank you.
Thank you. Please proceed.
We thought that PTB graft was a gold standard. Again, from the next decade, just a minute. Thank you very much. So my topic on the PTB graft for ACL reconstruction. PTB graft is an emerging graft, and there is a fight is always happening. So from 2003 to 2009, when we started arthroscopy, we thought that PTB graft was the gold standard. Again, from the next decade, that is from 2010, then hamstring graft became gold standard. From 2018 onwards, again the PTB graft is an emerging graft, and there is a fight is always happening between the hamstring and PTB graft. So the major concern in ACL reconstruction in a common people and also as a surgeon, we are worried about the residual laxity. We are worried about the re-tear of ACL reconstruction. And also patients are worried that when they can go back to sports as early as possible. Of course, is there any possibility of osteoarthritis by doing these reconstructions? When you take the graft healing in the tunnels in PPD graft, we know that PPD graft has the advantage of rigid fixation in the bone tunnel. Bone block healing in the tunnel resembles the fracture healing. And also incorporation has been reported as early as 16 weeks post-operatively. So when you compare the PPD graft versus hamstring graft, the tear resistance is better in hamstring grafts. However, the forces encountered in ACL reconstruction are well within tolerance of PPD graft, even with the accelerated rehabilitation. So a PPT bone flex can provide rigid fixation and quicker graft osteointegration. It also gives you the strong initial resistance, early mobilization because of the rigid fixation, normal bone tendon junction resistance, and generally recommended for high demand young patients. The major concern is the donor site morbidity. Even though the anterior knee pain has been reported around 17 to 40% in the literature, how to avoid, that is the most important question. Even though we cannot completely avoid, you can make some technical makeovers to reduce that anterior knee pain. The other important complication which was mentioned about the patellar fracture, that is very, very rare because if you are not using the proper instrumentation, then the chances of patellar fracture is there. But otherwise, the patellar tendon ruptures and patellar fractures are very, very rare in patellar tendon harvest. The 5 degrees of extension deficit, which was reported in the literature, if you do a proper rehabilitation, again, there is no change. The osteoarthritis has not been proved. Is there any difference between the PPT graft or any other grafts? When I come to the other concerns in the ACL reconstruction, what we are talking about the residual laxity. By using the PTP graft results in more stable knee and negative lag and pivot shift compared to the hamstring graft. So PPT graft scores over in cases of residual laxity. This is a paper of long-term outcome in ACL in a systemic review patients, PTP versus autograft. This was published in 2017, where patients with hamstring graft had twice the risk of revision compared to the patients with the PTP graft. So in relation to the graft retear and revision, PTP scores better than hamstring graft. The same things in another paper, even though this paper has shown that there is no significant difference between these two groups, still PTP has got return to sports in 87% and patient satisfaction higher after ACL reconstruction and active athletes. So the use of PTP graft increases the likelihood of returning to play, whereas pre-injury participation in soccer and lacrosse decreases the clot odds. When I compare to the technique, I will go to some video about the PTP graft. Is it possible to do an anatomical ACL reconstruction? Is another concern among the surgeons when they are using the hamstring graft. Absolutely, it is possible. We don't need to use just a transtable technique. You can use the medial portal technique. You can make an anatomical reconstruction by making the technical adjustment. By making the graft bit smaller, don't use the 2 to 2.5 graft inside the femoral side. Make sure that you are taking 1.5 to 2 centimeter graft in the patellar side that will go into the femoral side. So I will show it in the technical video next slide. And also it's important that you should have a proper armamentarium. You cannot just use the only osteotomes to harvest PTP graft. You require a proper saw so that you don't damage the patella. So you don't do the patellar tendon rupture, you don't do the patellar tendon fractures by using just osteotome and hammering, especially in osteoporotic patients. It's very important that you should have a proper armamentarium of instruments. When I come to the technique, they make sure that if you don't make the midline incision, you can make a curvilinear incision so that patients will not get that anterior knee pain which you are talking about, the scar pain. So you can go slightly away from the medial side, and there is no need to make a 10 centimeter incision. You require a just 4 centimeter incision for your PTP harvest. And make sure that after incising, you can take usually I take the central third of the patellar tendon graft. Then he incise the patellar tendon fascia slowly, then spread that fascia on the either side with the help of the scissor, and you ask your assistants on the both sides to retract the patellar tendon sheath on the medial and the lateral side. So that will expose and show you the medial and lateral border of entire patellar tendon, so that you can choose the central slip of the patellar tendon, which normally we require 8 or 9 or 10 mm depending upon the patient's BMI. So you can take the 9 mm graft from the center of the tape. You can use the scale like this and mark it so that you can make the exact measurement of the graft which you wanted. So that is the mark which was made for the 9 mm graft. Once you have done that marking, then you make that vertical incision starting from proximal to distal. Once you incise that both the sides, ask your assistant to retract the remaining patellar tendon on the either side So that will give you more exposure. Then take out the retractor on the lower ones. Just immobilize the skin. You can see the skin is very highly mobile. So you don't need to make an extra incision. Then you extend the incision from the patellar tendon to the tibial side around 2.5 to 3 centimeters. You don't require more than that. So that is the incision which you require for your tibial harvest. Then use the T-sharp or the 10 mm width of the small blades for your harvesting of the tibial side. Using it to angle around 60 degrees to 45 degrees of angle. Don't make too vertical to take a big graft. Use around 45 degrees of angle or 60 degrees of angle on the either side. Ask your assistants to hold that pommels in the slightly sleeping mode so that you can use that saw very easily on either side like that. After making the medial and the lateral cut, then you make the distal cut, just changing the side of your saw. So that is the distal cut which you require. And again, it's a saw. As you can see the angle of the saw, it's around 45 degrees, so that you don't go the entire depth of the blade. Then you use the osteotome on entire side, either side. Gently tap it on both the sides, so that will take away the remaining attachment of your pistol graft. Just you can lever it after making a general taping on the both the sides. You start from the distal to proximal like this, and you can use the same 10 mm osteotome on the distal side, then use it, deliver it. Once you deliver the graft on the tibial side, you can remove the remaining attachment by using a scissor. Hold it with the towel holding forceps. Releases the remaining attachment from the fat pad. So keep the tongue of the bone which above the attachment of your patellar tendon, so that will give you the more length of the bone for the entire tibial tunnel. So once you are done that release, then you do the knee extension. So that will help you for the skin to mobile proximally. So you don't need to make any extra incision for your patellar harvest. You can see the space, how much space left between the patella and the skin incision. Once you do the extension, then take that proximal retractors, you retract the skin, that will expose your patella. So again, you can see here, we don't make any extra incisions, just moving this retractor just over the skin, that will allow you to go up to 2 centimeters in the patellar side. Once you are done that, use again 10 mm knife, extend the incision which you had made it for your graft on the patellar side, both the medial and the lateral side. Go up to the bone and mark in the patellar side around 1.5 to 2 centimeter. Don't go more than that, because it will be difficult to negotiate in the femoral tunnel, especially when you are doing through the medial portal technique. So usually I take from between 1.5 to 2 centimeter. So that is the incision you mark it for your patellar side harvest on the both the sides. Once you are done that, then you can use the same saw which was used for the tibial side harvest. Ask your assistant to support the knee. Keep it around 30 to 40 degrees of flexion, so that your saw doesn't touch your retractor. Again, you see that angle around, we are using around 45 to 60 degrees of angle, so that you don't go too deep, and your entire depth of the saw no need to go into the patellar side. That possibility of the patellar bone fracture can happen. So go up to only 9 mm or 8 mm, depends upon the graft, because you want 8 to 9 mm of graft whole circumferentially. So once you made it medial and lateral, then you make the proximal cut. Again, you use the same 45 to 60 degrees. Make sure that your assistant is holding it in a proper flexion around 30 to 40 degrees. So that will facilitate for your proximal cut. So you make that proximal cut around 8 to 9 mm. You can see that by the entire blade is not going inside. Just I'm angling the blade around 45 degrees to 50 degrees. So that helps you to make the distal cut. Once you've done that medial, lateral and proximal cut, then I make the deep osteotome, because you don't want the osteotome, use the osteotome again. You clear the fat pad. Now turn the saw on the upside down. You can see that again I had come to the foot and its foot and side. I'm using the saw to make a deep cut so that I don't need to hammer that remaining patellar tendon. So around 8 to 9 mm down the tendon, you just make the another deep cut. So that will facilitate for your easy harvesting of the patellar side. Once you have done that, again you use the osteotope. Again you see that I don't hammer at all in the patellar side. Just using it, lever it, and your patellar tendon graft is has come out completely. You can see that length of the both the sides grafts. Then you trim it according to the size. Usually comes around 8-9 mm. You make a two holes on the both proximally and distally for you use your fiber wires to negotiate. One hole is not sufficient because it will flip inside the tunnel. Make sure that you make at least two tunnels making with 1.8 mm K wires. So that will facilitate for your threads to go inside. You can see this is how you put the threads inside, then you negotiate inside and go and do the remaining fixation. So your PTP graft is very indicated in young patients involved with the contact sports. In patients with the generalized ligament laxity can be used, or ACL tear with the grade 3 MCL where you are worried about the hamstring and the medial side and the posterior side weaknesses. Again, PTP graft is the ideal choice. Of course, in the revision situations where you use the primary hamstring graft in the correctly positioned tunnels can be used as a single stage revision ACL reconstruction if the tunnel diameter is not too wide. Thank you very much.
Thank you so much, and again, thank you for having.
Thank you, Dr. Sundarajan, sir. Please go ahead. And next talk is from Dr. Sachin Tapsavi, Evolving Concept ACL Femoral Avulsion Repair. When and how I do it. Dr. Sachin Tapsavi from Pune.
Yeah. Thank you so much, and again, thank you for having me over here and allowing me to come and speak about some of the concepts about ACL repair. So I'll be presenting today on ACL repair. Why should we be doing it, and when should we be doing it? So essentially, we're going to be speaking about the science of the ACL repair. So almost about 70% of your ACL injuries will be non-contact, and if you have an additional neuromuscular deficit, you will get a primary as well as a secondary type of an ACL injury. So the amount of interest that has been there in non-contact ACL injuries is quite significant. And if you look at all these papers that have been published, which show that definitely there is a higher incidence of these non-contact ACL injuries that occur. The interest in ACL repair has grown definitely, and this has been because of understanding of more concepts which allow us or enable us to understand which are the correct people for which an ACL repair may be looked into. So essentially, you had a lot of ACL repairs that were being done maybe about 50 years ago, but they were for the wrong indications. And over the last decade or two, we have a recurrence of interest in these type of ACL repair surgeries. A lot of interest has been into the basic science of healing of the ACL. The ACL is definitely a richly vascularly supplied organ, and late Professor Freddie Fu, to whom we owe a lot of our understanding of the ACL, spoke a lot upon how the ACL was a living structure and the ACL had to be preserved throughout its lifespan. So essentially, whenever you have a tear of the ACL, the same extrapolation to that of the MCL cannot be done. So Martha Murray about 10 years ago won the Kappa Delta award for this specific research pattern of hers. They looked at healing patterns both in the ACL and the MCL. And in the ACL, you do not have healing in all the four phases because essentially you cannot have a blood clot that forms. As against the MCL, wherein once the blood clot forms, you have collagen production, which then leads to a healing response. Again, if you have an enhanced histologic repair in a central wound with a collagen plasma, collagen PRP scaffold, you can extrapolate and find that you do get healing. So what we have here on top are the various staining patterns, right from fibronectin and all the growth factors, and looking at the three extrapolations of the patellar ligament, the ACL intraarticular and the ACL with the collagen PRP scaffold, one can observe that you can get some form of healing response which is pretty similar to that of the extraarticular structure. It also allows us to improve neovascularization and increase the amount of type 3 collagen. So essentially there are three different techniques by which you can repair the ACL. You have the direct suture repair, or you have what is called as the dynamic intraligamentary stabilization technique, or you have the bear technique. So, as Dr. Anant Joshi did mention, all the proximal tears are amenable to doing a ACL repair, as are the tears which are present on the distalmost aspect. So, type 1 and type 2 ACL tears are probably the ones that we should be using, and these tear patterns should be picked up both preoperatively and intraoperatively before you go ahead and start your ACL surgery. So type 1 and type 2 are the ones that you want to pick up. So how do we do this? And we wrote about it almost about 4 years ago. Essentially, once you choose the correct type of tear, you want to use some form of suture passage device, and then you want to create a small hole on the femoral side using a knotless anchor, and then reattach your torn ACL back to exactly where it should be. These may at that time be supplemented with some form of a protective internal brace, and this is probably one of the very few indications where I would recommend that an internal brace may be used. The same technique is used on the tibial side as well. And again, we wrote about the same almost about 6 years ago and published our technique, in which you use a technique which is similar to what you will use when you repair an ACL avulsion. So in these techniques, essentially what you want to do is to debride the stump of your torn ligament. Once you debride the stump, you want to make sure that it sits properly. And once you're confident that it is going to sit properly and it can heal, then you go ahead and pass sutures within your stump of the ACL, and then you have either pull-out sutures or you can use a direct knotless fixation. The fixation modality needs to be secure. It is not essential that you need to use either of these two. The type of the fixation will not greatly change the outcome, but essentially you have to use your suture passing techniques, which will then allow you to get a good firm repair. It's always important to have good visibility, and very frequently in these type of surgeries, you will need more than one portal, which may be required for you to get a good firm repair. So here we are passing sutures in a crisscross fashion. This one is for the tibial side, the previous one was for the femoral side. And once you have these sutures that are passed, you will then retrieve them through the portals, make tunnels in the tibia, and then go ahead and repair the same. Standard instruments which are available from the as well as the shoulder kit are very extremely useful here. And a bit of practice of doing indirect and direct knot passing techniques can be extremely useful to achieve and gain confidence in going one step ahead. So in this particular instance now, we are now filling and dilating the tunnels in the tibia, both on the medial as well as on the lateral side. We are looking at it through a central transpatellar tendon view, and in order to gain good mobility and in order to have a good suture passage, you may use a cannula at times or ensure that there is no formation of a soft tissue bridge, and thereby achieve a good stable repair. So this is pulling down the sutures. one after the other. And this is at the end of your surgical procedure, where you are now able to achieve a good crisscross configuration of your ACL fixation, and you have restored the tension in your ACL. So this is in short how you do the technique. The other technique is the bear technique, which is now still in the phase of trials. And in this, a mid-substance tear can be repaired using a scaffold, which is infused with the patient's own platelet-rich plasma. And this scaffold is used as an intermediate bridge between the torn ends of the ACL, which are then approximated to each other, and a suture is used to try and get a good firm repair. These results are still in their final stages. We now have the 5-year results of the bear technique, and definitely they still have shown that there are no failures with this particular technique, and they are quite confident that this probably will be the treatment of the future. So this still not is in vogue completely, and we still need more data on the same. The dynamic interligamentory stabilization consists of using of two special implants, which are tensioned on both sides, on the femur and on the tibia. And to be very honest, I have absolutely no experience of using this particular technique, which is more popular in Germany as of now. If you look at updated systematic review of all the literature that we have, a total of 28 studies which were randomized to sutures and the DIS technique. And however, you can see that the re-rupture rate for all tear types is somewhere around 25 to 30%. But when you look at the proximal tears only about 12% of them will have a re-rupture, which again is closely approximating to the ACL re-rupture rates that we have in our clinical practice. I looked at my own data. I have about 42 patients who have had an ACL repair till date. The mean age was 21. 36 males and 6 females, and I have a mean follow-up of 29 months. If I look at the various tear patterns that we see of the MRI scan, the patients that I normally would always select are the type 1 tears, and they approximately constitute about 16% of my clinical practice. So results, I've had re-ruptures in 3 of my 42 patients. 2 of them were following playing soccer, and 1 was a road traffic accident, which was unrelated to the index surgery that had been performed, and all 3 of them were revised to the VTP ACL reconstruction. The results also showed that the IKDC scores improved from 57 to 88 at the time of the last follow-up, and the Tegner activity index rose from 4.9 to 7.2. The range of motion with the ACL repair, I find that though the ACL reconstructions may have a faster return to range for the first 1 month, at the end of 3 months, I found that both my patient groups were doing exactly the same. And when you add an internal brace, probably it becomes a lot more easier to mobilize them earlier with a lot more of confidence. Looking at the MR evidence of healing in my subgroup of patients, because MR scans were done for 28 of the 42 patients, 18 months following the repair. 19 of those 28 showed full healing of the femoral footprint. About 6 out of 28 showed more than 50 but less than 75%, and 3 out of those 28 had an ACL rupture, which was a group 3, and that is what it is. So she's one of my own classmates. She's about 52 years old, and this is 4 months following an ACL repair on her knee. She's one of the outliers whom I would choose, and she's trying to get back to return to sport, which can be done a lot more earlier in these patients. We recently wrote up a narrative on the same as well, whether we can use it for athletes. Yes, you can. You can use it, especially if you are looking at younger patients who understand what the whole surgical procedure involves, and these should have type 1 tears which present early. It is useful because it can preserve native tissue, and the results are comparable when you compare them with the other techniques of ACL reconstruction in that same type 1 tear. You can use internal brace or augmentation to definitely improve and increase your rehabilitation and allow them to mobilize further. So thank you so much for allowing me to present virtually, and hope to meet all of you in person very soon. Thank you.
Thank you very much. It's been an excellent talk. I think it's a growing trend for people trying to preserve ACL along with reconstruction. I think that's the way to look forward. Well, I'm here just to introduce Dr. Ashish Kumar, somebody who I didn't know much for the face-to-face. Recently being seeing him, before that in the COVID, been a number of times being with him on a virtual platform. Welcome, Dr. Ashish. So a bit of a lot of things I've seen with him growing up. He's been a professor of KGMU, been trained in Australia, France, and Germany, established arthroscopist, has published a number of papers, and he's been a UP Orthocon president. The other thing which you're not aware of is his passion for animals, mainly dogs, and his gardening. If you've got a free time, you can talk about him later. Welcome, Dr. Ashish. Go ahead, please.
So what we are going to talk about the revision ACL.
Hello. So, thanks for the nice introduction, respected chairpersons, dear friends. So, I'm thankful to my previous speakers who have talked a lot about the different techniques of ACL reconstruction. So, I need not to repeat all those things. So, what we are going to talk about the revision ACL. So, if you are doing so many primaries, then revisions are likely to take place. So, if you talk about the technique remains the same. You have to recreate the ACL like you have done for the primary. The same thing you are going to do for the failed ACL, but in a little bit of different manner. So I will be just talking about what you have to be careful while doing it. So 75 to 90% success rate varies when you do a primary ACL. So it's likely to re-rupture, or you have a failed ACL despite without rupture, there is stretching of the graft, or there can be a wrong technique that has been done in the very initial phase. As you undergo for stresses, then it is likely to fail. So in such case, how you are going to proceed, this is the important. What is a failed ACL? For all practical purposes, it is the recurrent instability. So if somebody is having still a Leishman sign positive, or a anterior draw test positive, then it is a failed ACL. Or he is not satisfied. There are a lot of patient variation. Somebody might be happy with that laxity, somebody may not be. We are very thankful to our patients who are not a sports person most of the times. So they live with it, and with that minimal laxity, or they are happily doing their job unless there is a pivoting. So if the pivoting comes again, then they come for you for the revision ACL or something you have to do for that. So pain is the other thing which may be there, maybe pre-existing arthritis, or because of your deeds you have developed the arthritis, and the stiffness and the loss of range of movement despite of physiotherapy. This is an important thing where you can have orthofibrosis, or that has led to a poor tunnel placement where isometry has not been respected, and you can have this kind of problems. Infection is something which is very different, so that has got a very different place to talk about. So you have to evaluate the cause of failure. This is the major crux, what has happened, and you are not going to repeat that, and you have to correct that. This is the basic talk that we are going to have here for 8-9 minutes now. So recurrent instability because of the graft failure, that will fail if you have done it technically wrong. So structural or functional, if it's a failure, it's a failure. Overlooked comorbidities is very important. You find out ACL reconstruction is very easy, I will do that. Whereas
I will not repair it, I will just dissect it or something like that. So that's the thing, you have to be careful. If there is a meniscal injury, please.
Recording in progress.
When post-op complications like infection, arthrofibrosis, arthritis, these are the other reasons why people come to you. So this is something when you see in uroscopy and the graft is re-ruptured, this is a very common thing. People have a second fall and they re-rupture their graft. This is what happens most of the time. Or there was a technical problem or some graft related problem that it is intact, still non-functional, has become lax. Early failures that occur within 6 months are because of the technical errors. Again, it's a major problem that has been emphasized again and again where to place your tunnels. This is the one and only thing that covers 80% of the things. Unrecognized PLC and cell injuries, malalignment of the lower extremity, so that you have to go for varus alignment as the major culprit, go for orthogram, but we are not doing all the time. We just jump over to reconstruct it. Biological failure of the graft and perforation, compromise, that's one of the fixation point. This is the other thing. So we have to be careful. If it happens after 1 year, we call it late. It is most common source is non-contact trauma, injury. Premature return to the competitive sports. Again, we have seen after 4 months somebody playing badminton. What should I say? Is it okay or not? Or like internal bracing. Somebody is saying it will lead to synovitis after 2 years and you have to revive it and take out everything and you have to go for something. Or somebody is proposing it that you must do internal bracing and then you can send them to early sports, back to sports. So it's always controversial. I am using since long so many cases with internal brace and fortunately things are okay. God knows what will happen. Suboptimal reconstruction. A thin graft. You say it is 6.5 and it's okay. You have not augmented it. You have not raised it. You said okay. For some time it is okay. But later on as you put the patient to the stresses or he thought that I should play badminton now because I have diabetes. So in such case it can fail. So these are so many things that lead to failures. Improper tunnel placement is the most important thing while doing the technique. So a femoral tunnel which is too anterior will lead to excessive graft tension during flexion. Too posterior, excessive graft tension while the knee is full extension. Or it's a vertical tunnel as we used to do in our transitional technique. That was the problem where there was no rotational support and patients come to you for rotational problems. They don't come to you for the anterior posterior laxity that we must understand and we must regard the strangulation of the femoral tunnel. Tibial tunnel, if it is too anterior, impinges the notch. We always check on the table when we do a primary ACL how full extension we can achieve or not. This is something. If it is too posterior, it impinges on the PCL and prevents the full flexion. Medial or lateral misdisplacement will lead to ultimately your graft failure, or during the technique you can injure the condyle and the condyle injuries you will do. So it's very, very important that you take regard to the tibial tunnels or the femoral tunnels. Improper graft tensioning. Again, if you tension it too much, that too in flexion, forget that you will get full extension. Because exact isometry has been followed or not, that's very important. But still, if you do the final tensioning and little bit, just not more than 10 degrees of flexion, then you will always remain happy. Otherwise, your patient is always unhappy. And please do understand that you cannot have a full extension, you cannot stand comfortably. So please take care of these things. And of course, we are putting a lot of pressure to the condyle things that will lead to arthritis later on. Inadequate tensioning, you ensure that there will be laxity. So if there is laxity, patient is never satisfied, and again, it is all what work is going to do after that. Fixation device failure, a proper thing. Your endometrium is lying over the soft tissue. Later on, will develop laxity. So better take an image picture before you leave the theatre and stay comfortable. Post-bone osteopenia, you put your interference to one side above, two sides above. So it is something you are taking care of osteopenia. So if such thing happens, do your fixation, but always do a secondary fixation. There is no harm in doing it and ensuring that your ACL will remain comfortable. Increase interference through tunnel divergence angle. There is something if you do in the femur side. Most of us are using suspensory, so it's not a big trouble to us. Inadequate socket length, of course, the healing space, like people say nothing less than 25. What the foreign people say, nothing less than femoral tunnel 25. But we are going nothing less than 15. So it's a discrepancy of 1 centimeter. So, but everything depends. It's a very, you are using a variable loop, things are very comfortable. If you are using a fixed loop, then of course then you are putting a more vertical tunnel to gain length. So these are the things you have to decide what you are planning to do. But of course there should be a good enough space where sharpish fibers can lead to a healing of your soft tissue graft. Missed ligament injury that we have already talked about. You have to be proper examination and take care of the other things also. Don't think I will do ACL and it will take care of the MCL as well. There are so many people who do ACL thinking that MCL will be taken care of with this. I will tighten the graft. Okay, on table you may have that kind of feeling, but later on it is bound to fail. Posterior horn of medial meniscus we have already talked. So you have to take the history how it happened, because you have to decide what has gone wrong, then only you can make it correct. Take a proper examination, see the gait, do the stability test, range of movement, you have to assess the operatively, because accordingly you have to act, compare from the other limb. Investigations apart from MRI and X-ray, we all do it. Go for the CT scan to see the tunnel widening and the tunnel positioning, how it is mal-positioned. Single stage or two stage is a big question. So, if the tunnels are ideal and usable, you can go for a single stage. Slightly misplaced but usable. Still you can a little bit of compromise and you can go ahead. Slightly misplaced and unusable. This is the situation where it's difficult to do. You cannot, because tunnels will pulsate and it will be a big tunnel. How to go for it? And a completely misplaced BFE. You can still do it. If you are completely misplaced, you have enough space like this, see from the middle portal, and then you can go ahead with your facial reconstruction. So single stage revision, expanded but completely malpositioned tunnels may allow for independent tunnels, you can build new ones. Expanded but partially malpositioned, okay, you can go ahead, but it's a trouble because then tunnels may pulsate. Choice of graft. We are always going for alternative autograft, which is available to us. We don't have allograft. So you have to go for the other limb for same hamstrings, or you are going for the ETB. Advantage, you are having a bone plug with you to compensate on both the sides. You can have a bigger bone plug, or you can use the quadriceps tendon with a superior patella bone plug that can be utilized. Or of course, peroneus longus is now a graft which is a strong and thick graft you can have, so that's another option. Allograft you don't have, but if it can do, at least has been described much in the literature. So coming to the surgical tips. The proper medial portal placement, from where you can see how the footprint of the femur side is there, so that you can decide, I will put my tunnel which is maybe here and there. So what is the level and how can I proceed? And of course access for drilling, so you can go far medial side for doing this kind of now new tunnel placement. Medial metal repair to be done, assessment of previous tunnel, debridement, loose hardware to be removed, of course, but if it is a fixed and lying out of your way, you can leave it as such. Don't create hollow tunnels by just removing it as an edge. So they are giving support to your new tunnel. Bar double screws, you can just drill through them. Suspensory hardware, you just don't touch them. They are difficult to take out also. And revision or classy may be required so that you can go as much posterior as you can for the femur side. Ensure it. Use available anatomical references, what is available, like butterfly ridge or dent ridge, you can see that. Or transport, or you can use the jigs also on the safer side. Transpatellar tendon portal may be helpful to view directly inside, and you have both the portals available to work for. Use flexible reamers, they are very helpful. Outside in or flip cutter drilling is another option, so that you can put your tunnel very differently from what has been created by the medial portal drilling. So use the flip cutter and you are outside, it will change your pathway. Over-the-top non-anatomic salvage techniques you must know, and there may be the possibilities if you want to revise it. More integrity well canal is an acceptable option. So a little bit of being anterior is not a big thing, but don't be superficial. Your metaphyseal grip is important to the graft. Maybe inside there is a hole, but if you have a good purchase in your metaphysis, your graft is going to stay there. Graft fixation, you just use whatever is available, you must be ready with that. Because you don't know what will be required at that time. Suspensory, or you can use the post, you can use the washer. So that will be required. So just be ready with that. If the good bone is stopped, just comfortably you can do something. If bone stock is compromised, in such case you have to look for the suspensory devices for the post. Two-stage reconstruction, partially overlapping tunnels are the most problematic that we are talking about. With significant widening, again you have to graft them and then proceed. Relatively anatomic tibial tunnels with expansion will be effectively managed filling with a large graft in a single stage setting. But these are the ways you can use bone plugs, more comfortable for us. Bone chips, auto allograft, and confirm the CT scan within 6 months after and go for the drilling. Extra articular reconstruction which are going to support your things. If there is just rotational problem, you can think about doing this LET for intact graft that fails to correct rotation. So it's a different topic and different technique, but that can help you to correct your rotation. Rehab, just a single word, go slow. Don't be more enthusiastic, you have failed once, don't do it again. So everything will depend how good you are able to do, how was the bone, how were the tunnels, how was the grip, then you decide accordingly. Of course, you have done the internal tracing or with other augmentations, they will help you in a little bit of early rehab, there is no doubt it. So at the end, be prepared for different situations, determine cause of failure, investigate accordingly, make preparations extensive. Right from removal of the hardware to doing what will be required, you should have coding people, everything, different type of screwdrivers, just cleaning devices, dental hooks, something like that. You must have. Remove whatever necessary. For that you need that armamentarium. Select your graft, BTB, cordyceps, colonius or the standard ones. All kinds of fixation devices, dual fixations at times to support your poor primary fixation. Tunnels, good metaphyseal contact, divergence, limited compromises, be prepared for everything. And of course, slow rehabilitation. So at the end, I have to say, evaluate the situation, evaluate yourself, what you are going to deal with, and your training and your confidence. Seek opinions, don't be hesitant. Thank you.
Thanks, Dr. She's been a good talk. I think we should also go ahead with the next speaker.
Yeah, we'll take question answer after summarizing this session. So I would request all the speakers of this session to please come on the dais for the Q&A session. All the speakers of this session, please come on the dais. I'll just, by the time the speakers are coming to the dais, I will summarize this session. Dr. Anant Joshi, the big orthopedic surgeon, as he said, the big surgeons talk more simple things. He said, be anatomical, make anatomical footprints. The transtrivial ports have been shifted to the transportal things now. Fixed is shifted to the adjustable loop, and diagnostic round is essential before taking the graft. And please be careful if you are using fiber tape because everything comes in package. So it has advantage of the strength, but it has got certain disadvantages as well. So please be careful. He also focused on stump preservation. By the time the speakers are here, I would request the delegates, if any question, please come on the mic. Dr. Anant Joshi.
So it has advantage of strength, but it has got certain disadvantages as well. So please be careful. He also focused on stump preservation. By the time the speakers are here, I would request the delegates, if any question, please come on the mic. Dr. Amit Joshi, he told about the preservation of the remnants. He put a lot of stress
that you please preserve the soft tissue, and whatever remnants are there, you please take care of that, those remnants. Dr. Sundar Rajan, probably many athletes and professional players are going to him. He told about BPTB and said that it is the most strong fixation and bring back the people to the back to the professional sports life. So it should be used in younger people. Dr. Sachin Tapasvi, he gave the concept of what are the innovation, biological repair techniques, beer technique he told about, and how can you preserve without replacement, can you do the repair work also. Dr. Ashish Kumar very intelligently threw the light on those things which we often miss, and where are the, you can miss the train and where can be difficulties and the fixation can fail. So very rightly he put the light on those things which we often miss. I would invite if any question from the, yes, Dr. Nirbhay, please, faculty is there on this session of ACL.
My question is to Dr. Amit sir. Sir, in stump preservation, what should be the actual length of the stump which should be kept?
Please speak loudly.
What should be the actual size of the stump to avoid overstuffing and to get the exact entry and exit points for the ACL?
Observation and your skill that will determine what.
So size of the stump doesn't determine. You see what is the size of the stump remained, and according to that you adjust your graft. So if you have a big size stump, probably a 7 mm graft will suffice. And if your stump size is smaller, then you increase your size of the graft. It is just a observational and your skill that will determine what is the size. But at the end of the surgery, if you are doing a remnant preservation, it is very, very essential to hyperextend the knee and see that it is not overstuffing. If you are overstuffing, then you have to do a little bit of debridement or of the notch. So increase the size of the notch so that overstuffing is not.
Just one more point. Actually, the stump is not actually acting like ACL. It has loose end at one or the other end. So if we use a graft of 7 mm, actually we are putting a graft of 7 mm. It does not actually of the size of say more than 8 mm or 9 mm because the remnant is loose on one side. So what I think is that we should preserve only the root part and we should take our ACL tunnel through that root so that we get the proprioception rather than having and believing in that weak stump.
You are right in the sense that if your remnant is loose, it is not attached. If you saw my video, if the remnant is loose and not attached, it has to be tightened. It has to be pulled out and tightened. Then only it will act as a ACL. Either it is attached to the PCL or it is attached to the femoral condyle. If you read one study by Samuels, what they have done is they have cut the remnant which is attached to the femoral condyle and which is attached to the femur, and then they have checked the translation. So if you cut the remnant which is attached to the femoral PCL and the femoral condyle, there is increased anterior translation. So they say that even the remnants which is attached to the femur, femoral condyle or the PCL have some stability properties. That is why you can preserve them and make your ACL graft. Put your ACL graft. If it is not attached to anywhere, then you have to reattach this to the femoral condyle by some methods. There are various methods so that they act as a ACL. And you are absolutely right. If you are not able to do any of these, probably you have to remove the remnant and make a footprint preservation of the same thing.
Delegates, Dr. Sachin Tapsavi is also joined as a speaker for this Q&A session. You can ask question to him as well.
So my question is for all the panelists. So there is no ambiguity about fixation on the femoral side. On the tibial side, either there is direct fixation or a aperture fixation, or there is a cortical fixation or dual fixation, like Ashish does dual fixation. So what is the take on either dual fixation on tibial side, aperture versus cortical fixation?
I have never done dual fixation. I have done either distant fixation or aperture fixation as per the requirement, but I have never combined the two.
So how do you decide about which fixation, like aperture or cortical?
So in majority of my patients, I always do distant fixation. So endo button on one side, a suture disc on the tibial side, whenever I am using the hamstrings. If the quad tendon is used, I use the endo button on the femoral side and usually an interference screw on the tibial side because the quad tendon is quite long. And when it comes to fixation with screws, I have always used titanium screws and have not gone for the biodegradable ones. So if the graft is coming to the tibial aperture, then I'll use the aperture fixation, like a screw. But if it is not, then I use a suture disc.
So for me, it is the feel while I drill through the bone. If it's a bad one, just goes like the reamer goes like this, then I have to be safe. It's mandatory that I will tie downwards also. So that initial days when it is taking care of incorporation, at the same time I put the screw so that will take care of all those ill effects that have been explained for the graft movement and the tunnel widening. That will take care of that, and it's a second security, because in a government setup you never know how patients is going to behave. You say use the brace, they don't use it. So these are the two reasons why I do dual fixation.
Dr. Sachin, your view, please.
Yeah, thank you. So I've always used an aperture fixation. I don't do a suspensory fixation on the tibia because the tibial fixation has been rightly pointed out to be the weakest link, and of all the fixation modalities on the tibia, a suspensory type of fixation is the weakest fixation, where your ACL may sort of, that could be one point of the ACL failing. I like to use an aperture type of fixation depending upon the quality of bone. I would prefer a titanium or a biodegradable screw. And the way to use the screw or way to select the screw is to use your screwdriver, push it up in the tibial tunnel by the side of the graft. If it goes in very difficultly, with a lot of difficulty, then the same size screw. If it goes in with some resistance, then one size up. If it goes in very easily, then two or even three sizes up.
I always use interference fixation in the tibial side. Only in some instances when you feel that that squeaking sound that has to come while passing your interference screw doesn't come, then in very few cases, very rarely, I use another additional fixation. But most of the time it is aperture fixation.
My question to all the panelists that, particularly Dr. Anant Joshi, that initially you used bone patella bone, then you shifted to the semi-T hamstring, and apart from the size of this incision, you have a massive follow-up of both the groups. What is the difference in the short term and long term in the both the tendons, PPTB and semi-T?
I think the greatest advantage of shifting to the hamstrings was stump preservation, which I think was not possible with the bone patellar tendon bone. And so I think we started appreciating the role of biology in the healing of the ACL graft. As far as strength was concerned, I am sure that the bone patellar tendon bone was far superior to the hamstrings. The problem is that you can have a length, tunnel length and a graft length mismatch in a bone patellar tendon bone graft, where you will have a bone plug which is projecting into on the intra-articularly, and that can lead to a block to extension. So the complication rates of patellar tendon were definitely higher, like restricted range of motion, anterior knee pain, as compared to the hamstrings. The hamstrings is a relatively complication-free graft, and the results I think are not as the bone patellar tendon bone was definitely superior, but the complications were higher.
What is your opinion about the cinder quads and the peroneal tendons?
I have no experience with the peroneals because I don't think I have to touch the foot of someone when there are enough grafts around the knee.
Dr. Anant Joshi?
In Nepal, females are very short stature. Their hamstrings are extremely small. Over last 2 years, for females, peroneus longus is the choice of graft for ACL reconstruction in my practice.
Sir, how do you compare between the two peroneus longus versus quadriceps in Nepal?
I'm comfortable, it's just like a bigger hamstring, I'm comfortable.
Compare in the sense, you see the fixation device. The fixation device, if you take CQT, probably most of the time, as sir showed, there are endo button devices for fixation of the femoral side. But if I take CQT, it's both side interference screw. But if it is peroneus, I'm comfortable. It's just like a bigger hamstring. I'm comfortable with the suspensory fixation.
No, my question was, if you take the graft from peroneus or quadriceps above the patella, so how do you compare both the process, like what graft is better and
Some studies coming up for the peroneus
as Dr. Joshi showed in one presentation, you can take the quadriceps above the patella so that your incision mark is also not hindering and you get good size also of the graft.
Absolutely. At this moment, if you see the literature, there are a lot of literature pouring in favor of quadriceps tendon. But there are, some studies coming up for the peroneus as well. So as far as the strength of any ligament is concerned, it directly proportional to the diameter you get. So even in quadriceps, you get 10 mm diameter, and even in the peroneus longus, you take 10 mm diameter, the strength remains the same.
Question to
Okay.
Dr. Sachin
You have to
Tapsavi.
say something on this?
Sir, there was.
I think these are the peroneus for me are important tendons which play a role in stabilization of the foot. And I don't think unless we have long-term studies to show whether it has deleterious effects on the arches, maintenance of the arches or the weakness, I would hesitate to touch it.
You would go for quadriceps.
Yeah.
Dr. Sachin, question to Dr. Sachin. There was a lot of debate in the last decade about double bundle versus single bundle. What do you see the future of the double bundle? Whether it is going to stay or we are shifting towards the single bundle?
So I think, So I think about the double bundle, I am aware of only a few centers in Japan who practice it now. Besides that, I don't think anybody else is doing double bundles anymore now, because the outcomes of properly done anatomic single bundle are comparable and better to a double bundle. Also, with a double bundle, if it fails, then you have a bigger problem for doing revisions, which is why I think in those patients or those indications where rotatory instability was considered a problem to correct with a single bundle, we now have the extra-articular penodesis technique, which is either by the modified Ellison, the modified Lemaire, or by the ALL type of reconstruction, which is extremely useful and takes care of that problem.
The last question to all the panel is that what is the real indication of notchplasty? Whether we can decide pre-operatively or on the table, notchplasty?
For me, it's an intraoperative decision. Most often it is required in chronically neglected ACL deficient knees where the notch has become stenotic. In these situations, you do a conservative notchplasty enough for you to see the posterior margin of the femoral notch, and then depending on the graft size, then you would either keep it at that or you would want to increase the size depending on the size of the graft. But I think the requirement for a notchplasty has reduced substantially since we shifted from the bone patella tendon bone to the hamstrings. In earlier days, I think notchplasty was done as a routine part of all ACL reconstructive procedures. But today it is very, very selectively done.
My question to all the panelists. So this is regarding the position of the anteromedial and posterolateral bundle. For a single bundle anatomic reconstruction, where exactly do you make the pilot hole to start with? Whether right at the bifurcate ridge or slightly towards the AM side, What is the current consensus? Where do we make the pilot hole?
On the femoral side, where we should start?
On the femur side. On the femoral side, considering the bundle positions, AM and PL, and position of the bifurcate ridge, where exactly do we start the pilot hole, the starting guide?
Personally, I have never used the bifurcate ridge as a reference point when I have been doing my ACLs. I always look at the native footprint of the native ACL and I use that footprint. That footprint basically, I look at it in relation with the posterior horn of the lateral meniscus. So if you read a couple of articles, they say that the distance from the posterior horn of the lateral meniscus and the posterior margin of the intercondylar notch. So I want the femoral tunnel to be as low and as posterior as possible when I am drilling it. And I really don't look at the eminences. So if you want to look at the eminences, you will have to remove all the soft tissue in the intercondylar notch and then look at that.
So you try to, the footprint on the femoral side is big. So you try to be in the center of that
center
of the footprint. Ashish sir.
The most important thing, you must peep from the medial portal for that reason. Then only you can see the footprint and its center. Don't just try to peep in from the lateral portal and just thinking that you are seeing the exact footprint and the center. That's the one thing. So I just try to, from the medial portal, you can find the center. And of course, you have to remain posterior and inferior. This is the basic crux. And I never hesitate in using my jig, and it's very comfortable. If you use a jig, at least you are not going to make any major mistake. So this is what I do, and I must go posteriorly. I have to clean everything till my jig sits into it. So most of the times I'm happy with that, and there's no problem with that.
So you have to leave that sleeve of few millimeter posteriorly of the bone. How much is that sleeve?
It's a big knee, then 7 millimeter. It's a smaller, or your graft size also decides how much you can use it. So accordingly, 7 millimeter or 6 millimeter, these are the standard thing that you have to do. If it's smaller, then you have to use your brain for that.
Anant Joshi sir.
Most of the time, right at the center of the footprint, that is visible. You see, if you understand the history of how the tunnel position on the femoral side had changed. Earlier in transportal, it was right up. Then people started saying that it has to be right just above the cartilage and posterior. Now they are saying that probably somewhere between the superior and the inferior at the middle. But the good indicator or good indicator of where your tunnel should be is the footprint. Try to find out the footprint, do a little bit of debridement and find out the footprint right at the center of the footprint.
Some studies have suggested that staying little bit on the anteromedial side reduces the tension on the graft, because that is more of an isometric position for the ACL. So, Sachin sir, what is your take on that?
I'm sorry, on what? Take on the footprint position.
Little bit towards the AM bundle side.
So you have to be, I would prefer to be more deep and at the site, as Dr. Joshi has mentioned. So I would not go to the center of the footprint, because doing a center to center has demonstrated a slightly higher failure rate, especially in athletes, not so many in non-athletes. So more towards the AM, so go more deep rather than shallow is the preferred location. Also in terms of high and low, previously we were more low and now we are slightly higher towards the residence ridge or the lateral intercondylar ridge, where we can gain access to the direct insertion fibers of the ACL. So on the ridge and more deep.
So more towards, little bit towards the AM bundle side.
Correct, absolutely correct.
Dr. Vinay.
Joshi sir, you highlighted that posterior horn, posterior root tear of middle meniscus is somehow over-treated. So we don't need to. Sometimes we do a repair, but that centralization doesn't happen. On extension, the meniscus still extrudes out. So what do you do about it? So you just leave it like this or do a centralization stitch or something like that?
When I select the patient for a root repair, I basically want to select patients with minimal extrusion. Those who are already extruded, I don't believe that the root repair is ever going to bring the meniscus back into place, because I think by that time the coronary ligaments and the capsule, which are also holding the meniscus in position, are already stretched out. So hoping that my couple of stitches in the root are going to correct the plastic deformation of my capsule is too much of expectation from my repairs. Although I don't believe in people who say that you can tether the root by drilling a tunnel in the tibia, which is now being extensively propagated. And I have seen disastrous results of that, where we have seen that the articular cartilage on the tibia has been extensively eroded just to fix the root to the midpoint of its body by passing multiple sutures. And we have seen destruction of articular cartilage not only on the tibial side but also on the femoral side because the high tensile suture material. So I think the meniscus no doubt is important, but I think at a point when the articular cartilage is completely destroyed, the root is not going to restore the articular cartilage.
So any time limit for that? That after this much time, I will not think about the route, something like that.
My question to all the panelists,
Sawal pucha.
No,
Timeline.
I think I don't have a timeline. I want to basically take into account all factors that are associated with the degeneration of the knee. I want to look at the state of the articular cartilage, the alignment, and whether the patient is able to tolerate the extensive immobilization and the non-weight bearing that is involved after a root repair. Because very often we have patients with bilateral significant varus deformity, and very often you have repaired the root on one side and they start complaining of complaints on the other side, which was normal. So you need to consider that these patients have to be on crutches for 4 to 6 weeks. And if they have a virus, you are going to treat one side and create problem on the other side. So I think all these things have to be factored in when you are thinking of a root repair. People are going overboard trying to repair the roots.
So, would you mind, because we have another session, Meet the Master, we can have more questions in that session. We are running a little late. So, please excuse, I will take your all questions just after 10 minutes maybe. Thank you so much. And thank you all the panelists for being here for the quick Q&A answer question session. I would request Dr. Anant Joshi, please stay back, because Dr. Anant Joshi has to go early. So I have requested Dr. Vinay Pandey, thank you very much for shifting your talk later, and we are taking talk of Dr. Anant Joshi before your talk. And Dr. Anant Joshi, he will be taking talk on current concepts, medial side knee injuries, my treatment algorithm. This is wonderful subject, because those who are not doing arthroscopic surgery, it may interest them. So please be very attentive. Thank you, and please welcome Dr. Anant Joshi.
As I mentioned earlier in my talk, I think at Sportsman we work as a team. So I do only the simple stuff. And the complex stuff is done by my colleagues. So if you have any complex questions, then maybe we ask them on the phone line. I'll have to, like Amitabh Bachchan, I'll have to ask for the...
As I mentioned earlier in my talk, that at Sportsman we work as a team. So I do only the simple stuff, and the complex stuff is done by my colleagues. So if you have any complex questions, then maybe we'll ask them on the phone line. I'll have to, like Amitabh Bachchan, I'll have to ask for a call somebody to answer your queries. So when it comes to basically a combination of arthroscopic and open surgery, I think teamwork is extremely essential. And that is what we have achieved at Sportsmed. We have got a wonderful team which works together so that our operating time is well under control. Now, one of the commonest ligaments which is injured around the knee is, of course, the medial collateral ligament. But when we talk about medial sided injuries of the knee, we should not be confining our attention only to the MCL, because the MCL, the superficial and the deep, are just components of the entire medial side, which also entails involvement of the capsule right from the midline, starting from the superior superficial MCL, going right up to the anterior margin of the PCL. So the semimembranosus with its expansions and the capsular thickenings around the posteromedial corner of the knee are also to be considered when we are talking about medial sided injuries of the knee. Now, the occurrence of these injuries are anywhere between 3 to 8%, and these may occur in isolation or in combination with cruciate injuries, the most common being a combined ACL and an MCL injury, which we commonly see in practice. So when there is a direct blow on the outside of the knee, where the foot is planted and there is a direct valgus stress on the knee, it is commonly the superficial and the deep MCL which are affected. However, if there is a valgus strain which is coupled with tibial rotation, then it is the posterior oblique ligament, the POL, which is more affected, commonly affected than just the MCL. So the mechanism of injury is quite important to understand. And combined injuries can have a variety of patterns, which may be contact or non-contact. So why are these injuries important for diagnosis and management? If we ignore these injuries, we realize that there could be the patient may come to you with subtle instability. And if it is just an isolated MCL or a POL, they will come to you with an instability which is not really antero-posterior, but they may feel that the leg is moving sideways. Secondly, if you have done an ACL reconstruction, then this is one of the factors which may lead to early failure of the ACL graft. So the evaluation should be done by using all your usual methods of examination: clinical, radiographic, and arthroscopic. Now, this is a classical case where this patient came to us and said that while he was walking on the street, something hit him from outside, and he almost fell on the road, and he has pain on the inner aspect of the knee. So that is the diagnosis, and usually these people will point specifically to the medial side of the knee and show you where the injury is. Now, this patient is also telling us something else, that whenever he is lying on the side and trying to lift his leg up, he feels that the tibia is sliding down. So this again tells you that this is a classic medial sided injury. This patient was very expressive, and he could tell you all the symptoms that he was experiencing. And with the leg unsupported, again, he felt that the leg was almost shifting laterally. The leg was almost shifting. So after you have listened to the history of the patient, when you start examining the patient, after you have listened to the history of the patient, again the examining the patient, and patients who have a valgus is again the alignment, and patients who have a more aggressive in them when treating the MCL than people who have a varus. You need to be more aggressive in them when treating the MCL than people who have a varus, which are better or laxity. Then we come to palpation. One must do palpation, making sure that you palpate the tibial side, the femoral side, and the mid substance of the MCL, and also palpate the POL posteriorly, as well as the tendons of the semimembranosus, because injuries have been known to affect the POL in quite a few cases. For me, the tap sign is very important, and this tells me the severity of the injury. So, very often I will tap the femoral and the tibial sides of the MCL, and the way the patient reacts to your tapping can tell you how much the injury could be severe. So, this is you go by history taking, then coming to palpation, you palpate the various points on the knee, and then when you talk about laxity testing, you we normally use the Fetto and Marshall grading, where grade 1 is there's no valgus laxity, grade 2 is valgus at 30 degrees of flexion, and grade 3 is which shows that the injury is more severe, is in extension. So if there is a valgus opening in extension, you know that it is not just the MCL, it is the MCL and the POL. And in some cases, it is also the cruciate ligaments that may be involved in a grade 3 opening of the knee. So opening in extension is MCL plus or minus POL. Opening in 30 degrees of flexion is just an isolated MCL injury. So sometimes when you are examining the patient, it is difficult to differentiate whether the opening is occurring on the medial side or is it a lateral opening. And therefore, one of the things to do is hang the leg by the side of the table and feel the joint line while you're doing varus and valgus testing. And this helps you differentiate between whether the opening is on the medial side or the lateral side. The drawer test, of course, should be done whenever you are wanting to check the cruciates. You will do a drawer test, but this should not only be done in neutral but also in external rotation, because if there is increase in translation with external rotation, you know that the posteromedial corner of the knee is affected, and if it tightens up in internal rotation, then you that ascertains your confirms your diagnosis that the injury is on the posteromedial side. Plain X-rays can show you if there are any avulsions or bony avulsions, or if there is any pellegrinastidas which is commonly associated with heterotopic ossification, which is associated with MCL injuries. Stress X-rays, we normally don't do stress X-rays, but wherever we feel that there is a doubt in confirming the extent of opening, I think you can do stress X-rays, but they should ideally be done under anesthesia, and we can do these under CAM guidance, so you can dynamically assess the amount of stress that opens up the joint. So the gradation of the injury can be done by stress testing, but ideally done under anesthesia, and hence it is not routinely done. MRI, of course, is extremely useful. It not only shows you the extent of the injury to the MCL, but also if there are associated injuries. A lot of bone contusion patterns are associated with a lot of these collateral and cruciate injuries, and one can almost identify the injuries looking at the pattern of the bone contusion on an MRI. So the MRI is useful in locating the size and the extent of the tear. Now, this is the normal algorithm which we follow at our clinic. If a patient comes to us with an acute MCL injury and it is an isolated injury, if it is a grade 1 and 2, it is conservative treatment. It is grade 3 in a valgus knee, or there is a bony avulsion or MCL entrapment, then we would go for a immediate intervention and a repair with augmentation. And in the chronic, so what should raise the red flag when you are looking at the medial sided injuries? So severe valgus, bone avulsions, and MCL entrapments. These are places where you would like to do early intervention. Combined MCL and ACL is a bit controversial. Our take on this is we always conserve the MCL in majority of the places and do a delayed ACL reconstruction after the patient has got full range of motion. And this may take anywhere between 6 to 8 weeks or even 12 weeks for the patient to get full range of motion. This is very important because we have seen that patients who have been operated in a hurry when the MCL has not healed, have landed up with severe joint stiffness, and it is extremely difficult to then rectify it and get back their range of motion. So in very selected patients where the MCL injury does not seem to be that hot, if you can call it, and the ACL has gone from the femoral side, we have done an ACL repair along with an MCL repair or a reattachment. But these instances are very low. I think in majority of the patients, we do a conservative MCL in most patients. Now, unfortunately, what we have seen amongst our orthopedic colleagues is that conservative treatment means either do nothing or put the patient in a plaster cast for 6 weeks and then see what happens to the knee. But that is not what conservative treatment is all about. I think conservative treatment is making sure that you aid and do not disrupt the healing of the MCL. We offer, if the patient has a lot of swelling and he has instability on weight bearing, you may have to put him on crutches for a couple of days or weeks. So we put a padding under the knee to relax the MCL and the posteromedial capsule, and this may be there for about 10 days to 2 weeks. Once that has happened, then we give them a hinge knee brace to prevent any valgus strain on the knee, and we emphasize on range of motion, which is not forcible. You make sure that your physiotherapist colleagues do not do any kind of massage or ultrasonic therapy, because we have seen that this aggravates the symptoms on the medial side. Because these people very often will land up with severe quad weakness by the end of your treatment, we emphasize on pharynx stimulation of the quadriceps as soon as we are putting them on non-operative treatment. And the most important thing is, if you find that the patient has grade 3 laxity on day 1, keep on doing serial evaluation of these patients after a week or 10 days, because very often you will be surprised that most of them will come up and they may
Sorry
not
for
need surgery at
interruption.
all.
Sorry for interruption. May I request there is a lot of noise from the back. This is very important talk, and this is for everyone. Those who are doing arthroscopy and those who are not. This is very important. Kindly be little quiet for some time. Thank you so much. Please go ahead.
Most of us wonder where grade 3 MCLs can really heal and give us the desired results. Now, here is an example of a patient. He is a mixed martial arts patient who had this MCL injury. It was like a contact injury, and this was his MRI picture. And somebody would have thought that this should be operated immediately. However, on serial evaluation of this patient, we found that the knee was coming up and it was not opening up to that extent. And surprisingly, this is the result at the end of 3 months following conservative treatment of MCL. So I think one need not rush into surgery of the MCL, because one of the other problems that you could have is heterotopic ossification after operating on the MCL. So some of these results can be very good. The tap sign is, I think, very important, because it tells me how much of bone edema is likely to be there when I am tapping on the MCL. Now, this lady had a valgus external rotation injury with an MCL and an ACL. When I tapped, she was in a lot of pain. This was what her MRI was showing, that there was significant amount of edema of the MCL. Now, these patients you should never touch early, because they will end up with severe heterotopic ossification, because this is what we have seen happening in patients, and these patients can never get back their range of motion and probably have to undergo multiple surgeries to get to restore range of motion. So I think clinical radiological is extremely important, and serial evaluation in an MCL injury. Intervention will be required in certain situations, like this tibial sided so-called Steiner's lesion, where the tibial side MCL is completely curled up, and this is not going to heal. So in these patients, you may have to do a refixation along with maybe augmentation of the tibial MCL, and this is what we have done here. So this is the stability on the table after fixation of a tibial injury of the MCL. This is a medial sided repair which we have done in a farmer who had a MCL, posteromedial capsular injury, ACL and PCL. After repairing everything, especially on the medial side along with the capsule, which very often is ruptured right from the anterior to the posterior, this is the kind of stability this farmer got, and he did not consider undergoing any further surgeries, and he was perfectly normal just by repairing these extra articular tissues. So I think these injuries are very important. If you treat them in the right fashion in the acute stage, you can get excellent results. Another case of an entrapped MCL and a medial meniscus bucket. Now here you could not reduce the knee because the MCL, the medial meniscus was entrapped, and so also so this is a test which has been described as the sucking test for the MCL, where you feel that the MCL is entrapped inside, and you can see here on the abnormal side that there is something like a dimple on the medial side, and this is a sucking test which is for this kind of a condition. During arthroscopic evaluation, we found that there was an entrapped ACL and a medial meniscus bucket. We reduced the bucket handle, and then we did an open repair of all the structures. So you start from the deeper structures, repair the meniscus back into place, then the deep MCL followed by the superficial MCL, and very often you have to augment this either with some polyester tapes rather than sacrificing any of the hamstring grafts on the medial side. So these are the primary repair and augmentation methods that we follow in our clinic. We use the Stannard's procedure where the semitendinosis can be kept attached at the tibial side, looped along the medial epicondyle and reattached, rerouted back, and can be fixed back. And this can be done in the acute stage as a part of repair and augmentation procedure. Coming to the chronic injuries, I think these again can be isolated or combined. In the isolated valgus instability, if it is grade 2, we prefer what is known as a POL zone-specific advancement technique, and this is commonly done in people with low demand. And I'll show you what we mean by this. In grade 3, of course, you will need to do some kind of a reconstruction, and this could be both anatomic or non-anatomic. So I will quickly show you what are the differences between the two. So when you have combined instabilities because of the cruciate and the collateral and the capsule, I think one needs to go mainly for anatomic kind of reconstruction, especially in the high demand individuals. So what do we mean by zone specific advancement of the POL? If you look arthroscopically in the knee and you find that the distance between the meniscus and the femur is more, then you have to do advancement more from on the femoral side of the POL. And if the opening is more on the inferior side of the meniscus, then you have to do a tibial sided advancement. So here you can see that zone 1 and 2 are the places you will advance when there is a femoral side detachment or opening, and grade 3, 4 and 5 are the zones where you would do a tibial sided advancement of the POL. The various kind of reconstructions that we see are the single bundle anatomical reconstruction, the double bundle non-anatomical, the double bundle anatomical. We feel that the double bundle anatomical, although an excellent procedure, may result in too many myriad of tunnels in the tibia, leading to a lot of tunnel coalition, and hence one is going to be adequately trained to do these kind of anatomic reconstructions for the combined instabilities. Now these are examples of non-anatomic reconstructions where basically you are reconstructing the superficial and deep MCL and the POL using the semitendinosus graft, and this is an example of the non-anatomic reconstruction. Our experience, you can do minimally non-anatomic also by taking just skin incisions, but I think if you want to do a proper job, it is better to do a proper open procedure than going for minimally invasive procedures. We have limited experience with the Laprat technique,
where you have to use multiple grafts and drill multiple tunnels to create both the POL and the superficial and deep MCL. This requires a lot of grafts, not just a lot of grafts, but also a lot of tunneling. And if you have something like a bicruciate injury along with the medial sided injuries, we prefer to do the ACL and PCL the regular way and do a non-anatomic reconstruction on the medial side to avoid the tunneling and the implants that are involved in the anatomic procedure. So this is our anatomic Laprade reconstruction, anatomic MCL reconstruction, medial side reconstruction. So I think these are injuries which should not be neglected as they may lead to symptomatic instability or early failure. And comprehensive evaluation of these injuries involves both clinical, radiologic and arthroscopic modalities to be used. Thank you very much.
Thank you, sir. Please stay back on the dais because you will be later on addressing the Meet the Master. May I request the organizers please
उसी को सिलेक्ट करो,
honor the chairperson. Thank you, sir.
और ऊपर आप
Sir, please बैठ here.
हाँ दोबारा
Can I call Dr. Rajan Nath, sir? Sir, please come on the dais and felicitate
this network
Professor
device
Gyanand
लिख के आ
Chandra,
रहा
sir.
ऊपर।
And I'll call Dr. R.P. Johari, sir. Sir, please come on the dais and felicitate Govind Sethi, sir.
ऊपर ही उस पे क्लिक करोगे तो डिसेबल दिस नेटवर्क डिवाइस लिख के आ रहा है। अरे तुम 1 मिनट के चक्कर में तुम मेरा बयाना करा दोगे। हाँ 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 हो गए। Analytics खोलो and analytics खोलो।
Now, can I quickly meet the master because we are running short of time? Can I request all the speakers to be on the dais once again? Dr. Vinay, Dr. K.D., Dr. Anant Joshi, Dr. Ashish Kumar sir, please be on the dais. And quickly, I can request all the delegates to be come.
Now, can I quickly meet the master because we are running short of time? Can I request all the speakers to be on the dais once again? Dr. Vinay, Dr. A.D., Dr. Amit Joshi, Dr. Ashish Kumar sir, please be on the dais. And quickly, I can request all the delegates to be come with the questions. Dr. Rajiv Agrawal, please. And Dr. Anupam, please. Ajay, please come. Because we are running short of time. So this question is new introduction to our schedule. This is Meet the Master. You can ask from any session, any question, and this is rapid fire type of session. Please come with all questions. So there are 15 minutes for this session. Please be ready with the questions. Thank you, sir.
My question is whether we have to do reconstructions of ACL in all the cases, or we can conserve and we can do conservative treatment without reconstruction.
Dr. Anant Joshi.
And what is the timing of doing ACL?
Dr. Joshi, sir. My question is whether we have to do reconstructions of ACL in all the cases, or we can conserve and we can do conservative treatment without reconstructions. And what is the timing of doing ACL reconstruction in patients with acute injury?
Because I feel that along with the ACL, you have extensive bruising on the lateral femur spondyl and the lateral tibial plateau. You can have associated injuries like to the MCL. So for me, a safe time to operate on an acutely injured.
So I really don't operate on the acutely injured ACL in any of the situations. because I feel that along with the ACL, you have extensive bruising on the lateral femoral condyle, the lateral tibial plateau. You can have associated injuries like to the MCL. So for me, a safe time to operate on an acutely injured ACL is when the knee is not swollen, when the patient has full range of motion, his gait is normal and his muscle control is good. Now, this depends on the severity of the initial injury and may take anywhere between 3 weeks to even 12 weeks for me to decide on whether the patient needs surgery or not. So, the minimum time that the patient waits before he undergoes surgery is 3 weeks. The next thing is, I don't believe that everyone needs an ACL reconstruction because we see that the pattern of ACL tears vary significantly. In some patients, the ACL on the MRI looks edematous and it is not completely detached from either end, or it's not a mid-substance rupture. And therefore, in these patients, I feel that there is a possibility, just as we knew that in PCL, there can be restoration of PCL fibers. We have seen this similarly happening in ACL. And therefore, we do serial examination of the knee, even in the ACL cases. And if we feel that the Lachman is reducing and the patient's symptoms do not show any sign of instability, then we just keep them under observation and tell them to restrict their sporting activities, go on with their regular day-to-day activities. Because very often people are sitting at home because their ACL is injured, but that doesn't have to be done. And with a protective bracing, and then serial examination is what helped me decide whether this patient definitely needs an ACL reconstruction or not. What you must also remember is that in a young patient, if the patient has, in addition to the ACL and a meniscal injury, then in those patients I would definitely be more aggressive than patients who have just isolated ACLs, because the meniscus tear is likely to increase, and I don't want a repairable meniscus to be an irreparable meniscus just because of my being slow in decision making.
Thank you. Any other question? Dr. Nirbhay, Dr. Anupam, please.
Thank you, sir. My question to all the panelists: we are so much confused about the using the implant at the tibial side. It's to be the bio screw or the metal titanium screw. What the consensus is? Dr. Assis.
Bio screw or metal screw. So a lot of peer pressure, a lot of company pressure, a lot of patient pressure. सांप गलने वाला screw लगाना. We all have suffered with the allergic reaction and the complication that we observe, cyst formation, so many things with the bio screw. Now people have come up with a peak screw, somewhere in between, neither metal nor bio. So it is not seen on the X-ray. Your wrong deeds are not seen on the X-rays. So, but for all practical purposes, titanium screws have got excellent results. There is no confusion. It is because of all these reasons we are using this bio screw. This is a rare thing that you have to drill through the screw, and such case titanium screw you can very well remove also and can go ahead with the things.
Dr. Sachin, what is your view, sir?
So I think the newer generation bio screws are as good as your PIN or your titanium screws. The least amount of osteolysis will be with a titanium screw followed by a PIN screw. Bio screws are apparently supposed to slowly disintegrate and bone is supposed to reform, which usually does not happen. The HA and the TCP which is provided within the bio screw is okay. They say it is for bio-osteoinduction and osteogenesis, but the real reason why there is HA and DCP in the screw is to neutralize the acid, which is the PGA or the PGLA. So if you ask me what type of screw should you use, I think if it is very strong bone, then always use a titanium screw. Otherwise, a bio screw is good enough, and there is no difference technically between the outcomes if you use either a titanium or a bioscrew. But if you're using a bioscrew, make sure that there is either HA or TCB, there is a third generation screw, so that there is no osteolysis.
The small bone, he says, the use titanium, and the normal bone use bioscrew. Sir, Dr. Anant Joshi, sir, what is your view, sir? Final say on it. No experience with bioscrew. So the story is very clear. The master says he has not used the bioscrew. So nothing, no further discussion on this topic.
My second question is the position in fixation of the screw. The flexion position is, we used to do is 15 to 20 degree of the flexion at knee while fixing the tibial screw. Or it is, once it is a suspensory fixation, it's needed to be fixed in a flexion position, or it should be now. Once it is a suspensory fixation, it's needed to be fixed in a flexion position.
Yeah. What is the position of the knee when you fix the tibial screw?
Yeah, position, ideal position.
So it is, you can do it 15 to 20 degree of knee flexion. That is the ideal position of fixation of the tibial tunnel.
It is not important that you are using which device.
Yeah.
It is the isometry and the length of the graft and the position while you are tightening. So you have to follow that 10 to 15 degrees. So that you are going, either you fix with a suture disc or you are fixing with the bioscrew that hard, or any screw. That hardly matters. It's the length of the graft, in what position you are having the shortest length with the isometry. That's why you are doing it 10 to 15 degree of flexion.
Sometimes it is a 7 mm graft, then we are very apprehensive that we have to take the restless also to make it more in a big, thicker size. But it does says the 7 mm is enough to fix it, reconstruct the SL.
He says,
for me, the minimum size of the graft is 8 mm.
8 mm.
I do not forget.
8 is the standard one. If it is less than that, then augmentation with the fiber tape, something like that.
if you could fetch only 7 mm graft, will you delay the walking or weight bearing?
So many things. What is the BMI of the patient? For which patient you are having a fat lady with a 7 mm graft, lot of weight, lot of fat, then you have to be slow.
Most often the fat persons have got thinner grafts.
Yes.
So, and weight is more, graft is less.
You have peroneus longus for them.
So that is why you use various techniques to increase the size of the graft, like surshot, triplication, quadruple, pentuple, even hexaple, so that you get an adequate size of the
So
graft.
in those cases, would you prefer to use one fiber tape if the graft is thin?
I personally do not use fiber tape. I'll rather harvest another one graft so that I can increase the size.
Will you take the graft from the other side also?
Not necessarily. I can use quartz in addition to the
From the same
hamstring, use gracilis. But most of the time, if you have semi-T and hamstring, if you hexaple them and do all inside ACL reconstruction or use a suspensory fixation in the tibial side as well, you will be able to get more than 8 mm graft most of the time.
So same side, but he'll not go less than 8 mm. So this is the final verdict for this question, I think. Is it okay? Or Dr. Vinay, you want to say something?
Yeah, Anand sir, quite a few videos were showing you using fiber tape. Today's a lot of videos had this fiber tape alongside ACL. So have you shifted toward this fiber tape along with ACL fixation, or but you showed video also of complications with that? So what's your take? Either you're using fiber tapes or you're not using?
Dr. Anant Joshi, sir.
I think in recent times, in the past 6 months or so, I think we have gone away from using the fiber tape. We were using it, I think, more freely earlier, but after seeing these reactions to the fiber tape, I think I have become a little bit more cautious.
He says he found lot of reactions for fiber tape.
So, the problem is, unfortunately, in the scientific community, when you report something which is negative, it can never be published. and therefore you will see only positive results of all these augmentation devices. You will not see negatives. But from your own personal experiences, I think you need to change your course of the procedure that you are doing depending on your experiences, and not wait for the rest of the world to tell you that this was not the right way.
Ashish sir, I think you are proponent of using fiber tape. Huh? Sachin sir, what's your take on that? Using fiber tape alongside ACL?
Not at all. Absolutely not.
Oh, so the verdict is please avoid using fiber tape. Is that okay? Like intra-articular, of course, because it can
Then
give some
how,
reaction.
like if it is 7 or 6 mm, then how you do? You take the bracelet along with that and supplement it.
So he says, Dr. Amit Joshi says, do not compromise for the thickness of the graft, but do not use artificial things to make it thick. Next question, please.
What is the ideal time to get MRI after an acute injury? After an acute injury, what is the ideal time to get an MRI?
Anytime.
I think you are asking because there were in some papers, some literature, it is said that if you do early MRI, then you will see the vivid picture of the knee and then exaggerated injury level. So, but you see, understanding of what you are looking at it, the presence of hematoma acts as an enhancer of your injury, like in shoulder. So probably if there is indication for surgery, I'm not hesitant to do MRI on the same day or next day. But if there are no indication for doing early MRI, I'll let the patient be quiet because it is painful process, doing 45 minutes of MRI. So let it be quiet for 1 or 2 days, 3 days, 72 hours. The need goes down and get an MRI done.
Quality of machines has also changed now. It is not the old saying that you should wait till everything subsides, edema subsides. You may miss certain things which you are going for the immediate repair. So it's not very pertinent to the today's MRI and everything that you delay it till edema subsides.
So would you like to wait for ACLR to be done after the injury because you find a lot of blood inside and your vision is hampered? What is your view, sir? Or you will go immediately after the injury?
Blood is getting washed off. That's not the issue. What Dr. Joshi has said that when your knee is quiet, you can start with the exercises
So
on the
what
day
is that
two.
quiet period? When do you think it is quiet, sir?
Variable.
Sir, how do you decide that now the knee is quiet, sir? Dr. Anant Joshi, sir?
I think, as I mentioned before, that the patient should not have a swollen knee, so no swelling. So patient should not be limping. There should not be any extensive bone bruising on the MRI. Bone bruising on the MRI. Patient should have full range of motion and muscle control should be good.
Excellent, sir. This is great help to all of us. How to decide the quiet knee. This is very, very important basic knowledge which Dr. Anant Joshi has given. Next question, sir.
Good afternoon, sir. Sir, a young soldier who's just 31 years old. He's actively involved in all hilly terrains and his straight job is the same. Sustained injury with ACL and bucket handle lateral meniscus. I went inside. First, I thought of doing the lateral meniscus. I tried to do, but while putting all inside technique with the fast fix, after doing the first fire, I was not able to take the complete loop, but still I tried to retrieve it and made a second fire. While doing the second fire, most of the fibers were torn, sir. Eventually I tied it, but could not achieve that bump of meniscus. And then made us entry with second fast fix.
Please make the question short, sir. We are
I
running
just
short
want
of
to
time.
know if I am unable to repair lateral meniscus completely and some fiber has to be sacrificed, what to be done in this young soldiers?
So basically, you can bring a part of the meniscus which has been deformed.
No, I think you have repairable and irreparable tears. So unfortunately, in this case, it has become iatrogenically non-repairable.
Yes.
So you have to trim it because there is no point in leaving a deformed meniscus inside the knee. So basically, you can trim a part of the meniscus which has been deformed and retain the remaining, the rim. Of course, it's very important in a young soldier to have the lateral meniscus, and lateral meniscus tears do heal very well. But these are some technical issues where you can have problems, and one needs to do something which is a bit more drastic than you
Anand
would
sir.
like to do.
Sir,
So,
only.
Anand,
Yeah. I think we should have only two questions more, and then we have to. Dr. Sethi from London and Dr. Chandan, our secretary, please.
Regarding the ramp repair, what angle of suture last?
Is 45 degree. 45 degree right and left.
So you take the bite from both the sides, posterior, anterior, simultaneously, or you have to shuttle, because taking the bite with both the side of the tear, it's difficult.
one by one is good, I think.
It is technical issue. It depends. If you can take bite with one single go, it's better to take bite with one single go because this reduces the time of surgery. Because along with the ramp, you have to do ACL reconstruction as well. So if you are not able to take a bite with a single go, then you can take it in two goes. What is harm in that?
Use two posterior medial portals or
posterior. I use transseptal. Yes, I use posteromedial and the anterolateral portal.
Anybody taking posterior lateral as well? Visualize.
You can use the transportal technique if you find that you have to take shuttling of the sutures, etc. If you want to make it easy and not take two portals on the posteromedial side, you can do two portals also with two cannulas, one superior, one inferior. Or if you don't want to have suture entanglement, you can do a transportal technique, take out sutures from the lateral side as well, and then retrieve all of them on the medial side.
Dr. Sethi, please.
The things loud and clear, I think Dr. mentioned.
Please be loud.
There should not be any rush in doing ACL reconstruction. We don't even start seeing patients or managing it within the first 3 weeks. Let it quieten up. No need even to do an MRI. We never know, he may not need an MRI. It may be another injury, probably hemarthrosis of secondary cord rather than ACL. And as rightly said, one should not have a flexion deformity before he gets to an ACL. Get them into a physio. The problem only comes in when there's a bucket handle tear medial meniscus with an ACL. What will you there? You can't leave him. You can't do that. We tend to do it, go ahead and reduce it if we can. If not, surgically reduce it and rather repair it. Don't go for ACL. Go back again in 6 weeks' time. What's your thought about that, sir? In a bucket handle tear, middle meniscus, ACL injury, we can't wait for bucket handle 6 weeks. We need to do that. So what we tend to do it, I want to make sure, are we doing right or wrong? We try to reduce it if we can in ED or repair it and go back and do ACL after 6 weeks. But we don't let them mobilize because we don't want the repair to be undone. Put them into a brace, wait for 6 weeks. What are your thoughts about that?
I think majority of the stuff being done at NHS is wrong.
I just wanted to know that. What's your experience?
I think what we are doing is much better. If we have a bucket handle with an ACL, we would tackle both together at the same time.
Okay.
Because if you repair the meniscus and if the instability continues, the bucket is likely to fail and it might come in before you do the ACL.
So we don't allow them movement. So we put them into a brace. 6 weeks we don't allow them, unlike ACL, where you want to mobilize, but we don't allow them. We put them 6 weeks. Is there anything different you do? You would probably do.
We'll do everything
at the same
in
time.
one shot.
Okay.
I can understand there is a lot of hunger for the questions because the faculty is so learned, so auspicious. But we cannot go on the session. We'll ask the questions in maybe the lunch time. Thank you very much, and thank you very much the faculty for answering all the meet the master. Thank you so very much. Please. And may I request organizers to be ready for the inauguration function. Thank you, sir. Please take your seat. Thank you, sir. इन्वोकेशन शुरू करो अजीत।
केयरटेकर बोल रहा हूँ, आप संजय केयरटेकर नंबर है आपके? हाँ चाबी मेरे घर से लेके 207 ज़्यादा गाली होती बहुत पड़ेगी, रेडी रखा अपने पास, रेडी करना जरूरत पड़ेगी, बोलेंगे ना कुछ ना कुछ देखें जो भी बोलेंगे, मैं रेडी कर देता हूँ आपको बिल लगे। वो केयर टेकर आ रहा है तो आवाज़ आ रही है, 102 की चाबी केयर टेकर को दे देते हैं। फोन किया था क्या तुमने? सो रहे हो क्या खड़े? फोन किया था क्या? फोन किया था तुमने? कैमरा बंद है। हाँ, तुमको आ रही है? सवाल ही नहीं उठता, मान ही नहीं सकता। 4-5 आवाज आ रही है? हेलो, छोटू आवाज आ रही है? जल्दी लगाओ, जल्दी लगाओ, टाइम ना खराब करो, जल्दी। मीटिंग हुई है, आपने मिस कॉल नहीं देखा, मैं भी बोल देता हूँ।
Good afternoon, everyone. So I request everyone please be seated on the chairs. We are going to start inauguration function very soon. Humble request to all the delegates, please be seated and please make a silence.
Good afternoon, everyone. So I request everyone please be seated on the chairs. We are going to start inauguration function very soon. Humble request to all the delegates, please be seated and please make a silence.
I request our chief guest, Dr. Anant Joshi, sir. Dr. Anant Joshi,
I
sir,
request our Honorable President, Uttar Pradesh Arthropedic Association, Dr. Ashish Kumar, sir, please come on the dais. Please give a big clap. I request our chief guest, Dr. Anant Joshi, sir. Dr. Anant Joshi, sir, please come on the dais.
Professor A.K. Gupta, sir. So please come on. I request our organizing chairperson of Kanpur Arthroscopy.
I request guest of honor, Professor A.K. Gupta, sir. So please come on the dais.
Now I request our organizing secretary of Kanpur Arthroscopy course, Dr. A.K. Agrawal, sir, please come on the desk.
I'll request our organizing chairperson of Kanpur Arthroscopy course, Dr. R.K. Singh, sir, please come on the desk. I'll request our organizing secretary of Kanpur Arthroscopy course, Dr. A.K. Agrawal, sir, please come on the desk.
Please give a caller to the
Now I request Secretary Kanpur Arthropedic Association, Dr. Chandan Kumar. So I request Dr. Chandan Kumar, sir, please give a caller to the presidential caller to A.K. Agrawal, sir.
Our senior sir, so please come and to the Saraswati Bandana.
I request Professor Rajen Nath, sir, our senior sir, so please come and do the Saraswati Bandana.
We wish to invoke Goddess Saraswati on this occasion because we have been listening to the learned talk since morning and we need to assimilate that. May Goddess Saraswati give us power to assimilate the knowledge that you have provided to us since morning. We also invoke Goddess Saraswati on this occasion because we have been listening to the learned talks since morning and we need to assimilate that. May Goddess Saraswati give us power to assimilate the knowledge that you have provided to us since morning. We also invoke Goddess Saraswati to give a feeling of nationality which is lacking in us, which is lacking recently so much. We want to be involved with love to our motherland. I vimal vasne alulai kuntale Shri Sharde Rashtriya Veena Tanik Kripaya He Janani Jankar De अनुनाद हाँ हृत तंत्रियों में ध्वनित हो जावे तथा प्रतिरोम में चैतन्य पूरित हो जगे हम सर्वदा। मातृभूमि वंदना अब मैं करना चाहता हूँ अपनी तरफ से। हिम उधर किरीटे जानवी हार शुभ्रे परिकर श्रुति विंध्यालंकृते रत्न गर्भे। और describing our Bharat Mata. हिम उधर किरीटे जानवी हार शुभ्रे परिकर श्रुति विंध्या लंकृते रत्न गर्भे सलिल सुशैव्या लंकृते रत्न गर्भे सलिल सुशैव्या लंकृते रत्न गर्भे सलिल।
Thank you, sir. I request all the dignitaries on dais, please come forward for the lamp lighting.
Bye.
जय गणेश जय गणेश देवा माता जाकी पार्वती पिता महादेवा दयावंत चार भुजाधारी एक दंत दयावंत चार भुजाधारी माथे सिंदूर सोए मूसे की सवारी माथे सिंदूर सोए मूसे की सवारी पान चढ़े फूल चढ़े और चढ़े मेवा लड्डुअन का भोग लगे संत करे सेवा
So now we have a small presentation. Now I request Dr. A.K. Agrawal sir to felicitate Dr. Ashish Agrawal sir, Ashish Kumar sir, our UPO president.
Thank you so much. Thank you. So now we will have a small felicitation program. Now I'll request Dr. A.K. Agrawal sir to felicitate Dr. Ashish Agrawal sir or Ashish Kumar sir, our UPOA president, by a memento and a small token of appreciation.
I'll request Dr. Ashish Kumar sir to felicitate our chief guest, Dr. Anant Joshi sir.
I'll request Dr. Ashish Kumar sir to felicitate our chief guest, Dr. Anant Joshi sir.
I'll request Dr. R.K. Singh sir to give felicitate to Professor A.K. Gupta sir.
I'll request Dr. R.K. Singh sir to give felicitate to Professor A.K. Gupta sir.
To felicitate A.K. Agrawal sir, KOA president.
I'll request Dr. Chandan to felicitate A.K. Agrawal sir, KOA president. I'll request Dr. K.D. Tripathi sir, please come on the dais. And Dr. A.K. Agrawal sir, please felicitate K.D. Tripathi
Dr.
sir.
Anant Joshi sir, please come on the dais. Dr. Sengar sir, Professor Sengar sir, please come on the dais and felicitate Anant Joshi sir.
I'll request Dr. Amit Joshi sir, please come on the dais. Dr. Sengar sir, Professor Sengar sir, please come on the dais and felicitate Amit Joshi sir.
I'll request Dr. Vinay Pandey sir, please come on the dais. Vinay Pandey sir.
Dr. Amit Joshi ka special thanks.
Dr. Govind Sethi sir, please
because
come on
he
the
has
dais.
drove
Felicitate
from
Dr. Vinay Pandey.
very long distance.
I'll request Dr. Vinay Pandey sir, please come on the dais. Vinay Pandey sir. And Dr. Govind Sethi sir, please come on the dais and felicitate Dr. Vinay
I
Pandey.
request Dr. Pankaj Tandon sir, please come on the dais and felicitate our dynamic secretary Chandan Kumar sir.
I'll request Dr. Pankaj Tandon, sir, please come on the desk and felicitate our dynamic secretary, Chandan Kumar, sir. So I'll request Dr. R.K. Singh, sir, Dr. Nirbhay Kumar, sir. Dr. Nirbhay Kumar, sir, please come on the desk and felicitate our organizing chairperson, R.K. Singh, sir. Just last one. So I'll request Dr. R.K. Singh, sir, Dr. Nirbhay Kumar, sir. Dr. Nirbhay Kumar, sir, please come on the desk and felicitate our organizing chairperson, R.K. Singh, sir. So I request organizing chairperson, Dr. R.K. Singh, sir, please give welcome address.
We are already short of time, and because Joshi is requesting don't welcome, simply say thanks. He will be leaving very soon.
So I'll request our organizing chairperson, Dr. R.K. Singh, sir, please give welcome address.
I'm very much thankful to all the delegates as well as all the senior speakers. We are already short of time, and Dr. Joshi is requesting don't welcome, simply say thanks. He will be leaving very soon from the airport, and we, on behalf of Kanpur Orthopedic Association, I am very much thankful to all the delegates as well as all the senior speakers. I don't need to repeat the names, but I'm very much privileged to honor especially Dr. Anant Joshi. I've been his admirer for the last 25 years. 25 years back, I visited his clinic, and I was really impressed the way he was working. And he is the person who has make arthroscopy as a super specialty. And I appreciate that, and we should learn from him. And similarly, I'm also thankful to our president of UP Orthopedic Association and all other senior speakers. Thank you very much. Thank you very much.
I'll request our UPO President Ashish Kumar, sir, for the presidential address.
He asked for organizing such kind of things. So I was,
Thanks, Dr. Ajit, and the dignitaries on the dais. So, as a UPO president, I'm supposed to speak a little bit. So, it's a wonderful program. When Dr. Amit, he is senior to me, he asked for organizing such kind of things. So I was not expecting this much good arrangements. It's a wonderful arrangement, and the stalwarts of arthroscopy have been invited, and they have joined online as well. And it's a wonderful thing to have this kind of program here. All aspects have been covered regarding the knee, and I have contributed a little bit to it. So I must congratulate Dr. Amit and his whole team. As far as Dr. Joshi is concerned, he to arthroscopy ke pitama hai. So we all have learned seeing him, and now I believe ki everybody, in every college we are having, like in my department we have 21 residents now every year who are getting trained in arthroscopy. So arthroscopy has to increase leaps and bounds, this we all know, and that's why this kind of meetings are very, very important. So I have, once again, I congratulate him and the best wishes for forthcoming time when he will keep on organizing such things. Thank you very much.
Thank you, sir. So I think this is a pride for Kanpur, not only the Kanpur, it's a whole UP, and all the Kanpur Orthopedic Association members are blessed to have Anant Joshi sir in between us. So if we would love to listen you if you want to say something. How was the hospitality? How was this place?
I'm extremely delighted to be back in Kanpur after almost a gap of almost 30 years.
Dr. Singh, our friend Ashish, my old friend Dr. Gupta, and all the committee members of the Kanpur Orthopedic Association who have taken great pains to organize this meeting. I'm extremely delighted to be back in Kanpur after almost a gap of 30 years. I remember having come here for delivering an oration for the Kanpur IMA. And then I've been waiting to get an invitation from Kanpur, which finally came when Dr. called me. Dr. Amit called me. And so I have been coming quite frequently to this great state of Uttar Pradesh. And I have friends, I have people planted in all the different areas like Lucknow, Varanasi, Allahabad. But unfortunately, I didn't have anyone in Kanpur. And finally, I got a friend now who will keep on inviting me, hopefully, for his next meeting.
Always pleasure and proud for Kanpur people to invite you and to host you.
So I'm extremely grateful to the organizers for hosting me here. We also had something different than just the academics. We had a cycle ride in the morning to promote health, and that was a good step forward, different way of thinking of how to promote not just arthroscopy but also sports science. I'm also delighted to see so many younger as well as other colleagues who have come here for this interaction between the orthopedic surgeons. I think it helps all of us in bettering our understanding of the subject that we are dealing with. As always, the hospitality has been really outstanding, and I'm extremely grateful. And thank you once again for having me here.
Thank you so much, sir. Your simple presence is quite igniting for the brain of our young colleagues. So I'll request all the faculties, please come on the desk. We have a group photograph followed by the closing of the ceremony.
So we have the national anthem. I request everyone please rise. Sir, thanks. We don't have time. Sorry, sir. It's a thanks to everyone.
Vote of thanks देना था, लेकिन because we are running short of time, let us stand for the amendment. Sir, I give extended thanks to everyone.
So we have the national anthem. I'll request everyone please rise. Sir ने कर दिया, thanks. We don't have time. Sorry, sir. It's a thanks to everyone.
Vote of thanks देना था, लेकिन because we are running short of time, let us stand for the amendment. Sir, I give extended thanks to everyone. Detailed thanks I'll give post lunch. Thank you, sir. Sir, his flight may be missing flight. Sir, please be here with the timing, sir. Thank you, sir. I'll give, and I understand there are a lot of falls and the police then which must be disturbing you. And we keep KOA apologize for all those follies. And I thank you all of you, including pharma, including media person, our faculty of course, and delegates for this wonderful presence and making the program successful. Thank you so very much.
So we'll start national anthem. Jana Gana Mana Adinayak Jaya He Bharat Jana Gana Mana Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha
गंगा हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जाने तव शुभ आशीष माने गाहे तव जय
Thank you all. So now I request everyone for the lunch. Please come and join us for lunch.
भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you all. So now I'll request everyone for the lunch. Please come and join us for lunch.
When the flat of the beach is at the entrance of the duct, the needle is twisted onto X in the canyon. Squeeze the main trigger.
ये देखो ऐसे लगी लैपटॉप में, लैपटॉप की
देखिए भाई, हम किसी का दूसरे का रूम हम नहीं खोल सकते। मान लो बाद में कुछ भी होता है तो बाद में रिस्पॉन्सिबिलिटी हमारी है। तो कहता हम ऐसे किसी का चैम्बर नहीं खोल सकते। ये हाँ, वो कहें कि आप जाइए खोलिए तो वो अपनी रिस्पॉन्सिबिलिटी से खोलेगा जब वो कहेंगे।
इनको कोई चाहिए ना डायरेक्ट सीधे कर देते वहाँ रखिए, ऐसे कोई थोड़ी रखिए। अपना काम खत्म ना दे दिए उसकी जिम्मेदारी।
नहीं नहीं, अब इनको बताना पड़ेगा सर को।
भीड़ भाड़ में
हाँ, वही चीज़ अभी देखता हूँ सर इंस्टाग्राम। ये 1.5
Or looking at going on inside this, every inside of this best. What is important and essential here is to look and use special needles with 2O polyester suture or 2O ultra high strength suture, and these are threaded on flexible nitrile needles. Inside of system, a small area of the distal tissue. What we want to do is expand the innovations on the area of the system for which we can use inside of system. And all that will focus, I think, result in
बहुत हो गया, मुझे लगा शायद वो कल ही आया, तो मुझे लगा शायद वहीं से बात कर रहे हैं। कहाँ लाइक करते हैं? यही सब चल रही है। हमारा नंबर ना कहाँ पर गए, कितना बड़ा मॉल है, उसका साउंड होगा। जैसा आप चाहिए वैसा करें, फूड से चाहिए, पैसा ऑफर चाहिए, कैश से चाहिए, जैसा भी चाहिए।
सर वाला हमें दे दो, सर वाला हमें दे दो। अब इसी में डाल दें, कम हो गया ना, मोड़ के डाल देंगे तो टेंशन खत्म रहेगी ना। अगर निकलेंगे तो ये नहीं रहेगी अब बन गया।
कुर्सी जाओगे अंदर अपनी सीट में
मेरा कल तो पेपर है, हम तो कल सकून से डॉक्टर साहब का लेकिन मूड बड़ा फुसका हुआ पेपर है तो पढ़ाई तो आज नहीं हो पाई। अरे डॉक्टर साहब का मूड एकदम बना हुआ है।
सुबह साइकिल भी चलाए थे थोड़ा, डॉक्टर साहब भी चलाए थे, 2 बार बचे कितने फिर चला रहे थे, एक तो गए काफ़ी दूर तक, उनका बैराम भी इधर से गए उधर लेके आए, पूरा फूल घूमे।
Please wait for few minutes.
ये अलंका वाला काम समझ रहा है, वही जो बली वाला चेक
खाओ। इतना खाओ बाथरूम जाना जरूर पड़ेगा। भागने जाना, मिट्टी में मत जाना बस। ये पूरी बैंसन नहीं होती थी। दांत का मत खाओ, तुम ज्यादा खाएंगे क्या देख रहे हो? क्या? चिकन नजर लगा हुआ आप समझे मिलेगा
डाइटिंग पे
आज मैं मालिक ने कहा शाम को समझे पार्टी देंगे
I request to everyone that we are going to start our third session very soon. Within 5 minutes, we are going to start our third session. So please finish your lunch fast.
पानी बोतल खोल
माना कोई ऐसे हैं शाम का क्या हमें उड़ा के
कंसोल तो नहीं आ रहा देखो कंसोल तो नहीं आ रहा भाई उठा के पी लो यार अभी कैमरा वीडियो आए थे वो चले
May I have your attention, please? So we are going to start our third session, which is on understanding medial knee injury. I will request Dr. Santosh Rajpal sir. Dr. Santosh Rajpal sir, please come on the dais to chair the session. I will request Dr. Rajen Nath sir. So please come on the dais. I will request Dr. Pankaj Tandon sir. Please come on the dais and start.
Good afternoon, everybody. Dr. Vinay Pandey. Thank you, sir. So, thank you, sir, and Shah sir for giving me the opportunity. My talk for the day is about ACL alignment fixation. We will be talking only about technical course. So, how to fix the fragment and how to go about it. So, everybody is aware about this classification system given the Myers and McEvers. Classified ACL alignment into 4 different types. Type 1 is undisplaced fracture. Type 2 is anterior lifting of the fracture. Type 3 is complete displacement, type 4 is combination of the fracture. The different fixation methods have been advocated, which are classified into direct methods and indirect methods. So direct methods are screw, staple, K wires, and indirect method is suture, which has come up in the last 10-20 years. So this is probably the earliest method of fixation given, wherein arthroscopic reduction of the fracture fragment was done, and it was fixed by K wires. So type 3 injuries were managed, and 2 to 7 years follow-up was done, and it yielded good results. The problems described in the literature in this article was pin migration, residual laxity, and hardware removal. But they did emphasize that arthroscopy is associated with lesser complications than arthroscopy. This is an article from Ganga Hospital, where 32 patients, close to 2 years follow-up was done. Accident, IKDC and this room was shown more than 90%. They had one complication, this is a staple fixation method. So one complication was backing out of the staple 8 months after the injury and the surgery. So this resulted in impingement and articular cartilage damage, which is a catastrophic kind of complication. So intraarticular hardware is something one has to be wary about. Anti-impingement and implant removal is a possibility when using hardware inside the joint. There is an article from Ahmedabad wherein 10 patients were followed up for 6 to 18 months. A medial parapetial arthrotomy was done and screw fixation was used. Again, a good Newton score was shown. Very good result. Again, screw head impingement was a possibility. For small fragments and fragment combination, this was probably not the best method of fixation of ACL evidence. Hardware removal again was a possibility in these fixation modalities, wherein metals are put inside the joint. Since then came a lot of indirect method of fixation through suture, fiber sutures and fiber wires. This is an article from Pune by Dr. Tapsavi, which is shown in the morning as well. He identified 2 bundles of ACL, and the wires was taken from anteromedial bundle and posterolateral bundle. And the 2 tunnels were created in the tibia, and therein the sutures was taken through the tunnels and fixed upon the anterior surface of tibia over a button or a post. The wire through the ACL bundles is not so easy because it's an acute condition, and sometimes it's very difficult to identify the different bundles and then to take by the end. Again, the ACL stump cut through while passing the fiber wires is a possibility which is seized wiring, and which has been mentioned in the article by Dr. Tapsavi. There is an article from Japan wherein suture reduction method was used. Again, suture use technique was employed. Medial lateral tunnel was created, and a tension device was used to create tension and fix the ACL fragment. Again, 3 tunnels was created. Knot through the ACL again, one has to know how to perform a sliding knot, which is not very friendly for a person who is not doing shoulder arthroscopic surgery. So one has to know the sliding knot technique to perform this procedure. Again, use of indigenous sensing device, which is not really available, was used in this case. Another method very close to the earlier one, there is a suture reduction method was used, medial and lateral tunnel was created, and manual tension was used. But in this case, all the 3 sutures were fixed on the tibia through a knotless anchor. So knots around the ACL, one problem, 3 tunnels in the tibia, making a more bone, and 3 knotless anchors were used, which is more. So knots around the ACL, this is an article from Kanpur, more bone, and 3 knotless anchors were used by sensor. One knot around the ACL, this is an article from Kanpur, more bone, and 3 knotless.
Various all inside anchors, which is usually
And it is like a double fixation used in shoulder surgeries for repairs. Again, different fixation methods have for this case, and osteoporotic cases where the anchor is anchored to the bone and dependent on the bone density. This is an article from Iran in which medial and lateral bite was taken from the ACL stump, and the tunnels are drilled. The fiber wires are taken from the tunnel. The fiber wires are taken from the tunnel and are tied upon anterior surface of tibia over button or the post. Again, the problem in this technique was the pipe was taken through the tibial tunnel and the ACL stump, thereby causing a possibility of cheese wiring and cutting through of the fiber wire through the ACL stump. So all these techniques were basically emphasizing on taking the bite through the ACL stump. off time has to be done. And so anyone who is not very wary about shoulder down time surgery sales will have difficulty in performing these procedures. This is a technique by our own Dr. Anant Joshi sir. Here, two fiber wires were not were tied around the ACL stump, and then all the four strands were taken through the single tunnel through the tibia. Now, this technique has described steps of the surgery, wherein this step 3 has a sliding Mickey knot. I am sure that a lot of people would not know what is Mickey knot. Putting a sliding knot is sometimes very tough for a person who is not to shoulder surgeries. Step 6 has reduction of the fragment. This step is very important and requires multiple maneuvers to reduce the fragment. So you are going to do a lot of suture management to reduce the fragment into the crater. So these two steps make you think that this is a procedure which is not very friendly for a person who is not in shoulder surgeries. This is another article from the Kanpur, where it bites through the anterior and the posterior of the system was taken. There was no biological procedure. Bite to the anterior and posterior half of the system was fixed over the tibia and surface over the button or a post. So all these techniques they are basically depending on the bite which is taken from the ACL stump. Now this is a study, very good study from the Japanese population, where 25 patients were divided into young and adult with acute and chronic injury, and they quantified how much is the damage to infrasubstance of the ACL stump in a scenario of ACL injury. So they said 3 out of 19 acute tibial spine fracture had ACL mid-substance injury, thereby meaning that the ACL mid-substance is not a good version mid-substance tissue, wherein you have acute tibial spine fracture. And concomitant acute ACL and mid-substance injury was seen only in adult population, not in younger population, which is less than 50 years of age. That makes 30%. So 30% means out of every 3 patients, 1 patient will have this problem of poor mid-substance tissue in scenario of ACL injury. And for chronic cases, they reported 2 out of 4. That is 50% of population having a chronic ACL injury will have a mid-substance, poor mid-substance kind of tissue. So in this scenario, one has to be careful when taking bite to the ACL tissue in a present scenario. And this study was based on this experimental study done by Noyes in 1974, wherein they suggested that it is the deformation which tells whether the weather will happen or mid-substance tear will happen. So at slow deformation rate, tibial aversion fracture happens, and in a fast deformation rate, it is the mid-substance tissue which gives way and a mid-substance tear happens. So it is not the same. You can have a picture where ACL aversion happened and patient has a poor mid-substance tissue for taking the bite. And then if you take a bite from the same tissue, it might not be a very good idea. Another thing that has to be taken into mind is last 2 years suture tapes have come up for basically shoulder surgeries. A lot of studies have studied the difference between the bias and the tape, and they have concluded that tape provided a 3-fold increase in foot contact pressure and 1.4 increase in construct strength compared to number 2 fiber suture. Also, suture tape improves construct strength and load bearing capacity and improved contact pressure and area. Keeping this in mind, this was the technique which was put forward, and it is obviously arthroscopy surgery in sports medicine, 15 step to ACL fixation, a small video. One is to assess the fracture configuration, that's the first part. One has to quantify whether it is type A, B, C or D, 1, 2, 3 or 4. Which kind of fracture is this? Also combination has to be taken into mind. The second is to clear the fragment. Once the clearance is done, the crater is deepened, especially for old cases. One has to deepen the crater to put in the fragment into the crater. Once that is done, little bit of burying of the crater is required. Again, it is only advocated in cases wherein one has to deepen the crater to put in the fragment into the crater. One cannot afford to have a prominence of bone anteriorly to cause impingement later on. Again, the fragment intersurface burying is done one has to be very, very gentle in performing this, because if you be too aggressive, you might end up damaging the bone fragment. Then step 6 is assess the fracture reducibility. One has to try to put the fragment into the crater and see for any prominence of the bone. One can fine tune the fragment if at all it is required at this stage. The fine tuning is done only to ensure that the fragment sits in the crater. It's paramount that any bony anterior prominence has not to be there. Once that is done, the preliminary fixation with KR is done. And then a medial and a lateral passage was created using 2.7 and 4.5 derivative. There's the medial passage. One should ensure that the passage of these two tunnels at the anterolateral and the anteromedial border of the crater. This bite has to be taken with the fiber tape as far posterior as possible. One should try not to violate the ACL. The bite has to be taken as far posterior as possible. The tunnel overview is done with 4.5 derivative. The long wire is passed. And both the strands of these fiber tape pass through one tunnel without putting a knot. So both strands are taken from one tunnel, and the other fiber tape is taken from the other tunnel. So because no knot is taken, you don't need to have a surgical skill of putting a knot or sliding knot, and there is no strangulation of ACL which happens if the knot is too tight. Removal of KR is done through the fiber tapes. The pressure tightening can be done. One should ensure that anteriorly there is no bony prominence causing impingement. That's how the reduction looks like once the fixation is done. So it is this kind of construct which is at the end of the procedure. It's a balanced, knotless fiber tape through fixation, and it is very cost effective. You tie the knots on any surface of tibia. That's how it looks like at the end of the procedure. So it is very important to check for anti-impingement. So that's the upper surface of the fragment and the upper surface of tingle fragment. So one should ensure that there is no prominence left after fixation of the fragment. One word of emphasizing small fragments to achieve satisfactory reduction is a good option. Here the fragment is taken off. One can also burn the lower surface of the fragment to make the fragment sit in the crater. That's a small video of suture reduction method. One can use a suture to reduce the fragment into the crater. So what is done is the fracture is visualized. A bite is taken through the ACL stump. So crater is cleared of all the medulla in the bone debris. The bite is taken using least scorpion device. This acts as a reduction suture. So now this suture will be tied in a cinch loop fashion on the ACL stump. Now a drill hole is drilled at the face of the crater. And this suture is passed through this drill hole, and this in turn reduces the fragment into the crater. One can utilize this method of reduction as an indirect method of reduction. So now when suture is being pulled and is negotiated on the anterior surface of the fragment, once you pull it, it will push the fragment into the crater. That's an indirect method of reduction called as suture lever reduction method, which was given here in Agrawal. So knot tying can cut through the ACL stump, difficult for those not into shoulder surgery, and too tight causing ACL strangulation, and reduces the contact area between implant and the bone. Fiber tape, the possibility of ACL cut through is there. 75% increased contact between implant and the fragment. More fiber tape can make a rigid fixation, and a uniformly distributed compression is there. It is a simple and reproducible technique and very cost effective. Thank you so much. I would request people to be a member of Arthroscopy Association of UP. We are running this association for the last 5 years. Ashish sir has formed this association, and anybody can contact me, Ashish sir, for being member of this association. We have 135 members in this association. Only UP. Thank you so much.
Thank you, Dr. Vinay. Now I invite Dr. Anant Joshi to enlighten us about the technique of LCL reconstruction, how he makes the surgery easy and affordable.
Sylvia. Sylvia.
Thank you very much. So, if you see evolution of reconstruction of ACL, PCL, LCL, and the municipal repair, most of these are nowadays the one structure.
Thank you very much, respected chair. So if you see the evolution of reconstruction of ACL, PCL, LCL, and the meniscal repair, most of these are nowadays tackled with the surgical approach. The one structure, which is called MCL, is mostly they are treated conservatively and surgical indications are very few. So grade 1 and grade 2 can be treated as conservative, and grade 3 has to be treated operatively. This is the standard learning. But there are expansion of indication of these MCL reconstruction. Suppose a patient who has, Stanner's lesion, that is the avulsion of MCL from the tibial side. This is indication of surgery because these patients are not going to heal because the MCL has avulsed and come out of its place, so it will not heal. Bony avulsion are another indication for surgery because we utilize the presence of bony piece for a perfect healing. Incarceration of MCL into the joint, usually this happens in the multi-ligament setting, is an indication for emergency surgery. And even if it is grade 2 or grade 3, MCL reconstruction are indicated when they are contemplated with the multi-ligament. This was a 23-year-old professional footballer who came to us. We examined, and then she had actually a grade 3 injury. So I'll show you the MRI, which has been reported as a grade 3 injury. So we actually offered her, since she being a professional footballer, we offered her a surgery. but she refused to undergo surgery. Because of her refusal, we managed conservatively to her immobilization in a knee brace for 3 weeks and then physiotherapy. You see that even that type of tear has completely healed in 3 weeks' time. So this patient was a national football player, a female, and she went to her active career even with the conservative management. So we were excited with this conservative management. Another patient, 24-year male, a professional footballer again, he came to us, had an isolated MCL injury. We thought that this was reported as a grade 2 injury. So you could see that opening a little bit. And this was reported as a grade 2 injury. We thought that if grade 3 can go back to sports, why not grade 2? So we treated that patient conservatively, and he comes to us after 3 months, and you see that what he was demonstrating, this was demonstrating active opening of his medial side, which is similar to the case which was shown by Dr. Anant Joshi sir. So the difference between these two cases are the valgoid knee. So the first case was a lady, she had a varus knee. This gentleman has a little bit of valgoid knee. So valgoid knee are very poorly tolerated, the MCL tear, even grade 2, grade 3 are very poorly tolerated. So what does this two case explains us that you have to have an individualized approach rather than saying that grade 1 and grade 2 heal, grade 3 requires surgery. Rather than that, probably you have to look into the various other aspects of MCL injury as well. As far as the early intervention versus delayed, most of the time it is delayed unless it is associated with multi-ligament injury. So MCL is delayed for 3 weeks. But if MCL doesn't heal in 3 weeks, then we lose an option of repairing or augmenting. So any MCL injury which you treat after 3 weeks, probably you are going ahead with reconstruction. But there is a chance of repair and augmentation. Here I very often use a tape or internal bracing system to augment the MCL repair. That is possible within 3 weeks' time. Surgical options, there are various surgical options based upon the time the patient present to us. But we are talking about the reconstruction. Reconstruction of MCL provides the best predictive outcome. There are various methods that is described in literature. Here the picture shows the single bundle, the double bundle, which is basically the other technique that I'm going to talk about, and the Laprad's technique, which is we are going to discuss. The Laprad has described the anatomic reconstruction, and then they have reported of various biomechanical advantages. But remember, Laprad's technique requires 4 tunnels, 2 in the femur, 2 in the tibia, 4 implants. So that means it will add to the cost. And if you are talking about in association with multi-ligament, especially TCL, there is a chances of tunnel coalition. And while fixing into the distal part, with the interference screw, there is a chance of, the graft cutout. The tunnel coalition was a real problem, and it has been acknowledged by the same group of people who developed this anatomical, and they have given an extended, chapter on how to avoid the tunnel coalition. So tunnel coalition is a real problem. Now we are talking about tunnel coalition in the American people who are very big. Their size of condyle is also big. But if you go to the literature, which talk about the size of the femoral condyle, so this is one of the study which was published in 2016, says that probably the femoral condyle of our people or the shorter people are smaller in size. So if the femoral condyle is smaller inside, having so much of tunnel and 2 separate tunnel from MCL is not very reasonable. This is another paper which say that probably in Asian population, the size of the femoral condyle is smaller. So one size doesn't fit. So if femoral condyle of very big person will not be same.
Thank you.
Sorry, sir. I request that the lunge should be now wound up Please wind up the lunch, and please do not, all the people who are having a lunch, please do it quietly. Don't disturb. There's a lot of sound. And I request the hotel authorities to wind up the lunch now. Thank you. Sorry for the interruption, sir. Please go ahead, sir.
Thank you very much. So one size doesn't fit. So whatever surgical technique is described in probably a bigger size people may not be feasible to the size of people which are smaller. So my initial technique was Kim's technique, so which is essentially using the semi-tendinosus graft, looped it, fixed into the femoral side and brought it down to reconstruct the POL. But the problem with this type of technique is it is non-anatomical. So I'll show you in my next slide, which shows that probably your starting of the superficial MCL is too much anterior because semi-T is anterior to the attachment of the MCL. So that is how we came with a modification of Kim's technique and developed our weave technique so that to replicate the superficial MCL as well as the PO. So what we do in our technique, it has 4 different steps. In step 1, we harvest the graft with an open tendon stripper, keeping the tibial attachment intact. If you see in picture 1, the red shows that the graft is harvested and it is, so tibial attachment is intact. Then you make an incision into the remnant of the superficial MCL. So this is a subperiosteal tunnel. So make a subperiosteal tunnel and pass your graft through that subperiosteal tunnel. Put some stitches into that split of the remnant of superficial MCL. Then you take it up, find out the isometric point, fix into the femur into the isometric point. Then your remaining graft has to come down, and just behind the semimembranosus there is attachment of the POL. You fix that and the POL. So what this technique does is it uses only hamstring graft, one hamstring graft, which is sufficient to do an anatomic reconstruction, unlike Laprat's technique in which you need 2 grafts, a bigger size graft, probably you have to use an allograft for that one. And with just 1 tunnel in the femur, this can be done, and 1 tunnel in the tibia for the POL fixation. So this was a 34-year-old gentleman. I'll not go into detail of this technique because this is freely available in Arthroscopy Technique Journal. So this is a 34-year-old gentleman, had ACL with MCL. 10 weeks after injury, you could see that his Lachman test was positive. His valgus was positive. So I'll not go into the details of ACL. So this was his MCL, and without even pie crusting, it was opening a big opening. So we decided to do an MCL weave technique. So this is harvest and then pass it on. I'll not go into detail of this technique because again it is freely available. But what I wanted to show you that intraoperatively, even with the valgus applied, with so much of anesthesia and relaxation, you can see that the joint is completely restored and the opening is completely restored. This is another case in which you can see both the sides. One is pre-op and the other one is post-op. To your left is pre-op and this one is post-op. You could see that the joint opening is completely restored after doing the weave technique. Another case, similarly, you can see the joint opening has been nicely restored after the weave technique. So to conclude, probably when we talk about MCL, and the current literature is saying that gone those days when we used to, blanketly say that MCL can be managed conservatively. It has to be individualized. Associated injury has to be taken into consideration. The alignment of the joint has to be taken into consideration. If someone who is having a valgus knee, even grade 2 tear is very poorly tolerated by these patients. Early, if you can identify this tear early, probably repair is a possibility, and then you have to augment so that you can start early range of motion. One of the commonest complications of MCL repair or reconstruction is stiffness. So early range of motion has to be given to these patients. Delayed, if you get a delayed MCL, medial collateral ligament injury, reconstruction is the only option. There are various techniques in literature. The choice has to be, made considering many factors. Where are you working? What is the size of the femur? and how you are going to fix it. With this, I'd like to thank everyone, the people from Kanpur for excellent hospitality and having me here, and request you to be in Nepal anytime and whenever you want. Thank you very much, sir. Thank you, sir.
Thank you, Dr. Anant Joshi, for a wonderful presentation of MCL repair. The next lecture will be an online lecture by Dr. Sachin Tapsavi, who will be speaking on all about MCL repair. Again, when and how. So we will have various aspects of the same problem. One by Dr. Anant Joshi, second by Dr. Amit Joshi, and third by Dr. Sachin Tapsavi. So we'll wait for the online lecture by Dr. Sachin Tapsavi.
Yeah. So thank you so much, and I'll be presenting on MCL repair. So it's going to be a repetition of topics since all of them were concentrating on the medial side.
आवाज नहीं आ रही है यहाँ पर आपकी? डॉक्टर सचिन, आपकी आवाज इधर नहीं आ रही.
I don't know. I can hear you very well. Hello. Can you hear me?
Hello. Dr. Sachin.
Yes. Am I audible?
हाँ, अब आ रही. Yes.
Okay. So there's going to be a repetition essentially because we had 3 topics talking about the same problem, which is the MCL. And the MCL, as we all are aware, is a structure on the medial side. We have the superficial, we have the deep MCL, and the POL, and they're all present between layers 1, 2, and 3 on the medial side. What is also interesting to understand is that these structures, which are extremely important, play a very important role in stabilization of both the ACL and the PCL. So what I'm showing here from green to green is the superficial MCL, that's the insertion 6 centimeters below the joint line, as you can see there, and then the insertion is posterior and proximal to that of the medial epicondyle. White is the adductor tubercle, and the insertion of the superficial MCL is in between the medial epicondyle and the adductor tubercle. The structure that I'm picking up now is the middle head of the gastrocnemius, which attaches to the gastrotubercle, and the condensation of the deep fascia and the semimembranosus is the POL ligament, which inserts in around where the semimembranosus inserts and to the area which is just near the gastrocnemius tubercle. So this is your POL, which is extremely important. It tightens as your knee goes into extension, it becomes lax as your knee goes into flexion, and it is important to understand this structure that needs to be repaired or reconstructed whenever we do surgery for medial instability. So what we have here is a complex two ligament structure. You have the MCL, the superficial MCL, as well as the POL, both of them which are essentially important. The third structure on the medial side is the MPFL, which inserts in the crater between the adductor tubercle, which is right here, and the medial epicondyle, and then courses medially to the supramendial aspect of the patella, thereby allowing stability for the patella in the first 30 degrees of inflection. So your superficial MCL is your medial restraint inflection, and your secondary restraint anterior tibial translation. Your POL is the medial restraint and extension, which needs to be kept in mind at all times. And these are the structures that you need to look out for and you need to reconstruct or repair when you have an injury. The mechanism is a valgus overload type of injury, usually with the foot rotated externally and firmly planted on the ground, which is why you have a concomitant ACL injury at the same time as well. MCL injuries are quite common. So Andy Williams published last year, they took 100 patients who underwent ACL surgery, and almost 2/3 of them had some form of injury to the medial complex. Of these, 2/3 were introduced to superficial MCL, 30% were deep MCL, and 10% were with the posterior oblique ligament, thereby suggesting that we tend to overlook a lot of these problems. Deep MCL lesions like these should not be taken lightly because they are associated with a lot of rank lesions, and they may also indicate subclinical superficial MCL lesions. If you fail to treat them or repair them, there is a high chance that that patient may land up with anterior rotator instability, and then that will lead to failure of your ACL reconstruction. Another very good publication that came from Alberto Grassi's group, which was published this year, looked at almost about 20,000 patients who underwent ACL revision in the Swedish National Knee Ligament Registry. So what is important to understand is that the risk of revision of your ACL reconstruction is the same if you have had a concomitant ACL and MCL reconstructed. But if your MCL is treated non-operatively, then you have a significantly higher risk of getting your ACL revised. So which means that don't overlook an MCL injury that requires surgical treatment. So MCL injuries essentially can be classified into 5 different types depending upon the location, the clinical findings, as well as the MRI findings, and I find this classification to be very useful because it allows us to understand what sort of treatment plan should be followed in all these patients. All grade 1 and most grade 2 can be treated non-surgically, but some grade 2 and all grade 3 probably should require surgical management. Stress X-rays and MR scans are really important because non-operative treatment will consist of giving restricted progressive range of motion for 6 weeks. If you have a varus aligned knee, then you can allow them free weight bearing. If it is a valgus aligned knee, then you should allow them partial weight bearing and you should brace them for 3 to 6 weeks. An acute pedal repair is offered when there is extensive pedal disruption. When you have a displaced middle meniscus tear, you have a stellar lesion, or when you have a poniavulsion. So, irreducible knee in which the whole medial side is pulled inside the intra-articular aspect is usually pathognomic of a lateral or an anterolateral rotator dislocation. In this, the medial femoral condyle perforates the capsule, and in these patients, urgent open reduction is extremely important. The stellar lesion was described by Christian Holzer and Christian Fink along with Johann Belminens, and they observed that a stellar lesion needs to be picked up very quickly and efficiently because if the superficial MCL goes superficial to the pes, unlike where it should be underneath the pes, it will never stick back, as you see in this MR scan image, and these are the ones that need to be treated rapidly and correctly with surgical reconstruction or surgical repair depending upon the time when you get these lesions. How to repair them? Pretty simple. Dissect, pull up the pes, feed the torn superficial MCL underneath the pes and reattach it with whatever sutures that you may feel to do so. This is one such example of a stellar lesion repair. So we have here this lady who has a 1-day-old AD3M. She's got an ACL, a PCL and a grade 3 MCL. Looking at the status of the knee and the extensive bruising, we decided to do a 2-stage approach for her, in which stage 1 was planned to fix the MCL side and stage 2 was to reconstruct the ACL and the PCL. These are our stress X-rays showing gapping which is more than 4.8 millimeters compared to the opposite side, and you can see that there is complete disruption and the injury is predominantly tibial based. So a large exposure, very important. You should not you should try and have a flap which is thick and deep. Do not raise small flaps of skin and soft tissue. The incision should be large enough to expose from the medial epicondyle to the distalmost insertion onto the proximal tibia, and then you go ahead and repair and dissect layer wise. So you first start with layer 3 which is the meniscofemoral and the meniscotibial ligaments. As you see here, this is a tibial sided injury with the deep MCL pulled off from the tibial side. You can see the medial meniscus, which is there. The medial meniscus is then reduced. Couple of this is how the medial meniscus which was torn. That's a superficial MCL flap, and you can see the undersurface of the medial meniscus right there. So couple of 0.5 millimeter anchors on the rim of the tibia, and then the first step is to repair layer 3. After you finish layer 3 and the meniscus, you then go to layer 2, which consists of the superficial MCL and the capsule. So these are whip stitches taken in the superficial MCL. We have a 5 millimeter anchor at the insertion site of the SMCL, ready to take the superficial MCL and get it repaired exactly in its bed. So that is step 2, and then we close the capsule, which is layer 1, and the MDFL, which is layer 2 and 3, and that completes our medial sided repair. Stannard, way back about 10 years ago, did publish that if you do not augment your repair with some form of a reconstruction, then you have a higher risk of failure, which is why it's always a very good idea to back up your repair with an augmentation. This can either be in the form of using artificial tapes or by using some form of autograft. Again, Lampard published this year in the AJSM, where he looked at a prospective multicenter randomized trial where they had superficial MCL with or minus ACL with a keyhole intact, and they found no differences in any form of the objective outcomes. What do we need to look at here is to understand that we need to repair, and which is why I use a modification where I harvest the 70. I do a staple tenodesis to the medial side and then bring it down to the POL. It's always important to get the POL also sorted out, because failure to do so may result in your whole repair failing, which is why we need to have this. Again, looking at the structures on the medial side, here is an acute MCL tear, large decent exposure, go right in. This is what you want to expose. Put in a couple of sutures, harvest and keep the 70 ready. And once you're done with your repair, you want to lose your 70 and bring it back to itself in this particular fashion to get it repaired in the POL area, and thereby create a modified lid type of augmentation to your MCL repair, which is also very extremely important. If you have bony avulsions, that makes your life simple. This is one example of a medial bony avulsion which was fixed with PAP staples, and the whole thing did not require any further treatment. It's important to understand that you should repair your ligaments properly. This is one example who came to me for redo surgery, when the surgeon attempted to take some sutures and used some screw and some staple, but of course this failed and this required a conventional in-place reconstruction type of procedure. So early operative treatment will always have better outcomes when you compare them with non-operative or delayed surgery. Reconstruction is important. We published this year in the ESCA journal our series of 34 patients which were followed up for a minimum of 50 months or so, and we showed that when we do proper reconstruction along with the same, we have improvement in the valgus express x-rays as well as the IPDC scores. So I think, is that all that you need to know? No, there's a lot more that all you need to understand, and I'm going to invite you to come and join us in 2 weeks from now for our Pune course. We are already about, we have 900 registered delegates with us. It's going to be a big event going over 3 days, and we have Professor David Dujour who will demonstrate things like trochleoplasties, will show meniscus transplants, and I look forward to welcome you then. Thank you so much for your attention.
We have not much of time left because we are already running late. Any questions?
Thank you very much, Dr. Sachin Tapsavi, for an excellent lecture on repair of medial collateral ligament and the posterior oblique ligament. I'm really afraid we have not much of time left because we are already running late. Any questions?
Thank you. Thank you so much for your kind
You
attention.
can have one or two questions. Dr. Amit Agrawal has been very kind enough to permit two to three questions from the audience. If there are no questions, we will close this session.
Thank you. Thank you so much for your kind attention. And your
Thank you, Dr.
patience.
Sachin.
Thank you.
Thank you, sir. Now I request Dr. Amit Agrawal, sir, please come on the desk and felicitate our chairpersons. Dr. Santosh Rajpal, sir.
Dr. Rajpal sir, who is the senior person of Kanpur Orthopedic Association, was awarded the Lifetime Achievement Award on a few weeks ago. So for us, congratulations, sir. He is 80 plus young orthopedicians of the town. Thank you, sir, for your respect.
डॉक्टर राजेंद्र सर को नहीं पता है सर फ्रॉम द सेम स्टेज डॉक्टर राजपाल सर हु इज द मोस्ट सीनियर पर्सन ऑफ कानपुर ऑर्थोपेडिक एसोसिएशन was awarded the lifetime achievement award on a few months before. So once again congratulations sir. He is 80 plus young orthopedic surgeon of the town. Thank you sir for your spirit.
Dr. Rajendra sir.
Other than the subject knowledge, we are only contributor. Either maybe the poems, rhymes, or the subject knowledge.
Professor Rajendra साहब has got very sweet. इतना अच्छा गाते हैं, इतना अच्छा उनका गला है. And all orthopedic meetings is preceded by his rhymes. तो और उनकी संस्कृत की knowledge बहुत अच्छी है सर. Other than the subject knowledge, so he is always a contributor. Either maybe the poems, rhymes, or the subject knowledge. And he has been a teacher. It is my proud privilege, sir. Thank you so much.
Dr. Pankaj Tandon, sir.
Thank you, sir. Thank you. So we have the workshop now. Before that, we have a small session of felicitation of all the
जो भी सर हम लोगों ने नाश्ता खाना खाया है सब डॉक्टर पंकज की वजह से खाया है. Thank you sir for taking care of us. 3 cheers to Dr. Pankaj Tandon. Hip hip hooray. Thank you sir.
Thank you. So we have the workshop now. Before that, we have a small session of felicitation of all the Honorable President and the organizing secretary and the whole organizing team has decided to felicitate our organizing team for this Kanpur Arthroscopy course. So for that, I would request our Honorable President, Dr. Ashish Kumar sir, please come on the dais. I'll request Dr. Binay Pandey sir, please come on the dais.
Dr. Ramji Khanna sir, please.
I'll request Dr. Anant Joshi sir, please come on the dais.
Dr. Ramji Khanna,
Anant Joshi sir, please come on the dais.
I request you please come forward.
Dr. Ramji Khanna sir, please.
Come on.
Dr. Ramji Khanna, Dr. Puskar Anand sir. I request you please come forward fast. Dr. V.S. Sharma sir, please come on the desk.
Dr. Anil Sugla sir. Dr. Dutch Gadi.
मल्टी वाला नहीं था थोड़ी जगह चाहिए एक ही बोर्ड है.
Dr. Anil Sugla sir.
बोर्ड भी नहीं लाइट वाले कौन होंगे आप?
Dr. Dutch Gadi.
Dr. Manav Rudra.
डॉक्टर पवन गुप्ता सर।
डॉक्टर गौरव गुप्ता।
डॉक्टर मानो लूथरा सर। डॉक्टर गौरव गुप्ता।
डॉक्टर रोहित नाथ। डॉक्टर रोहित नाथ। डॉक्टर निर्भय सक्सेना सर। डॉक्टर निर्भय सक्सेना।
डॉक्टर रोहित नाथ सर। डॉक्टर रोहित नाथ।
डॉक्टर टीपीएस लांबा सर।
डॉक्टर रोहित नाथ।
डॉक्टर लांबा सर।
डॉक्टर निर्भय सक्सेना सर। डॉक्टर निर्भय सक्सेना।
डॉक्टर विजय गुप्ता।
डॉक्टर टीपीएस लांबा सर। डॉक्टर लांबा सर।
डॉक्टर विशाल अग्रवाल।
डॉक्टर विनय गुप्ता।
डॉक्टर अजीत तिवारी।
डॉक्टर विशाल अग्रवाल सर।
I want extra some special clap for these two guys, Dr. Ajit and Dr. Vishal. Sir,
Dr. Ajit Tiwari.
Dr. Vinay. Sir, इन लोगों के लिए जबरदस्त है। Dr. Vinay.
Sir, I want extra, like some special claps for these two guys, Dr. Ajit and Dr. Vishal. Sir, Dr. Daksh also. Where is Dr. Daksh? And Dr. Vinay. सर आ जाइए, चारों लोग आ जाइए आगे, प्लीज आइए। इन लोगों के लिए जबरदस्त ताली है। डॉक्टर विनय। And I request everyone to please join for a photograph with faculty. Sir, faculty, Dr. Amit, Dr. Vinay, Dr. Ashish सर आगे आ जाइए।
भैया वही है, वो किसके सामने लेके आया तब तक लगा रहा है। पीछे नहीं।
यही बताइए, आवाज आ रही है? क्या चलाना, क्या चलाना, क्या चलाना, क्या चलाना, क्या चलाना, क्या चलाना, हाँ बल्कि एक घंटे में फ्री हो जाए, 1 घंटा देखिए वो आप वहाँ से कितनी देर में आ जाएगा, क्या लेके आ रहे हैं। आज काम आज ही का है क्या? भैया एक बात बताइए, वही बगल में हमारे यहाँ से 120 किलोमीटर है।
थैंक यू कांधे से कांधा मिला के चलने वाली टीम। और इनको देख के वही याद आता है कि हेलो मैं अकेला ही चला था, जाने में मंजिल मिल गए, लोग रात मिलते गए और कारनामा बन गया। थैंक यू सो मच, थैंक यू सो मच, थैंक यू सर।
And please do not go because
थैंक यू। कंधे से कंधा मिला के चलने वाली टीम,
this is going to take some time.
और इनको देख के बस वही याद आता है कि हेलो, मैं अकेला ही चला था जानवे मंजिल मगर लोग आ मिलते गए और कारवां बन गया। थैंक यू सो मच, थैंक यू सो मच,
One demonstration will be done over here.
थैंक यू सर। And please do not go because we are starting the workshop. This is going to take some time because everything is to be arranged on the table. But this is the most important part of the course. So please do not go and take participation in the workshop. As we have already said, one demonstration will be done over here, focused by the camera, delivered on the screen. We all will see that demonstration and then we'll follow the same. You have number on your badge, 1, 2, 3, 4. You can go to the corresponding table. Every table has got number. You see the number on the table, 1, 2, 3, 4, 5. So you join your table seeing your card number. Please go to your table, 1, 2, 3, 4. Please join your table. And I'll request Dr. Vinay Pandey to please take over to the central table, and organizers to please arrange the central table here. Dr. Chandan, क्या टेबल लगवाओ एक
And another request is on the central table where the demonstration will occur, please do not gather. Only the table instructor, Dr. Vinay Pandey will be there and one of his helpers. Rest, we all will remain away from that table.
And another request is on the central table where the demonstration will occur, please do not gather. Only the table instructor, Dr. Vinay Pandey, will be there and one of his helpers. Rest, we all will remain away from that table.
Hello, hello.
Hello.
जाओ लेके आओ
भैया को
पेन ड्राइव ले आओ दो डाइल ले आओ पेन ड्राइव सॉरी पॉइंटर लाइट लाइट
हेलो And by the time the tables are being arranged, there are 3 lucky draws. So I would request our faculty, Dr. Amit Mishra, and President Dr. Ashish, if he here, please draw the lucky draw and find who is the most lucky person. Mr. Anup Har Singh, team, please bring that box.
And by the time the tables are being arranged, there are 3 lucky draw.
With the gifts.
So I would request our faculty, Dr. Amit Mishra, and President Dr. Ashish, if he here, please draw those lucky draw and find who is the most lucky person. Mr. Anup Har Singh, team, please bring that box, magic box, with the gifts. I request Mrs. Joshi. No, this is Mrs. Joshi's job because she has also to contribute something. Aye, Mrs. Joshi, please. Mrs. Joshi, I request for.
Hello. We are going to start with this demonstration. Everybody ready?
Before you start, Dr. Vinay, I would request once again to all delegates to be on their tables, not here.
So everybody has to sit from there. What we do here.
Dr. Vinay, lucky draw तब तक वो वहाँ पहुँचे, तब तक ये lucky draw हो जाएगा.
अच्छा चलेगा.
If crowd is here, then no fun. आइए, Mrs. Joshi.
Rawat from Regency Hospital. Is he here?
78 JF 3409 GF 3409 जिनकी गाड़ी हो प्लीज हटा दे.
So the first lucky draw goes to
Dr. Ajit Rawat.
Dr. Ajit Rawat from Regency Hospital. Is he here? Otherwise, this will go to the second person. If person is not here, the prize will go to the next draw. किसने? अजीत रावत. चलिए, क्या बात है. आइए. Clapping for our very dear Ajit. आइए.
अरे बस.
Now the second lucky draw. Let's see.
मैच फिक्सिंग हो चुकी है.
After the
आप ही गए.
number 88.
Dr. Vinay Gupta.
Sing team, please to be on the photograph.
Dr. Vinay Gupta. Wow.
Now the second lucky draw. Let's see. After the sixth, number 88.
Dr. Vinay Gupta.
Dr. Vinay Gupta. Wow.
Dr. Shivam Chauhan, is he here? Oh, great.
अब तो पक्का फिक्सिंग है.
Fixing थी है वाकई में. Nice. Thank you, Dr. Shivam.
And one more.
Thank you, Mr. Joshi. So once again, the moment our delegates will go to their customers, we will be starting.
Dr. Shivam Chauhan is here. Oh, great. अभी इसका मतलब फिक्सिंग थी नहीं वाकई में. Nice. Thank you, Dr. Shivam. Thank you, Mrs. Joshi.
यूपी का रहना चाहिए.
So So once again, the moment our delegates will go to their corresponding table, we'll start here. I request all the delegates, please go to their corresponding table. Your number is there in the number, nahi sir isme?
So this is gracilis hamstring. So suppose we have two graphs like this.
जैसे
So one is gracilis.
कुछ तो यूपी का सर रहना चाहिए.
We take both the graphs out.
So
and we hold it with
first is to
like this.
graph time. Jeevan. So ethibond.
Now we start tying with ethibond.
So this is gracilis hamstring. So suppose there are two graphs like this. So one is gracilis and one is hamstring. So we take both the graphs out and we hold it with LS like this. So आपने इसको hold कर लिया दोनों को. Both tendons are there. Correct? Now you start tying with ethibond. So end has to be tied. So this is called a whip stitching of the tendons together. So you take a bite like this. इसको closing करना. Closing. दो एक साथ कर रहे हैं. So we are going to make 4-strand ACL reconstruction. So ultimately this is gracilis, this is extremity. Once we fold it like this becomes 4-strand. Correct? So after stitching we will make it 4-strand. So this is 2-strand. Correct? So closing. Okay. So how do we make it? So we go like this. Come from down. Okay. Correct? Number 2 and number 5. You can tie either number 2 or this is number 2. Can anybody show? This is number 2 at the bond. Correct? Number 2 and number 5, 2 are there. So we are trying with number 2 at the bond. This is number 2 at the bond. This is like this. Number 2 at the bond. Correct. So we start tying the knot. So we go like this and then we come up like this. And then again we go from down to up like this. इसको आप ऐसे कर लेंगे तो वहाँ दिखेगा like this. Can I show? This is the configuration that we are getting. Show this. Again we go from there and like this. This is whip stitching. इसको पकड़ सकते हैं. Hold it.
And can I request all the demonstrators,
So
Dr.
again,
Chandan, Dr. Gaurav, Dr. Daksh to be on their demonstration table.
So that
Dr.
is how
Chandan,
we are whip stitching the
Dr.
ends of the
Gaurav,
tendon
Dr.
together.
Nirbhay, please be on your demonstration table.
Correct?
Dr. Gaurav.
So now we have taken 4 to 5 whip stitches. Come from that side. And then you go down again from up to down like this. It is always good to take symmetrical bites so that to damage the tendon less and less. Can you see this configuration is coming there like this? Correct. So that is how we are whip stitching the tendon ends. So at the end of whip stitching, this is how the tendon looks like. Correct? We have stitched the end of tendons together. Similarly on this side, इसको कर लेते हैं ना? We are इसे पकड़ ले इसको. Then एक और ethibond देना. Again, we will do the same maneuver here also. Again, focus there. Focus. So again we go like this, top to bottom.
So again 4 bites. You can go to 5th bite as well. 4th bite is good.
That's how you get maximum tensile strength in the suture configuration. So both ends we are tying together. So this is how you prepare your So again 4 bites. You can go to 5th bite as well, but 4 bite is good enough.
So we are at the end of the tendon preparation. So now,
So you want to make this configuration symmetrical. So symmetrical configuration will have maximum
more strength as compared to native AC.
cutout strength.
So it is always 4, 5, 6. And the other thing is, we have to make this.
So we are at the end of the tendon preparation.
So not as the size 8 is.
So now, because 4-strand ACL has similar strength or more or less more strength as compared to native ACL. So it is always 4, 5, 6. And the other thing is, we have to make this, the stand, minimum size 8. Size 8 means what? I'll let you know. So not less than size 8 is required. So again, this is how we have. Can you see? Once this is done, needle cut. Needle cut. So now this is done, and this is how a tendon looks like. And once this is done, you can pull tendon so that you can take out the shrinks in the tendon. So once this is done, you will size the tendon. So sizing is done. Ek dhaga le le. Pass in a thread like this. This is how you're going to size the tendon. So you make it 4-fold. Now this is 1 strand, 2 strand, 3 strand, and 4 strand. And that is how you size your tendon. There is a sizer which comes with implant companies like this. This is sizer. So you put in a sizer and try to pass the tendon through. This size 8. It is written 8, 8.5, 9, 9.5. Correct? So if it goes through this, this is 8. Suppose you want to take it, minimum weight is kitna? Suppose you want to take it from, this is 5. So it is going from 5. Okay, suppose you want to go take it from 3, for example, 3.5. It is not going. So minimum you want this tendon to be 8. Currently we can say it is 6. 6. You can say 6. So you have to make this tendon minimum 8. So right now this is 6 because this is like this. Otherwise it is, you have to make it 8. Make it 5 tail, 6 tail. There are different methods of making it. So size you should get minimum 8, not less than 8. So initially we used to use size 7 also, but now studies have come up which show that less than size 8, the graft failure rate is very high. So this thickness of the graft should be minimum 8. Correct? So once this is made up, you keep the graft, and then you will start the preparation of the tunnel of the femur and the tibia. First is graft harvest and graft preparation. Preparation of graft is like this. If you are trying to make a 4-tail graft like this, and 4-tail ACL reconstruction has a more strength, grafted ACL has more strength than the native ACL. That is how. So once you start with this, first is we will remove this so that we can see the notch. इसको आपको इधर से लाना पड़ेगा ऐसे. Then only you will be able to see. इसको हटा देना. So that is how we are going to see. This is femur, tibia, this is left side. Correct? यहाँ focus करना यहाँ. And zoom in little bit. ये और ऊपर जाएगा क्या आपका? Here has to come like this. ऐसे आना है इसको. ऐसे आना पड़ेगा. तब दिखेगा यहाँ पे. Make it go up. Focus like this. So first is preparation of femoral tunnel. Okay, great. So ACL goes from the tibial footprint to the ACL footprint. This is lateral side of femur. That is the medial side of femur. This is lateral. This is medial. So the medial wall of lateral femoral condyle. This is the lateral femoral condyle, and that's the medial wall. This wall is the medial wall. So somewhere on the medial wall is the attachment of, this is the medial wall. See there. That's the lateral femoral condyle, that's the medial femoral condyle. So on the lateral femoral condyle, medial wall, somewhere back is the attachment of ACL. वो कहाँ गया? हटा दिया क्या तूने वो? एक अपना जो खुला हुआ था ये मंगा देना उसको दिखाने में आसानी होगी. So somewhere there. So where is the attachment? We'll show with it. उसको देखेंगे दूसरे पे. वो देना ना इधर.
So we are looking at like this, correct? We remove this, we can't see that. So see that from there.
So step 1 is graft harvest and graft replacement. So on this model, you will try to understand where is the attachment of. So see back portion. So this is like this. This is the attachment of. It is far posterior. So we are looking at like this, correct? We remove this. We can't see back. So see back from there. That's the condyle. So there is the attachment of. That's the attachment of ACL. Correct? So if we go more precise, if we take this off, so where is the attachment of ACL is, there is a ridge which is called as bifurcate ridge. Pen dena jara mujhe, pen hai kya? Marker pen. So there is a bifurcate ridge like this. Marker pen nahi. Great. So there is a bifurcate ridge like this, and there is a ridge. This divides the two bundles. One bundle is here, the other bundle is here. Can you even see? So one bundle is there. So this is bifurcate ridge, lateral intercondylar ridge. This is lateral intercondylar ridge, and so whole is the stump of ACL footprint. That's how you define ACL footprint. We are seeing from behind. That's lateral intercondylar ridge. That's the bifurcate ridge. On top is anteromedial bundle. The bottom is posterolateral bundle. This is posterolateral bundle. That's the anteromedial bundle. That's bifurcate ridge, and that's intercondylar ridge. So one has to reach from front to this portion. So you can't see from there. Correct? So as you bend knee more and more, this comes in picture. So if I bend knee like this, it comes in picture. If I straighten the knee, it goes back and behind. So जब भी femoral drilling करते हैं, we have to bend knee to 100, 110 because we want to make this come in picture. Correct, like this. So knee is bent like this. So just keep this picture in mind. We have different offsets. Offset this offset. This offset, एक guide wire देना, is meant to put it on the back of the femur, and when you put a guide pin, it exits somewhere in front of that portion. So this distance is marked on every guide pin. Like this distance is, in this case, is 7 millimeter offset. So this is 7 millimeter. That's distance between these two is 7 millimeter. Where it is written there. Here it is written. So that's 7 millimeter offset. Similarly, we have 5 millimeter offset, 6 millimeter offset, 7 Depending on what is the size of graft, you want 6, 7 or 8 millimeter offset. So here we will go with 6 millimeters offset, 7, 6 there. 6 millimeter offset we will use. So you want to make this graft far posterior. So we are talking about isometric point. On the tibial side, the attachment of graft is about 14 millimeters. It is a huge attachment. So we want to go to the center of the attachment there, but we try to be on the anteromedial bundle side, not the posterolateral bundle side. Whenever we are reconstructing the ACL single bundle, we try to be on the anteromedial side. So how do we do it? We pass in this guide pin through the anteromedial port and go behind the femur like this. This will go like this and go and attach like this. Zoom in here. Okay. So we make this go like this and go to the back portion of femoral condyle. So it lodges in the back portion of femoral condyle. And when you drill, you are 7 millimeter anterior to it. So when you put in a guide wire, so when you are going to put the guide wire, this guide wire will be 7 millimeter anterior to the desired position of
So this is how you fix your guide. That's the part of the keyhole.
So you will be 7 millimeter anterior to where you want to be, correct? So from in this, you bend the knee accurately because you want to bring this posterior condyle into picture. So you make it go like behind and put it there. So this is how you fix your guide pin. This is posterior part of the femur. And now you start drilling. Drill karna is pe.
So once this is done, you remove the.
So once you start drilling,
this 5, 6, 7 we decided by the graph which we have. Either 8 graph, 9 graph, 10 graph. The thicker the graph, the bigger the offset.
it exits to the lateral femoral condyle.
The tunnel will be part of.
So once this is done, you remove the guide pin. Your job is done because you have marked the femoral attachment site. This 5, 6, 7 is decided by the graph which we have. Either 8 graph, 9 graph, 10 graph. The thicker the graph, the bigger the offset. Because the thicker graph, if the offset is small, the tunnel will be far posterior. It can blow out posteriorly also. Once this is done, you will drill it with 4.5 or 5 millimeter drill bit.
Now we take the depth gauge. So once you are there, you want to know what is the length of the tunnel. Again, you will push it in.
Done.
And once you exit out, and you will mark the tunnel there. That portion.
So you will exit through the femoral cortex and take everything out. Now you will take a depth gauge. So once you have drilled, you want to know what is the length of the tunnel. Again, you will push it in, and once it exits out, and you will mark the tunnel there on that portion. Zoom in. So you have marking there. I think it should be. This usually comes about 35. In most of the cases, you will get tunnel size of 35.
Very big. 45, 60, that means you will have bungee effect.
In this we have 40 tunnels. Tunnel is 40 here because of course this is a specimen. So normally if your tunnel is good, you will be somewhere around 35. 35, 36, 34 is a good tunnel size. 40 is okay, acceptable. 45 not acceptable. 50 absolutely not acceptable. If your tunnel length is very big, 45, 50, 55, 60, that means you will have bungee effect. Now what is bungee effect? Suppose you have a tunnel length which is 50. So your loop is going to be big. So your button is going to be there and loop is going to be big. The more the loop is big, you have this bungee effect, windshield wiper effect, or the bungee effect. What happens? Because there can be movement of graft in the tunnel starts widening. More is the loop size, more is the bungee effect, and more is the windshield wiper effect, wherein the tunnel is going to enlarge. So that's not a good sense. So you have to stay close to 30, 35, 40 tunnel. The more the tunnel is bigger, it is the problem. The shorter tunnel, the problem is with loop only. So what So we are planning to take a loop of 15, which is the shortest loop available with the implant, not less than 15 loop we have. So the minimum loop size that we can take is 15. They don't have loop size less than 15. So because the tunnel was 40 and we want a loop size of 15, we have to drill tunnel up to 35. Now how do we calculate this? That I'll tell you once we are off this. So what we are going to do is,
So this measurement is based on how much exercise we get and how much loop that we are taking. So we have planned 15 loop buttons.
So he has drilled till 35. All these have markings on it. All these drill bits have marking on it. So this measurement is based on how much the tunnel size that we get and how much loop that we are taking. So we have planned 15 loop button. So that's the loop length is 15. This length is 15. So we have to accommodate 15 mm. So 1.5. So 20, 25, 30, 35. That is how that loop gone. So 15 is because you want this loop to be short. This is going to hold the cortex. This is the loop, and the graft is going to become a graft there. Graft is going to pass through this. This is the construct.
Because the more the plate is going to widen, correct? You want this. So template this loop is the place more.
Yeah, 15 is best because you want this loop to be less. That is how the graft is going to sit like this. So if this loop is bigger, suppose this loop is bigger, then this graft will keep on having this play. Because the more is the play, the tunnel is going to widen. Correct? You want this play. So heavier this loop is, the play is more. That is why you want to keep this loop as small as possible. That is why 15 is the least that you can take. So once you have this, you have drilled the tunnel of the femur, then you come to, then you pass in the thread. So you have taken the thread. This is fixed loop, yeah. ये बना हुआ है. This is packed. They have opened it. This, you will get it. This you will get this like this. ये packed ऐसा आएगा. ये ऐसे बंधा रखा रहता है. You open it up and make it like this. That is, this is 15 is the smallest size. If you don't get the size less than this. Button size is either 1.2, 1.4. Different companies have different size. This is 1.4, I think, size. Indoors buttons here, Smith & Nephew has 1.2 size. They have 1.4. Different companies have different size. So when you are taking this out, you will keep the loop on that side and pass the thread like this. Correct? And then you can just make it like this. Now we are going to drill for the tibial tunnel. Tibial tunnel is the different landmark for the tibia. So what landmark? This is a footprint zig. This is called as footprint zig. So zoom in karna. You have different kind of zigs for the tibia. That's a footprint zig. You only have to keep this on the footprint. Over shape. You can have tip hammer. Tip hammer. So you have a zig which can be like this. The wire is exiting at the tip, or the wire is exiting like. So it can be like this also. You fit it into this. Sometimes few companies have where the guide wire is going to exit there, or it will exit there, or it exits in the center of this. This is called as footprint zig. That is elbow hammer zig or tip hammer zig. All these zigs are for tibia. Footprint zig or elbow hammer zig or tip hammer zig. So here they have given us footprint hammer zig. So what do you do is, this footprint zig has an advantage. You put it on the footprint of the ACL, whatever is there. Suppose with the ACL, you put it on the footprint of ACL. Now wire is going to exit at the center. The wire is going to. So you put this zig on the center of footprint, and the wire is going to exit the center. Immediately you get the center of the footprint on the tibial side. Correct? So that's the advantage of footprint zig. So you put footprint zig like this. So you put it like this. And once this is done, yes. So that's they have this. You press it like this, and this opens, becomes loose. You leave it, it becomes tight. Correct? So goes in and out, but coming out is not possible. It gets locked. There are serrations there. You see, there are serrations there. So once they have gone in, but you want to take it out, it gets locked. You have to press it to take it out. You leave it, it can go in, but doesn't come out. Correct? So what we are going to do is put it on top of this. First, you fix in your tibial footprint, and then you fix it to the bone. Now you have different angles for this. Sorry. This is 40, 45, 50, 55. The more the angle, the larger the tunnel. Usually we keep it on 55. Fix on 55 and then you lock it. So you can, yes, like this. So you have different markings on top of this. Either this is 40, 45, 50, 55. Put it on 50. You can make it go to 50. You can whatever you want. So here we take it on 55. Okay. So which this is the line. So this is the angle that you're getting between this and this. So you reduce it, the angle reduces. This angle reduces. You make it so you want a larger tunnel. Suppose what is the use of it? Suppose your graft length is small and you want your graft to exit the tibia and you are planning interference fixation and you want to shorten the tunnel. So if your angle is 55 and tunnel is large, your graft is going to stay inside the tunnel. So if you want a shorter tunnel, because you have a shorter graft, then you can play a little bit with this thing. You cannot make it 40, of course. So you can go to 55. If you want a larger tunnel, what happens? Suppose you have to do a root repair here. Now root repair tunnel is exiting exactly there. So you want to make this ACL tunnel go further down. Then you make it 60, 65. So what do? You put the zig there. And then yes, correct. So suppose we have 2-3 tunnels. Here we are thinking. Here we are dealing only with ACL. Suppose you have ACL, PCL, root tear. So when you have multiple tunnels, you want to cheat the tunnel. Correct? No, it is not important. Important is where it is coming. Important is where it is exiting inside. You cannot be on the top of tubular tuberosity. Just medial, 1 centimeter medial tubular tuberosity, go in. Correct. Tuberosity, correct. If the zig is not good, it will not exit in the center. So it has come to the footprint. So that's the advantage of footprint zig. So footprint medial lateral you don't have to understand here. You just put it on the footprint and it comes out. Then you remove it like this. Then again you will drill. कितना था? तूने यहाँ पे कितना किया था? फीमर कितने से किया था? 7. इसको भी 7 कर दे. हाँ. That is no. Which one? This one? No. You understand this. A lot of youngsters are confused in what is the angle of this, that. No. It is only material where the tip is exiting here. You cannot be on top of tubular tuberosity. If you are too medial, you have to play with this when you are doing a multi-ligament scenario. This can be there, this can be up, this can be down. This cannot change. So why these multiple angles has been given? These multiple angles has been given because sometimes you have to make it 60, sometimes you have to make it 50. Otherwise, they would have given a fixed angle. Fixed angle तो है नहीं. क्यों उसके multiple angle है? Because अलग-अलग scenario में आपको angle change करने पड़ते हैं. So what is paramount is this has to exit here. Of course, this cannot go there. This cannot go on top of tubular tuberosity. Somewhere in the middle, best is to be 1 centimeter away from where you have given incision for the graft harvest. You have to make it there only. So once then you put a support like this and then you start drilling. Again he will drill. But you can put a curate on top of it. You can put a curate on top of it. And then you have made the tunnel. The same graft size which was there, it was 6, he is making 7. Suppose this is the 7 graft. So same graft size, you make the tunnel there. Yes, so you have 3 landmarks which help. So posterior border of anterior lateral meniscus. You don't have a lateral meniscus there. So where the posterior border of anterior comes, this should exit exactly in line with this. Correct? Towards the medial tibial spine, not the lateral tibial spine. Suppose you draw a line, this is suppose lateral meniscus. Suppose I am drawing, suppose this is the lateral meniscus, that's the horn of lateral meniscus. Like this and like this. So you follow this border and it goes straight and there is a medial tibial spine, there's a lateral tibial spine. Towards the medial tibial spine you have to stay. You cannot stay on the lateral tibial spine. So lateral tibial spine से तुम्हें medial तरफ रहना है, because you don't want a lateral intercondylar impingement to happen. Impingement happens on the lateral side. So you want to stay on the medial tibial spine side. Okay. So once this is done, you will take out this wire through a retriever there, put a retriever like this, and hold this wire like this, and pull it through the. Now this is our leading suture from where our zooming करना भैया जरा zooming. From where our graft is going to go. Don't make it like this. That's how our graft is traveling inside. So once this is done, you have secured your rail load, then graft ले लिया. ये है. धागा ले आओ. Loop में से you have prepared that graft construct, arc loop construct. So what I'm going to do is, now this foretail will go. What you can do is, initial two cases you should mark it. Mark what? So this is your button size. At the end of the button, you have to mark what is your tunnel length, because then you know, because you are doing scopy, you know when this mark will reach there, that means button has come out. So you mark, suppose our tunnel length was 40. 40 tunnel length, just mark 40 there on the graph. Now you know this, when this mark will come at the mouth of tibial tunnel, femoral tunnel, sorry, that button is out, because the total tunnel length is 40, correct? Because हमारी पूरी tunnel की length 40 थी, तो ये 40 है. That means ये यहाँ पे मार्क पहुँचेगा, हमें आर्थ्रोस्कोपी से दिख रहा है अंदर की तरफ, बटन बाहर आ चुका है यहाँ से. क्या कर रहा है? निकल गया इसका. So it is 7 millimeter anterior to bestial, which you can never measure. So you have two landmarks. These are practical landmarks. Third is of course tibial stump. One landmark is follow the posterior border of anterior horn of lateral meniscus. Follow and reach the medial tibial spine. Where the medial tibial spine starts going down, that's the point where you have to exit. Not on the lateral side. So medial tibial spine down, then lateral tibial spine down. In this valley, you have to stay medial, not lateral. That's the point. Okay. ऐसा फ्लिप करने के लिए ये होता दो ही है. अब ये तो गिर गया है, नकली है ना भाई. तो you make it go like this. Now understand this. What is going to happen? So एक मिनट हटा दे, संजीव पकड़े. So what do we do is, suppose इसको पकड़े संजीव, दोनों पकड़ ले बेटा. So see what is happening there when I am doing some maneuver there. Look at the button. What is happening? That is seesaw motion. Correct? So one is leading suture, which will pull the button all the way here, and then with this I will make the button flat. So for example, what is going to happen is, I pull, make the button go in the femoral tunnel. Again I take the slack out. Okay. Now again when I pull, so this button has to come out and come, it comes out. Now make it horizontal. Correct? Yes. So so this has pull out like this. Once I make this, and you pull it down, now our ACL has, so this is sit up. Now this calculation, whole calculation 15, 35, 25 is because of this only. So once now your button is fixing there and ACL is sitting there. Now you have to put in a screw. So like the screw है खुला हुआ, metal screw है या metal screw? Metal वाला है. ये तो वो screw है. कितने size का देगा? Okay, 935. So you put in like this. This is the guide wire. This goes in, and then you डाल दे वहाँ से. अनुराग इधर आ. अनुराग, डॉक्टर अनुराग से डलवा. छोड़ दे. 15 degrees. 15 डिग्री. हम बता दे रहा हूँ. अनुराग आ जाए डाल. उसको दे देना. This is a ratchet screw. So this is a ratchet screwdriver. You don't have to screw, just get like It goes on. Ratchet है यार, समझा? ये संजीवन बता देना ना. खींच रखना. Just pull it down. Keep it pulled. Go in. This is a ratchet screwdriver. So you just have to, don't have to leave the handle. Just keep it doing like this. चला अंदर. कोई नहीं जा रहा है ये संजीवन. अटक गया तेरा बीच में आगे देख. Why this is happening? Because this guide wire is टेढ़ा मेढ़ा. नहीं इसको ऐसे करना है. नहीं वो लॉक कर दिया. Yeah, goes like this. जा. Push. खींच के रखना. So this is a different Anurag. That's वो खींच के रखता है लड़का वो. So that's the screw which is coming, which is a slanted screw to match the tibial slope. Earlier we had rounded this thing. So that is why there is a confidence there. Now in this you tighten Anurag, tighten. Yes, go in. Keep going in. So it will match the slope of the tibia. So you don't have to put the screw all the way inside. और थोड़ा एक बार और करना. एक बार. Now this will match the best. So it is matching the slope of the tibia. Correct? That is how. नहीं ना. इसका 15 डिग्री. Sorry. ये स्क्रू निकालेंगे बाहर. हो गया. संजीवन इसको निकालें कैसे? ये बीच में कर दें. बीच में सर इसका स्लांट ऐसा है. नहीं वो मैं बाहर निकाल रहा हूँ. ये देखिए ना कटा हुआ इसको स्लांट है. जब इसको अंदर डालना है तो ये जब अंदर जाएंगे तो पहले ये प्रोमिनेंस रह जाती थी. बट नाउ इट मैचेस स्लोप ऑफ द टिबिया. ये स्लोप अप ये स्लीप मैच कर जाता है. सो इट बिकम्स फ्लश विद द टिबिया. करेक्ट. ये नाउ द ACL is हाँ जी सर. नहीं यहाँ तक आने की जरूरत नहीं है. इट हैज टू स्टे 5 मिलीमीटर डाउन. Sir, when you make the angle tight, so when you're putting the screw in, you have to push the tibia back. Correct? So when you extend the knee and the capsule is tight, you cannot maneuver tibia. So we understand this. Once the knee is locked in extension, capsule locks the knee, which happens with MCL also. MCL जब हम चेक करते हैं, LCL करते हैं, why we flex the knee 30 degrees? Because the moment you extend the knee, it becomes tight already because capsule holds the knee. So you have to make it 30 degree flexed. If you make it absolutely straight, it will lock the knee. Then if you want to push the tibia back, it will not go back. Then you will not be able to apply pressure. If you make it 90, how do you apply pressure? You have to apply pressure 90%. So 30 is what is universally being agreed. So you have to push the tibia back. Why? Because tibia is little anterior. Because of anterior coming every time, the tibia is little pushing back. हो गया? नहीं जो टॉल ACL थी उसको पहले निकाल. नहीं उसको सर बचाते हैं. अभी तो स्टम्प प्रिजर्वेशन ACL हो गया. स्टम्प प्रिजर्वेशन में whatever ACL we can preserve 30 डिग्री सर. अब ये तो कर नहीं सकते. ये ऐसे इस पोजीशन में करते हैं 30.
ये एडिशनल
हाँ जी. No, what do we do is that's a very अरे लेगा क्या वो लेके आओ यार. So what do we do? There is a technique for this. Very good technique by Ashish sir. कहाँ चलेगा क्या? नहीं इसमें बड़ा ये वेरी गुड टेक्निक. एक ड्रिल देना जरा. ड्रिल कहाँ गई? अरे वो आपकी टेक्निक. So what do you do is this is there. Make a drill from there to there. Pass in this thread from inside and make a knot. You got it? Make this tunnel. Make 2 threads go through the. इसमें tunnel drill कर दे बेटा बस. यहाँ से drill करो. अब वो it's a very good technique. So ये thread यहाँ से निकाल लो. Thread यहाँ से निकल के ऊपर से आ जाएगा and make a knife. आशीष सर टेक्निक. So make this go.
पोजीशन क्या होती है टनल की? ट्यूबरोसिटी से थोड़ा नीचे या
नहीं, इससे कोई मतलब नहीं है. So you understand this? It comes like this. Suppose करो दोनों धागे and then you just tie this another. Let both the come. हाँ बीच में चला जाएगा, ऐसे ही चला जाएगा.
एक आया सर.
कुछ है इसमें से बजाएगा
मतलब एक में उठा के
प्लांट
कुछ है नहीं अरे अंडरस्टैंडेबल है. इसको यहाँ से लाओ, ये छोटा है ग्राफ, सपोज करो छोटा है, टाई नॉट. So when you tie, this becomes tight there.
मैं नॉर्मली जो है जब बनाता हूँ तो हम 8 स्टैंड बनाते हैं. मार्कग्राफ इतना नहीं निकलता. मार्कग्राफ अक्सर अंदर यहाँ तक. If your graft is long, then you just cannot do it. Then you have to put a staple or something like that for fixing. वरना जब ग्राफ्ट अंदर रह जाता है हमारा तो मैं उसको पुल करके धागों में बांध देता हूँ. This secondary stabilize. If your screw is loose, something happens. हमारे साथ 1-2 इंस्टेंस आए कि जब स्क्रू अपने आप बाहर आ गया, इन्फेक्ट हो गया, लेकिन सेकेंडरी फिक्सेशन से ग्राफ्ट रुका. इट वर्क. यू हैव टू बी वेरी कॉशियस नॉट बनाते समय कि ऐसा तान के नहीं कर दो कि वो तुम्हारा डेड स्पेस क्रिएट करे. तो नॉट यू हैव टू एडजस्ट शुड कम समवेयर हेयर ओनली. तो ना तो उसको नील करने में नॉट बढ़े और ना तो उसको जो है वो तुम्हारा डेड स्पेस एलिवेट करके सॉफ्ट टिश्यू को ना करे. अगर नॉट आती भी है देन आई टेक जो डीप बाइट लेकर के थोड़ा सा सॉफ्ट टिश्यू के ऊपर. लड़कियों में दिक्कत है नील करना उनकी आदत है. अगर बड़ी नॉट बना दी तो करता है.
सीजर है क्या? सीजर सीजर just to demonstrate. सीजर देना काट वो सर बस डेमोंस्ट्रेट करने के लिए. just to demonstrate.
डुअल फिक्सेशन. अगर स्क्रू लूज हो जाए, स्लिप कर जाए,
so
then there is some
make it like this.
which is holding it कुछ दिनों के लिए कि जब तक जुड़ ना जाए. वह पर्चर पे जुड़ना है उसको तो
एक स्टैंड इधर आ गया ना. so इतना नीचे नहीं भाई, ऑब्वियस सी बात है. but look at this. that's the method. this should be somewhere there, not here. so one fixation is there, the other fixation is not at the leg. it should be somewhere there.
फ्री की है वो. बट सेकंड फिक्सेशन ही धागे ही से होता है.
धागे से बस बांध दिया आपने, इसमें नॉट मार दिया इसने. हाँ जी सर, यहाँ पे रहेगा, इस जगह पे, ऑन दैट साइड.
ये यहाँ रहे.
हाँ जी हाँ जी. है ना, वो तो यहाँ ऐसे. नहीं यहाँ नहीं करना सर, कोई करना है तो लंबा था. इतना बड़ा लंबा ग्राफ भी समझ तो फिक्सेड है.
हमने कहा ये जो ऑर्गेनाइज किया ये मतलब
ये तो बड़ा नहीं मिलता.
एक्चुअली कोन के ऊपर रहेगा.
Usually the length of graph is about 200. You quadruple get 90, 100. That's it. This is about 300. So graph यहीं तक मिलेगा. फिर उसके बाद आपको धागे शुरू होंगे. धागे यहाँ पे आएंगे. So उसको यहीं पे
किस प्लेन में रहेगा ये मैं जानना चाहता हूँ. जैसे जस्ट पेरियोस्टम के ऊपर रहेगा या कि मसल लेवल में. वो सर एडजस्टेबल लूप.
That milking is for adjustable loop, not for fixed loop. जब adjustable loop होता है तो उसमें you don't measure all this. In that adjustable loop, the advantage is that you don't have to measure the length 35, 15, 40, 55. You don't have to measure. हाँ?
तो ये कि 30 का ग्राफ लेते, 20 का लूप लेते और 30 निकल लेते. सर आप
करेक्ट. सो समझो मेरी बात. 15 का लूप लिया, 40 की सुना भैया, 40 की टनल है, 15 का लूप हो गया. समझना इस बात. पेपर पेन है क्या? सो सपोज दिस इज 40 इज माई टनल साइज. करेक्ट. 40 15 का लूप है, 25 ग्राफ है. करेक्ट. 25 ग्राफ को फ्लिप करने के लिए मुझे कितना चाहिए? +10 चाहिए. तो मान लो 25 की ग्राफ्ट 15 तो प्लस 10 कितना हो गया 35। हाँ तो 30 तक ड्रिल करोगे, करेक्ट कर सकते हो। सो यू कैन टेक 20 ग्राफ because why because I want this loop to be shortest, I don't want this loop to be longer। 35 की हो तब भी 15 लो, 40 हो तब भी 15 लो, 45 हो तुम्हारी टनल ही गलत है। तो अगर तुम्हारी because you want, because see this tunnel is 40, suppose this tunnel is 8, graph is how much, it is filling the tunnel, what is not filling the tunnel is the loop, this is the button। तो ये लूप जितना प्लेस है वो लूप देगा, अगर ये लूप इतना बड़ा होगा, डेड स्पेस नहीं, हाँ डेड स्पेस फॉर दिस लूप टू मूव हियर एंड देयर। सपोज टनल इज लाइक दिस एंड दिस इज द लूप एंड दिस इज द ग्राफ, now there is a play like this and this will keep on interacting, that is called as tunnel dilatation and which will cause disintegration of graph।
वो भी गलत नहीं था, जैसे 20 का ग्राफ 20 का लूप कर देते।
हाँ जी 30 डिग्री पे सर, ये अब सीधा ऐसे क्या करते हैं,
वो सिंपल कैलकुलेशन सर, ये इसको हटा दें यहाँ से।
हाँ हटा दो। हाँ जी एवलियन टेप इधर बस 2 टेप लाए, टेप लेते आ, टेप ले ना, हाँ फाइबर वायर ले आ। हाँ जी सर काट दो यहाँ से। सो सिंगल फिक्सेशन, सो आई मैंने सवाल पूछा ना, तो डुअल फिक्सेशन चारों लोगों में से सिर्फ आशीष से करते, बाकी तो कोई नहीं करा, सबने यहाँ से इसको जस्ट ड्रॉप इट ऑफ। दे से द फिक्सेशन अपर्चर फिक्सेशन इज बेस्ट, दिस अपर्चर फिक्सेशन, दिस कॉर्टिकल फिक्सेशन, दिस इनडायरेक्ट फिक्सेशन। जो जापानीज पॉपुलेशन है वो ये रिकमेंड करती है कि टीबिया साइड में अर्ली फेलियर जब एसीएल का होता है, दैट इज फ्रॉम द टीबियल साइड, सो दे रिकमेंड डुअल फिक्सेशन ऑन द टीबियल साइड। Western population doesn't believe in this, they say only one fixation is good enough, but Japanese, Korean, they always fix 2 tibia, यहाँ लगा देंगे, पोस्ट बांध देंगे। So what we do is, एक और देना
38 के लिए आता
तो तुम 23 ले, 33 33
वो तो सर वो ड्रिल करते ना 33।
हाँ तो 15 मतलब ही नहीं यार, क्यों 20 में भाई वांट टू चिकन आउट यार, डरते हो ना 5 ml बचाने से। नो 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 नेवर डू दैट।
ठीक है, ये जैसे आपका कौन सा ज़्यादा
वो है तेरे पास क्या, यू वांट टू सी दिस, दिस इज अ वेरी गुड।
सर पहले
मैंने इसका हो गया यार, वो जो मैंने वो उसमें, तो व्हाट वी डू इज, वो है क्या तेरे पास, अरे फर्स्ट पास है। सो व्हाट यू डू इज, इसको काट देना, एक और है धागा, ये एक और धागा है क्या। So what I do is I take that bite and take this thread from back of the ACL like this. कुछ retriever है? No back. So ACL के पीछे से ले आया मैं ये। Suppose this is an avulse term. Now you have a ACL and there is a bone there. So once you put, this will be on the bone. ACL
स्टार्टिंग के लिए ये हमारा सर
कौन है यहाँ पे,
ये यहाँ से बचना, तो इसका ये
तुम ACL के पीछे से ले आए। अब तुम्हें यहाँ पे पहले तरीके क्या था, नॉट मारने के तरीके थे ना। नॉट मारने में यू हैव टू नो ऑल काइंड ऑफ नॉट दैट यू डोंट नो प्रॉब्ली, सो यू हैव टू हैव दैट स्लाइडिंग नॉट। सो कई लोगों को स्लाइडिंग नॉट मारना आसान नहीं है, फिर देयर इज लॉट ऑफ सॉफ्ट टिश्यू इन्वॉल्वमेंट। सो व्हाट डू यू डू, टेक अ फाइबर टेप व्हिच इज अ ब्रॉड थिंग, दिस फाइबर वायर, टेक अ फाइबर, थोड़ा होता है वो, देन यू सिट इट लाइक दिस, यहाँ पे टनल बना लो, करेक्ट। अब वो सामान चला गया, तो टनल बना करके उसको यहाँ से निकाल ले आओ, यहाँ से आ गया ये। ऐसे ही दूसरा एक फाइबर, अरे है थ्रेड तेरे पास है, और एक थ्रेड है उधर से इधर लेके चले आओगे। सो दिस विल बिकम अ क्रिस क्रॉस लाइक दिस, सो इट प्रिवेंट्स दैट फ्रैगमेंट फ्रॉम गोइंग अप। just anterolateral anteromedial to the, वो नहीं देगा भाई, अच्छा यहाँ से निकाल लेते हैं, चलो निकल आया। so make this go like this, कुछ रिट्रीव करने को दो यार, don't make it निकाल दे यार। Again. So make a tunnel there, and that's the configuration that you should get. ये भी टनल में से निकाला?
इसी टनल में
नो नो नो, 2 टनल। अच्छा, एक टनल ऐसे, एक टनल ऐसे। तो यहाँ पे निकाल करके
साइड पे ना।
हाँ जी, ये आपने ऐसे निकाला। दिस इज द कॉन्फ़िगरेशन, करेक्ट?
ये हमारा ये है वर्जन, ये वाला वर्जन, ये वाला है।
हाँ
ठीक है, तो ये हमने वर्जन के
इधर से निकाला, जहाँ पे जितना बड़ा एवल्जन है। मान लो एवल्जन का मीडियल कॉर्नर ये, लैटरल कॉर्नर, सपोज गिव मी अ मास्टर। मान लो कि तुम्हारा एवल्जन इतना बड़ा है, ये उसका मीडियल मार्जिन है, ये उसका लैटरल मार्जिन है। सो दिस विल गो लाइक दिस एंड दिस विल गो लाइक दिस।
मार्जिन से लेना है,
मार्जिन से? नो नो नो, यू हैव टू बी एंटेरो लैटरल एंट्रो मीडियल। यू कैन नॉट बी देयर, यू कैन, बिकॉज इफ यू लुक लाइक दिस व्हेन यू टाई इट, ये बम्प सामने से उठता है। सो आगे से दबा के रखना उसको लाइक दिस। सो व्हाट हैपेंस, दिस compresses this corner, this compresses this, and this crisscross will not allow the bone to go up like this. That's the वो उसमें क्या करते हैं कि हाँ उसमें
बांधना किस तरीके से,
वो बोन के ऊपर टनल बना के बांधो। सिंच नॉट में क्या करते हैं कि इसके क्रेटर में लगा लो और क्रेटर से पास यहाँ से खींचोगे तो दिस विल मेक इट सेट लाइक दिस। नो नो, उसके बाद भी तुम्हें 2 टनल बनानी है। दैट्स फॉर रिडक्शन। In the first technique, I use a K wire for reduction. If you don't want to use a K wire for reduction, because this is important when there is convolution, then if you put a K wire, it might burst. So you want to do little bit. You don't want to handle the fracture fragment. तुम इसे छूना नहीं चाहते, तो तुम नीचे से ड्रिल बना के आगे से धागा लेके नीचे से खींचोगे तो वो बैठा देगा उसको ले जाके। But that is only when on CT scan you have seen that there is convolution and you are afraid यार इसको हाथ लगाऊंगा तो थोड़ा हिल जाएगा ऐसे। ठीक है, हाँ। सो दिस इज देयर जोन स्पेसिफिक कैनुला सिस्टम, द वंडरफुल सिस्टम दैट दे हैव गॉट। सो दिस, इसमें लिखा हुआ है, सो आई थिंक ऑल मीडियल मेनिस्कस कैन बी मैनेज्ड बाय दिस सिस्टम। You don't have to do all inside for medial meniscus. They have this zone specific, posterior zone, middle zone and anterior zone. It is written on top of this. Left anterior, right posterior. Suppose you want to do, so this is the, suppose this is medial, this is lateral. So what do you, this is right posterior. So you use this is meant for that. Put it there, and then if you push in a needle, the needle. So this is Dr. Tapsavi had in this lecture zone specific. This is the zone specific cannular system. So you push in like this, it will avoid the central structures. So he said na zone specific से मेरा area बढ़ गया. So you pass on thread like this. So you don't need to have that costly thing of हाँ जी, नहीं अंटिया से पोस्टियर जा रहा हूँ, ये एंटीरियर है, आगे है पीछे है। मैं डिमॉन्स्ट्रेट कर रहा हूँ ऐसे। सो पूरा नहीं खींचो, देन यू पुट दिस आइदर अप डाउन, जहाँ पे लगाना है इसको तो मैंने यहाँ फिक्स कर लिया। सपोज यू वांट टू मेक दिस गो लाइक दिस, अगेन पुट इन द थ्रेड। So you don't need that. So for medial meniscus, I have stopped using all inside devices, very costly devices, 16,000-20,000. So make it go like this, and when you tighten, this hold the meniscus. Correct? हाँ, फिर इसको पीछे इंसिजन दिया, उसको अंदर आपको, then again you can hold it like this, hold. So then you can give a sliding knot like this, or you can just a half hitch, single half hitch. Just knot pusher लाया है क्या? Inside out. So you take this like, you have knot pushers, this shoulder system. All kind of tear you can manage medial meniscus, not lateral meniscus. जाएगा नहीं किसमें? Okay. So this is knot pusher. So you push the knot, go in, keep tightening it like this, going in, keep tightening like this, and it goes in. So it will. पकड़ इसको संजीवन इसको फिर push and knot like this. Okay. Then again you can give a half hitches like this. यहाँ से उठाना है इसको. Don't leave, no? Don't leave. So again, you can take this like this, and again push it, and lock it. Keep pulling. Pull. Sarag raha na? Then hold. Keep holding. Don't leave. Again, back it out. Push it in. Again, back it out. Again, push it in. Again, back it out. Then again, just as a spout. You push the knot in, no? That is how you tie the knot. Then you have your cutter. Cutter last में आएगा, वो अलग से लगाना पड़ेगा. वो तो all inside का सर है अभी. ये inside out का अलग cutter आता है. तो क्या?